A very good morning. I welcome you all of you on behalf of organizing team of Fertivision 2020 in today's poster session. It is my pleasure to have you all on this global virtual platform. Now, I would like to invite the esteemed judges for today, Dr. Rita Mahe. She is the additional professor at AIMS in New Delhi. Welcome, ma'am. Dr. Aruna Nigam, ma'am is professor at Hamdard Institute of Medical Sciences, New Delhi. Welcome, ma'am. Now I hand over this session to Dr. Shikha Jain. Dr. Shikha Jain, please.
Good morning, all of you. Good morning, judges and presenters. Dear presenters, kindly stick to the timing. You have 3 minutes for presentations and 2 to 3 minutes for question answer. So
Sorry, only 2 minutes for presentation. Only 2 minutes.
only 2 minutes for
Yes.
presentation and question answer for 2 to 3 minutes.
Only 3 minutes. Yes, total
Okay.
5 minutes.
So I would like to our first presenter, Dr. Aditi Rai. Her topic is reproductive outcome in patients with refractory thin endometrium after autologous stem cell therapy, a case series. So please, Dr. Aditi Rai, hand to you.
Dr. Aditi.
Dr. Aditi, you need to unmute yourself. Yes, please continue, madam.
Yeah. Good afternoon, everyone. Myself, Dr. Aditi Rai from LTS Hospital, Bangalore. So I'm here today to present our exciting result of autologous stem cell administration for refractive thin endometrial treatment. So to begin with, stem cells are precursor undifferentiated cells and potential to self-renew and generate multiple mature cell type. The stem cells existing in endometrium might originate from bone marrow, and the bone marrow stem cells may play an important role in endometrium tissue remodeling, cell signaling, immunomodulation, and stimulation of dormant endogenous cells with regeneration potential. Using this principle, we have planned this pilot study to evaluate the role of stem cells therapy in endometrium regeneration. We have identified 3 patients who consented to us to undergo autologous stem cells therapy. So the bone marrow aspiration was done under local anesthesia from the iliac crest, and the total 50 ml of bone marrow were aspirated and sent for processing. So after processing on the same day, we have done under hysteroscopic guided bone marrow stem cell implanted beneath the endometrium in the subendometrial zone in all 4 layers of uterine wall, and patient was observed for 4 hours, and after 4 hours, patient were discharged with following medication. The result of our studies, all 3 patients were conceived after autologous stem cell injection, but one patient who had Asherman syndrome had spontaneous abortion around 8 weeks of gestation, and other 2 patients were continuous their pregnancy and doing well and continuing at 8 months of pregnancy. So the conclusion of my study is stem cell is a new ray of hope in female who fail to attain optimal endometrial thickness despite using all medical treatment, and seems to me promising new treatment for regeneration of endometrium. Thank you so much.
Very nice work done by you, Dr. Aditi. I just want to ask 2 questions. Number one, why did you prefer the stem cell over the platelet-rich plasma, which is now also a very promising therapy and is non-invasive type, like you need to aspirate it from the iliac crest, it just can be done from the blood? Number one question. And number two, what could be the side effects of your therapy?
Yes, ma'am. So, ma'am, I would like to answer the first question. The bone marrow stem cells is the most commonly used treatment, and the safety and efficacy is well documented, ma'am. And the bone marrow is existing in the endometrium and might originate from the stem cell existing in endometrium that might originate from the bone marrow, and the bone marrow stem cells play an important role in tissue signaling, immunomodulation, and stimulate the dormant endometrium to the regeneration potential. And the second point is The bone marrow stem cells upregulate the anti-inflammatory cytokines and downregulate the pro-inflammatory cytokines. So it will help to regenerate the endometrial potential, ma'am. And the second question I want to answer, ma'am, the side effect is mostly the cost patient point of view. The cost will be 60 to 80,000 as per Indian scenario, and it will be costly for the person who is going for this treatment, and other anesthesia related complication and very rarely side effects like infection and bleeding chances will be there, but that can be minimized if we are doing very meticulously, ma'am.
Okay, very nice. How did you inject it? Which instrument you used to inject it subendometrially?
Ma'am, the Botox injection needle we have taken, and the operative hysteroscope 2.9 mm 30-degree hysteroscope we have taken. Under the hysteroscopic guidance, with the Botox injection needle we have put into the catheter, and the subendometrial zone under hysteroscopic guided we injected 1 to 1.5 ml in each wall of the uterus, and around 1 to 1.5 ml in all layer of uterine wall on all four layer, ma'am.
Okay, very nice.
Dr. Aditi,
Yes,
so
ma'am.
how did you choose the patient? Like, were this patient where you have already tried other management options for thin endometrium? Like one patient you had Asherman, and what about the tuberculosis? Was it ruled out or not? Like, how did you select these three patients?
Thank you, ma'am. The first case, the patient who had Asherman, the history was she had 5 years of infertility and she had unwanted pregnancy. So she underwent 3 times medical abortion and DNC underwent. She complains of post-abortal endometritis. So the outside only they have given the treatment, and the patient had complaints of hypomenorrhea. So we have done hysteroscopy and we find out it's a Asherman syndrome, and we try to release the adhesiolysis. Then followed by we have given the HRT for few cycles, ma'am, and relook
Time
hysteroscopic
over.
we have.
Okay, thank you.
Thank you,
Thank you. Thank you, Dr. Aditi. Now I would like to invite Dr. Vibha Mishra. Her topic is comparison of hysterosalpingography with hysteroscopy, a retrospective study. Dr. Vibha Mishra.
Good morning, ma'am and presenters. I am here to present my study on to determine accuracy of HSG in evaluation of infertility by correlating its finding with diagnostic hysterolaparoscopy. It was done at AIM Jodhpur from the study period November 2018 to the February 2020. Data is obtained from previous hospital records and online portal in the hospital. Total 40 patients were included. Only those patients who had suspicious who had a suspicious tubal and uterine pathology in HSG underwent diagnostic hysterolaparoscopy. Patients with male factor infertility and surgical sterilization were excluded. Findings were computed and analyzed and correlated. Mean age of patient was 28.12 years and mean duration of infertility was 4 years. Uterine anomalies diagnosed in 4 patients with HSG, and DHL confirmed one of these anomaly septate uterus, and in addition diagnosed 1 unicornate uterus and 2 more uterine polyp and polypoidal endometrium. HSG has 92.5% diagnosed in tubal blockage patients. 15 patients has unilateral and 22 patients had bilateral tubal blockage. DHL confirmed tubal blockage in 35% and is equal to 14. Among these, 11 were unilateral and 3 are bilateral. Positive predictive value for diagnosing tubal blockage is in HSG 37.7%. For unilateral blockage, it is 73.3%. For bilateral blockage, it is 13.6%. So HSG is more accurate in diagnosing unilateral blockage. Most probably, the bilateral tubal blockage in HSG is because of the corneal spasm. DHL help in diagnosing tubal adhesions, hydrosalpinx, endometriosis. Interventions was done wherever indicated, including tubal cannulation.
Time over.
Yes.
So, what is your message, Dr. Vibha? What is the conclusion of your study?
HSG is a most cost-effective analysis. It is a complementary to DHL, and it should be offered to all the infertile patient as a primary evaluation. Because if the we diagnose as a bilateral tubes are patent and uterine cavity is normal, we can give a trial of ovulation induction to the infertile patient, and it is a cost-effective tool in comparison to diagnostic hysterosalpingography. And if we are under patient is under diagnostic hysterosalpingography, then it is both therapeutic and diagnostic for it.
Dr. Vibha,
Yes, ma'am.
you talked about accuracy. How you assess the accuracy? You have not calculated the sensitivity and the specificity of HSG, although you have written in the round that HSG has a high sensitivity and specificity, but it has not been calculated in your study. What about that?
And because we are here not taking whole of the patients in that underwent hysterosalpingography, we have taken only the patients those who had underwent the diagnostic hysterosalpingography if we are finding any abnormality in the HSG.
Yeah, that's right. That's right. But of course, you can always calculate if you are presenting some study, the sensitivity and the specificity for the test are the most important criteria to be taken into account to conclude anything. And second thing, what is the criteria to differentiate between the septate and a bicoordinate uterus in HSG? Because in one of the cases, you cannot differentiate between the septate uterus, number one thing, and you could not identify the unicoordinate uterus also. So what is the criteria for HSG in diagnosing or differentiating between the septate uterus, bicoordinate uterus, and unicoordinate uterus?
In the unicoordinate, in HSG, in unicoordinate uterus as a banana-shaped picture that we couldn't have identified in it, and for the septate and bicoordinate we couldn't identify it by the HSG. We have to go for the diagnostic hysterosalpingography for diagnosis.
What is the criteria? What is the criteria for HSG? How will you differentiate? You can identify these two entities. So what is the criteria for that?
And because that is an angle was there in the HSG. If it is fundus angle is more than.
And Dr. Vibha, we have better investigation before going for hysterosalpingography, I think non-invasive, which can help us to differentiate between septate and bicoordinate.
And 3D, we can go for the 3D sonography. It is a quite better investigation for diagnose. It can quite accurately diagnose the septate and the bicoordinate uterus before we go for the diagnostic hysterosalpingography.
Time over.
Thank you, ma'am.
Bharti, I request, please don't remove the poster till she is answering the questions.
Okay, ma'am. Sure. Sumit?
Thank you, Dr.
Yes, ma'am.
Vibha.
Please take care. Don't remove the poster.
Sorry?
Dr. Aruna has asked to keep the poster till they are asking the questions. You keep the...
Sure.
Okay.
Our third participant is Dr. Monica Dalal. Her topic is challenges of Takayasu arthritis in pregnancy. Dr. Monica.
Yeah, good afternoon, everyone. I will present a case report of Takayasu arthritis in pregnancy and what challenges it poses during pregnancy. Takayasu arthritis is a rare chronic vasculitis of unknown etiology and characterized by narrowing occlusion and aneurysm of systemic and pulmonary arteries. It mainly affects the aorta and its branches. So we present a case of 30-year-old female. She is gravida 5, para 3, live to A1 with 9 months of amenorrhea. So with 33 weeks of amenorrhea with previous 2 cesarean with chronic hypertension and superimposed preeclampsia with oligohydramnios. She was a known case of Takayasu arthritis since she was 16-year-old. At that time, she developed sudden hemiparesis, and later on digital subtraction angiography, it was found that patient had occlusion at the origin of both subclavian and carotid with reformation of collateral, thus corroborating with the diagnosis of Takayasu arthritis. Her first pregnancy was an IUD with severe preeclampsia. Her both cesarean was done at our institute only, and at this time she was regular follow-up in the OPD, and she developed hypertension, and she was on tablet labetalol 200 mg 6 hourly and nifedipine 10 mg 6 hourly. On echocardiography, there was dilated aortic root, moderate mitral regurgitation, and left ventricle ejection fraction was 55%. And later on, she developed severe preeclampsia superimposed over the chronic hypertension. And so we have to do cesarean at 35 weeks of pregnancy. And she delivered a female with baby weight of 2.1 kg, and patient remained hemodynamically stable and was transferred to ICU. Her her BP was taken from the lower limb. Her upper limb pulses were not palpable. So we managed the pregnancy well, but there was a risk of severe impending eclampsia. There's risk of eclampsia, CHF, and it may jeopardize both maternal and fetal outcome. So interdisciplinary collaboration of obstetrician, cardiologist, and neurologist is necessary to improve the maternal and fetal prognosis.
Very nicely managed case, Monica. I just want to ask one thing, two things from you. What is the role of aspirin, starting the aspirin in the first trimester, as you have not mentioned it here?
Yeah, ma'am, she was earlier on aspirin, but later on she was asymptomatic. That's why aspirin was not started.
No, earlier on aspirin, then why?
Earlier means that when Takayasu arthritis was diagnosed, at that time she was on steroid and aspirin.
Yeah.
Later on, when patient
aspirin has been stopped? Why aspirin has been stopped? Because it could have prevented your severe preeclampsia also.
Yeah, actually in last pregnancy, she did not develop preeclampsia, that's why.
But still this is one of the
yeah, we could have started aspirin.
Right. So what contraception will you advise to this patient, not previous to LSAs, if she would have delivered? Can you allow the vaginal delivery?
No, if there is a chances of developing CHF and pulmonary edema in these patients, especially. So we can allow normal delivery. There is no contraindication to normal delivery as such, but we have to see on the case basis.
Okay. Now, what contraception will you advise?
I will. In this case, we have done a tubal ligation.
If it would have been a vaginal delivery,
then we can advise her. Copper T can be advised in this patient. Postpartum IUCD can be inserted.
Besides anything else?
OCPs we don't give in these patients. We can give DMPA. So we can advise Centroman.
Dr. Rita, your turn.
No, I think it's okay. So, you have done tubal ligation in this patient?
Yes, ma'am.
Okay, actually, my main question was like why ecosprin was not given to this patient, because and then she had eclampsia also. Like we could
that has been
better obstetrical.
No, she didn't develop eclampsia. She was a case of severe preeclampsia.
Is that preeclampsia also? Like we could have.
Yeah. We could have given aspirin in this patient.
Okay, thank you.
Okay, thank you.
Our third participant is Dr. Pallavi TN. Her topic is predictive value of cerebrospinal ratio in detection of perinatal outcome in high-risk pregnancy.
Dr. Pallavi.
Hello, good morning, ma'am. Hello.
Good morning, Pallavi. You are available.
Hello, ma'am. Myself, Pallavi. Good morning, everybody. I'm gonna present predictive value of cerebroplacental ratio in detection of perinatal outcome in high-risk pregnancy. A pregnancy is considered as a high risk where there are potential complications that could affect the mother, baby, or both. So Doppler ultrasound velocimetry of uteroplacental, umbilical, and the fetal vessels has become an established method of antenatal monitoring. allowing the non-invasive assessment of fetal circulation. And the present study is a hospital-based prospective study conducted on 150 high-risk pregnant women at Government Medical College, Amritsar. After taking written and the informed consent, the patient who is satisfying the inclusion criteria were included in the study, and they were undergone serial color Doppler ultrasound. The individual Doppler indices were documented, and finally the cerebroplacental ratio, which the systolic diastolic ratio of middle cerebral artery to the systolic diastolic ratio of umbilical artery was calculated, and the finally sensitivity, specificity, predictive value, positive and the negative predictive value were tabulated, and the outcome, perinatal outcome was calculated in terms of low birth weight, meconium aspiration syndrome, in need for NICU admission, how many stillbirths was there, and the neonatal deaths, number of neonatal deaths in the study group. And coming to a discussion, the Doppler velocimetry plays a major role in a fetal surveillance in high-risk pregnancy. Cerebral placental ratio gives information of both placental status when we do umbilical artery Doppler, and the fetal response to that changes in umbilical artery using the middle cerebral artery was seen. And the CP ratio, the abnormal CP ratio strongly correlates with the worse fetal prognosis. After calculating cerebroplacental ratio and then seeing the outcome, we could make out that cerebroplacental ratio had a highest sensitivity and a negative predictive value in detection of hypoxic ischemic encephalopathy, meconium aspiration syndrome, operative interference for and NICU admissions.
Dr. Pallavi? Dr. Pallavi?
Yes, ma'am, I'm listening.
Okay. So what all Doppler parameters you were doing while monitoring patients?
Ma'am, I have taken systolic diastolic ratio, middle cerebral artery, umbilical artery, and then from that I have calculated cerebroplacental ratio. Only 3 parameters I have taken in my study.
So, but usually we calculate with the PI values exactly.
Yeah.
We calculate the systolic diastolic ratios by definition also, like we calculate the ratio by PI.
Ma'am, there are many studies. Some studies have taken SD ratios, some studies have taken pulsatility index, and some have taken
by SD ratios.
Ideal is PI.
Hanji, ma'am, ideally, like most of the studies have taken PI.
Okay. Pallavi,
Hanji, ma'am.
It is a known fact that CPR, if bad, then outcome will be slightly grave, right? So what was new in your study?
Ma'am, actually my study is little more extensive. I have taken like throughout the study, I have taken PI, RI also. See, I've taken all the 3, and I wanted to see some of the studies have taken PI, RI, and ST. So I've compared all the 3.
Okay.
But only post I have taken ST.
You have written predictive value, but you have not written any sensitivity, any specificity, negative predictive value, positive predictive value in your these 2 tables. Where it is that?
Ma'am, from this I have calculated sensitivity and specificity. So there was no
where it is.
Ma'am, there was no space for me to put the sensitivity.
How much was the sensitivity? How much was the sensitivity, specificity, and the positive and negative predictive value?
Ma'am, for cerebroplacental ratio for a hypoxic ischemic encephalopathy, I got 99-98% like that. In for poor, of course, corona.
But there is no cord blood pH.
No, ma'am, I have not taken cord blood pH. I have not included cord blood pH in this.
What is the criteria of taking FGR? What is the criteria of diagnosing FGR?
Ma'am, in ultrasound, from gestation age, symphysis fundal height, and with the ultrasound parameters, with the gestation and the ultrasound parameters, I have got less than 3 weeks of difference, means I have taken as a IUGR.
Pallavi, that criteria is totally changed.
Yes, when we are taking these, you are taking patients for a study, you are doing cerebroplacental ratio, like how you have selected the patient. So are these normal patients? So how have you diagnosed FGR in these patients?
Ma'am, after 28 weeks of gestation, I have included.
Definition. What is the definition of FGR?
Ma'am, 3 weeks of discrepancy
No.
have been,
Okay.
I've taken the, and
Just that only.
Hanji ma'am.
So how did you decide for termination of these pregnancies? Like till how long you are following them with only CPR? So
Ma'am, I
based on
followed
CPR.
for 40 weeks till term I followed. Before that, if I got some gross abnormality in ultrasound parameters, like sometimes patient ultrasound shows absent or reversal of endosteric flow based on the patient gestation age, fetal weight, and everything. Looking at that, we have terminated.
Sorry to interrupt, but time over. Otherwise, we will not be
Okay,
able to
okay.
finish
We
on
are done.
time. Really
Okay.
sorry.
Thank you, Dr. Pallavi. Now our fifth presenter is Dr. Latika. Her topic is to study needle stick injury among various healthcare professionals in an area select of tertiary care center. Dr. Latika.
Good afternoon, everyone. Today I'm going to talk about our study, which was to study the needle stick injury among various health professionals working in an area select of tertiary care hospital. So the needle stick injuries, they're defined as the injuries which are caused by needles such as hypodermic needle, blood collection needles, IV stylets, and needles which are used to connect the parts of IV delivery systems. As per estimates of CDC, every year more than 3 million healthcare workers are exposed to the blood and body fluids via the sharp and mucocutaneous injuries in US alone, with an annual estimated 6 million needle stick injuries. And due to the needle stick injuries, the risk of infections are there, which range from as low as 0.2 to 0.5% for HIV to as high as 3 to 10% for HCV infections and 40% for hepatitis B virus infection. So the aim and objectives of our study were to assess the knowledge, attitude, and practice of needle stick injury among healthcare professionals who are working in the Department of Obstetrics and Gynecology, and to study the prevalence of NSIs, that is needle stick injury among healthcare professionals which are working in the Obs and Gyne department. So basically, it was a cross-sectional study. The doctors who were working in our department, that is consultant, all senior resident, junior residents, and the maternity students who are posted in labor room during their postings, and the nursing staff, they were included in the study. And the study tool was a self-administered questionnaire. It has two parts. The first part consisted of the questions which were related to the socio-demographic profile, and the second part had questions related to the knowledge, attitude, and practice regarding the needle stick injury. And the questionnaires were distributed among the participants who consented for the study, and the filled questionnaires were collected and the data was analyzed. So the results of our study were that majority of respondents, that is
Time over.
74.63%.
What is the sample size of the study, Dr. Latika?
Ma'am, 274 participants were there, ma'am.
Have you mentioned in the poster?
There was not only the concise form was supposed to be given. I missed that.
Okay. Dr. Latika, it would have been better if you would have given some table. It looks like that we are reading whole abstract, slightly extended abstract. With only 5 questions might be there in your pro forma. How many
And
questions?
ma'am, like only the major one on the key one I have given, because it was not the questionnaire. Basically, it had 10 questions related to the socio-demographic profile. Basically, the age, whether married, unmarried, male, female.
Actually, what does it differentiate? Married, unmarried will not matter in this study,
Yeah,
na?
ma'am, only the socio-demographic data for that
Even
purpose only.
socio-demographic profile also. We should be asking about how many were there nursing
Yeah,
staff,
in
senior
the,
resident,
yes, ma'am,
whether
that
they
was
have been
also
taught
asked.
about the needle stick injuries or not, in
Yes,
detail,
ma'am.
how to inject, how to aspirate.
Yes, ma'am. That was asked, ma'am. In the second part, we asked about whether they belong to the nursing staff or doctors. Among doctors, whether they were PG, senior residents, or consultants. Then experience in years we asked. Then about the number of patients dealing per day, and the timing of needle stick injury and the place of needle stick injury, and what were they doing during that time when that has occurred, and then whether they followed any precautions, whether proper gloves they have worn, and recapping of during recapping of needle or any other, at what time they had that needle, like what were they doing during the time they got the needle stick injury. Immediately
Okay.
after that, what did they do?
Okay.
Those things.
Dr. Latika, did you calculate any correlations like their knowledge and according to their, like whether they are doctors or nurses, like any correlation among their knowledge and
Ma'am,
practice?
the significant correlation was those who had less experience, 0 to 10 years. We divided that slot in people who had experience of less than 5 years, 5 to 10, and 10 to 15, 15 to 20, and greater than 20. So those who had 0 to 10 years of experience had more needle stick injuries. Like P value was significant, less than
I think
0.05.
you have presented those things in rather than these results, na? In the table form, and if you have any correlations. Okay.
Thank you.
Okay, thank you.
Thank you, ma'am. Thank you, ma'am.
Okay, thank you, Dr. Latika. Now, Dr. Kavita Mandrele, our sixth presenter. Her topic is pregnancy outcome in subfertile women conceived naturally or after.
Hello. Dr. Shikha, unmute yourself.
Dr. Kavita Mandrele, her
Yes,
topic
yes.
is pregnancy outcome in subfertile women.
Am I audible?
Yes, yes.
Okay, so this is a very simple study. It is an ongoing study and it is supposed to span from January 2020 to June 2021. So it is an 18-month study. Sorry, can you hear me?
Yeah, yeah.
So it is an ongoing study, but we decided to do an interim analysis, and it is basically comparing the pregnancy outcomes in subfertile women who either conceive naturally or after infertility treatment. It could be a conservative treatment or after assisted reproductive technology as well. So we all know that infertility couples have a higher risk of perinatal outcomes. They are more prone to have adverse problems during pregnancy, neonatal complications, and pregnancy complications. So the main objective was to evaluate the perinatal outcomes of pregnancies in subfertile women who conceived after treatment to those who conceived spontaneously, and also to see if there was a correlation to time to pregnancy on the risk of pregnancy outcome. So it is an ongoing prospective cross-sectional study spanning from, actually I have taken a data from January 2020 till October 2020. And we saw patients who either conceived spontaneously or after treatment, all presenting with infertility in our institution. And the data was analyzed in SPSS version 26. We had 84 fertile mothers who had conceived either spontaneously by natural conception or after conservative treatment or ART. So the age difference was not much in both the groups, and it was little higher in the patients who conceived after treatment, and the time to pregnancy was obviously higher in those who had conceived after treatment. Those who conceived naturally, the time to pregnancy was much less. The LSCS rate was almost double in those who had conceived after treatment, and
Time over.
patients was also little higher. And the time to pregnancy is an important factor influencing the risk of pregnancy complications. So we've seen multiple complications like hypertensive disorders, GDM, which were found to be higher in those who conceived after treatment. Thank you.
So Dr. Kavita, you have you checked this comparison, because this parameter, if we can see like age and these are not, well, it will show maybe significant difference like 40 year is coming here, because the two groups, they are not their age matched, and these things, I hope you are doing analysis maybe when your study is complete,
Yeah.
age matched controls.
We'll do a statistical analysis at the end of the study, but we can see a
Because
small
we can't
trend.
calculate these complications in the whole group. We have to do the age matched group, only then we can see whether the
Right.
actual complications are higher in that group if they are conceiving naturally or after treatment.
Right.
So,
But basically, I put the data right now so that you can see that there's a slight trend towards those who conceived after treatment, though I could not calculate the statistical difference right now. But a higher age group and time to pregnancy was little higher in those who conceived after treatment. The trend is there.
Dr. Kavita, I have question. How do you
Yes.
label subfertility in your group? And number second, did you randomize?
No,
Who
no,
will go
we
for a
have not
spontaneous
randomized.
conception? Who will go for induction cycles?
No, we did not randomize patients because it would be unethical to randomize patients who are having ovulation and then not give them like ovulation
No,
patients to
so
get
then
the
how did you
ovulative
label
drugs.
your subfertility?
Subfertility, we have taken the standard definitions of infertility.
What
how
is
they are conceiving naturally then? And how, is there
No,
any
no.
time
So
period you have decided that in
yeah,
this period I will decide that they have conceived and will take in that natural conception group?
no, like the patients who are coming to us for infertility treatment, we have taken those. There are many. I have almost 20 patients, 20% patients who conceive naturally. Many patients who
Yeah, that we know that.
counseling.
Hmm.
So we have not randomized them, but we have put them into groups.
No, no,
And
ma'am is asking you very. Ma'am,
sorry.
yeah, Dr. Aruna, I have the same question like Dr. Aruna has, like how we are
yeah,
selecting this
that's
group.
what I
No, ma'am, this is actually patients who are coming for infertility treatment. So you see in your practice also 20% patients at least will conceive naturally, that is without any treatment. So we have tried to put those patients in one group and then compare it with those who have been treated by infertility treatment, who have conceived after infertility treatment. Like that we have
So
grouped.
time to pregnancy.
Time over.
okay.
Thank you so much.
Thank you, Dr. Kavita.
Dr. Shikha,
Our seventh presenter, now audible, Dr. Sunita. Her topic is laparoscopy in severe endometriosis and subsequent pregnancies, a single surgeon study.
Good
Dr.
afternoon,
Sunita.
everyone. Am I audible?
Yeah.
Good afternoon, everyone. Myself, Dr. Sunita, Infertility Fellow at PGI Chandigarh. I'm here to present a single surgeon study on laparoscopy in severe endometriosis and subsequent pregnancies. Endometriosis is a chronic and recurrent disease which affects 5 to 15% of the general population, and in infertility, incidence may be as high as 48%. And its association with infertility is well documented with decreased fecundity. There are no randomized data on the effect of surgery on moderate and severe endometriosis on reproductive outcomes. With data for 10 women, the current study describes the cohort of women evaluated for infertility outcomes following laparoscopic excision of the endometriosis. Its methodology, it was a retrospective single center analysis done in Department of Obstetric and Gynecology, PGI Chandigarh, for a period of 2 months and 2 years and 2 months, from July 2017 to September 2019, and follow-up was up to November 2020. 10 infertile patients with endometriosis underwent fertility-preserving laparoscopic surgery, which were operated by a single surgeon and had stage 4 endometriosis intraoperatively. And post-surgery, patient underwent ovulation induction or controlled ovarian stimulation with IUI. Inclusion criteria were infertile patients operated laparoscopically, grade 4 endometriosis, and operated by a single surgeon. And exclusion criteria were mild moderate endometriosis with bilateral tubal block and who underwent bilateral self-injectomy during surgery. Patients were in the age group of 25 to 35 years, and among all women, post-surgery, 6 patients, out of 6 patients underwent controlled ovarian stimulation with IUI. 1 patient underwent COS plus IUI with followed by ovulation induction with letrozole, 1 IVF, and 1 tried for natural conception only. And 1 patient conceived spontaneously who had previous IVF failure outside in 2018, and time from surgery to conception was 5 months. 1 other patient conceived with ovulation induction with letrozole 2.5 mg TDS after previous 3 failed COS plus IUI, and 2 patients conceived with COS plus IUI, and outcomes were all term deliveries. And conclusion is conservative laparoscopic surgery is an effective treatment in the hands of an expert surgeon, which leads to significant improvement in pregnancy rate and yields good pregnancy outcomes.
Okay, very nice study. I just want to ask what criteria has been used for assessing severity and later on the functional outcome in case of in your cases?
Ma'am, intraoperatively, we had revised AFS scoring done for the patient, and who were in the category of grade 4 endometriosis, we choose them.
Like functional status, can you assess the functional status? Is there any criteria to use the functional status to give the predictive outcome for the pregnancy to these patients whom we are giving some management?
Ma'am, that is endometriosis fertility index.
Yes. Did you do that for these patients?
Yes, ma'am, we have used that.
So how much was that?
Ma'am, in 3 patients it was greater than 6. In rest patients it was less than 6.
So did you use that to classify your patient that whether they are going for IVF or ovulation inductions? Did you use this EFI?
Ma'am, we have calculated that. We have calculated that, and yes, ma'am, we have used that also. We have actually the both criteria, revised AFS scoring as well as EFI scoring, both we have done. Because EFI scoring is, it predicts more that of fecundity.
That has not been mentioned actually in your table, in your graph, no? In most of the cases, what surgery has been performed in grade 4 endometriosis?
In mostly it was adhesiolysis, and most had bilateral endometriomas, except 2 patients in which one had unilateral endometrioma, and 1 patient had only had frozen pelvis with adhesions. And in 1 patient who conceived naturally after surgery, she had unilateral self-injectomy as well due to gross hydrosalpinx and the dilated tube and very distorted tube, which was encased in the cyst.
Okay, very nice. Very good.
Thank you, ma'am.
Thank you, Dr. Sunita. Now, 8th presenter is Dr. Sabah Sharif. Her topic is uterine septum, journey from vein to bone. Dr. Sabah.
Good afternoon, ma'am.
Good afternoon.
I am presenting my e-poster presentation on uterine septum journey from vein to bone. The uterus originates from paramesonephric or Mullerian duct, and the prevalence rate of congenital uterine anomalies is 6.7% in general population, 7.3% in infertile population, and 16.7% in recurrent miscarriage population. And uterine anomalies are associated with recurrent pregnancy loss, malpresentation, fetal growth restriction, preterm birth. In our case, there is a case of a 26-year-old female with a history of previous 2 first trimester miscarriages. She presented to us with inability to conceive for 3 years. And there was a history of past history of myomectomy done in 2013 for subserosal fibroid. Post myomectomy, she had 2 spontaneous conception, which resulted in abortions. HSG was suggestive of biconvate uterus, and 3D USG was also suggestive of the same. Patient was counseled for MRI in view of uterine anomaly with recurrent miscarriages, but she again conceived and had an early pregnancy loss. MRI was done, and patient was diagnosed to be a case of partial thick avascular septa. and she underwent hysteroscopic septal resection with resectoscope, and patient conceived on ovulation induction and IUI after 1 year and had a successful pregnancy and delivered a healthy female baby. And septate uterus is associated with recurrent pregnancy losses in first and second trimester. And the number of vascular endothelial growth factors and homeobox protein 810 receptors in the transmembrane is significantly reduced.
Is she done? She has finished?
Yes, ma'am. Ma'am, there was some connectivity problem. Yeah, ma'am. On conclusion, the hysteroscopic septum resection is a safe and efficacious procedure in cases of infertility and recurrent pregnancy losses. And MRI is the best modality for accurate evaluation for the uterine anomalies.
Okay. Dr. Rita, you ask? No, I have a strong objection for your management of doing emergency LSCS in this case with preterm labor. Why you did a emergency LSCS in this case?
Ma'am, emergency LSCS was done in this case because of the preterm labor, ma'am.
Preterm labor is an indication for cesarean sections. It is a good thing she will deliver normally.
And which patients like these, she has myomectomy, even if she has myomectomy and septal section, so does it fit into the indication of preterm cesarean section? Like she had subserous fibroid.
Yes, ma'am.
And I hope the cavity was not opened. And the septal dissection also, you said that it was uneventful.
Yes,
I have one more question. Like, are these pictures of this patient only?
Yes, ma'am. The I took the patient file, attendance file, and I took the pictures from there. Ma'am, this is the patient MRI and USG, and it was suggestive of biconvoid uterus.
But 3D is not showing bicorner. 3D is clearly showing it is septate.
Ma'am, the HSG was suggestive of biconvoid.
No. After HSG, I hope you have done this 3D ultrasound. So if this is the same patient's picture, so that I can make out like the 3D ultrasound. And the other thing is what cautery you use for septal section.
Ma'am, hysteroscopic septal resection was done by using resectoscope.
What type of cautery usually we use? How many types of cautery we have, and what cautery you used in this patient?
Which year postgraduate are you?
Ma'am, JIA 1.
Okay.
Okay.
Dr.
Okay.
Okay, very nice.
Then
At
it
your
is
level, it's very good.
Yeah, yes.
Thank you,
Okay, thank you, Dr. Sabha.
Thank you, ma'am.
Thank you, Dr. Sabha. Our
Thank you,
next presenter is Dr. Niharika. Her topic is to study the efficacy of TVS, guided aspiration in patients having endometrioma.
Good afternoon, my judges, and welcome all. My study is to study the efficacy of transvaginal scan guided aspiration in patient having endometrioma. The aims and objective of my study was to see the TVS guided cyst aspiration as a viable option in place of repeated endometriotic cyst while avoiding morbidity of repeated surgeries, and to look for complication associated with this procedure and to find out the incidence of recurrence. The 51 patients of reproductive age group with endometrioma and infertility, whether primary or secondary, who underwent ultrasound guided cyst aspiration were included in this retrospective study in the Department of Reproductive Medicine Unit and IVF in St. Stephen Hospital between January 2015 to June 2019. Aspiration was performed by reproductive medicine consultant which were trained in interventional procedure using TVS guided cyst under all precautions as an outpatient procedure wherever possible. Patients were followed for up to 1 year of post-aspiration for any recurrence of cyst and any complications like hematoma, abscess formation, and the recurrence of cyst was taken as a final outcome. The results of my study was the 51 women of reproductive age group with average age of 33.1 years underwent transvaginal guided cyst aspiration. 17 of 51 patients had previous history of major surgeries and out of the 17 patients, the laparoscopic cystectomy was done in 10. Cyst was unilateral in 32 patients and bilateral was in remaining. The average cyst size was 31 to 60 mm with a range of 30 mm to 100 mm with volume of less than 100 cc's. There were no incidents of any intraoperative complications and only 16 patients had mild pain post aspiration and few had only mild nausea. Recurrence of cyst was seen in only in 18 patients, which is 35%, and which were managed by repeated aspiration. One patient of the recurred cases at 1 year had 3800 ml of fluid aspirated previously. 65% patient did not have any recurrence and were saved from major surgical intervention of cyst management.
Time over.
Okay, ma'am. So my procedure was found to reduce major surgical morbidity and is seen as a financially viable option. There were no statistically significant correlation of recurrence of cyst with CA125 levels, size and site of cyst, age of presentation, history of any ATT taken or other comorbidities, previous surgeries or content of aspirate, and procedure was found to be safe in all patients. So the conclusion of this study was TBS guided endometrial cyst aspiration is safe, inexpensive outpatient procedure for endometrioma. For the 1/3 of patients who had recurrence of cyst, it can be re-aspirated, still avoiding major surgical intervention. Based on our experience in 51 cases, TBS guided cyst aspiration is a viable option to manage the patient with endometrioma. Thank you, ma'am.
Dr. Niharika?
Yes, ma'am.
Yeah, did you consider giving any medical management to these patients, especially those who had recurrence?
Ma'am, most of the patients were having infertility. So we have to treat the patient in that sense. So
You did not consider laparoscopy surgery in these patients rather than going for aspiration?
Ma'am, we have seen that 17 patients after that had already laparoscopy in the past and many had undergone. So they were like, why are you doing, ma'am, again laparoscopy? So we started doing TBS guided cyst aspiration just to avoid again laparoscopy, re-laparoscopy, because we all know endometriosis is a recurrent condition.
After that, they went for IVF?
Yes, ma'am. After that, we give GnRH agonist for ultra-long protocol we give for 3 months, and then we started the IVF treatment for the patients.
Okay. I have one thing to all the candidates. You all have made like it is a written document of abstract or a paper, but you should be putting some table, some picture in your this thing poster.
Okay, ma'am. Actually, ma'am, that word constraint was there. So
No, actually, you need not put so many words and putting paragraphs. Poster is always a tabulate form, so you have to present your data. So it can't be paragraphs and these things.
It should click. If there are cases, just write down case 1, 2, 3, or Delhi between June and January. This you don't have to write down.
Okay, ma'am.
Okay. Okay, nice one.
Thank you.
Thank you.
Thank you, Dr. Niharika. And I would like to invite Dr. Maliti, our 10th presenter. Her topic is serum estradiol or follicle ratio on the day of trigger as a predictor of success in IVF outcome.
Good morning. My topic is serum estradiol per follicle ratio on the day of trigger as a predictor of success in IVF outcome. The prime concern in IVF cycle is to obtain sufficient number of mature oocytes, good quality embryos, and finally achieve a successful pregnancy. Multiple factors have been studied for prediction of IVF outcome. In my research, I have studied the impact of estradiol per follicle on as a measure of IVF outcome. This is a cross-sectional observational study done at Women's Center by Motherhood between January 2019 and September 2020. 125 couples undergoing IVF ICSI flexible antagon protocol, freeze-all and FET cycle transfer were recruited. And they were all women under less than 35 years of age. And exclusion criteria is the factors which can affect the oocyte quality, such as endometriosis, adenomyosis, and severe male factor. They were again categorized into normal, hyper, and poor responders based on AMH and AFC. Each group of patients are again subdivided into 5 categories based on estradiol per follicle ratio. The primary outcomes assessed are the number of mature oocytes obtained and the E2 per number mature oocyte, fertilization rate, cleavage rate, and secondary outcome will be the pregnancy rate in FET cycles. The results are, for an increase in E2 per follicle ratio, there is an increasing trend in E2 per M2 ratio, and the correlation is statistically significant in the group of hyper and normal. In poor, it is not statistically significant because it may be due to the lower number of the subjects recruited, it is 13. There was no statistically significant correlation of E2 per follicle ratio with fertilization and cleavage rate. As far as pregnancy is concerned, the cumulative pregnancy rate is calculated, and it is divided into those positive and those who are negative with nil embryos. 90 couples who have completed their transfer were analyzed, and 35 couples were yet to be transferred.
Time over.
The overall positivity rate is 64%, and though there is an increasing trend in between the groups 142 to 249 and 250 to 349 and 350 to 450, this is not statistically not significant and at 5% level of significance. Conclusion is, though there is statistically significant correlation between E2 per follicle and E2 per M2, it cannot be used to predict the IVF outcome in terms of cleavage rate, fertilization rate, and pregnancy rate. Thank you.
Okay, very nice study, Dr. Malati. I have two questions. The references you have given of 2014 and 2007.
Yes, ma'am.
Same type of study.
Yes,
At that time, frozen embryo transfer was not that common as it is being utilized these days.
Ma'am, those studies were actually not on frozen embryo transfers, ma'am, but I wanted to do research on frozen embryo transfer
Yes,
with
that's
antagon
what
cycle.
I wanted to say, because now the cycle is totally different.
That's why I would choose
cycle.
this.
That's why, how can you correlate the estradiol level of a previous cycle with this cycle on an implantation rate? That will always have a bias. Cleavage rate, okay, because that will depend upon the quality and your fertilization. But pregnancy rate, lot depends upon the implantation also.
Yes, ma'am. There are other factors which can affect the implantation rate, ma'am, but it is taken as a secondary outcome, ma'am.
So the pregnancy, did you calculate the pregnancy rate like complete cycle, like, or you had just calculated in one frozen embryo transfer?
It's a complete cycle, ma'am. How
So
many embryos they have?
where you have calculated, they have used all their frozen embryos.
Yes, ma'am.
So cumulative pregnancy rate you are calculating.
Yes, ma'am.
Okay. Maybe you need more number actually, and these studies are actually quite old. Like, did you check the recent studies on this? Like, what is the relevance of this estradiol and follicle ratio on these factors, and whether it has a value in calculating the pregnancy outcome in these patients or not? Any recent data on this?
The pregnancy rate is not much studies are available, ma'am. And frozen embryo cumulative pregnancy rate, as we.
So what is your primary outcome?
Primary outcome is whether there is any correlation between E2 per follicle more than 14 mm on the day of trigger with E2 per M2 ratio and E2 per number of M2s obtained.
Excuse me, time is over, ma'am. So we have to conclude this session. And really congratulate all the participants and thank you very much for your participation.
Yeah, thank you all the participants.
Thank you, Dr. Aruna. Thank you, sir.
Thank you, Bharti.
Thank you. Have a nice day.
Okay, thank you, ma'am.
Respected judges, dear presenters, our esteemed faculty, and dear delegates, I welcome you all to the last free communication session of Fertivision 20, the first virtual global congress of Indian Fertility Society. And with us, we have our 4 accomplished doctors as our judges. Dr. Alka Sehgal, teacher par excellence. She's the professor and head Department of Obs and Gynae, GMCH, Chandigarh. We have Dr. Sudha Padmasari. She's director of Padmasari Hospitals and vice president, Andhra Pradesh chapter of ISAR. We have Dr. Aswathi Kumaran, consultant reproductive medicine, Aster Miracle, a unit of Aster MIMS, Kottakkal, Kerala. And Dr. Deepika Jagga, she's consultant reproductive medicine at Apollo Cradle and Ridge IVF, Delhi. So may I invite Purnima Sharma to start with her talk first?
Am I audible,
Hello,
ma'am?
Purnima.
Hello.
Yes. Yes, you
Am I
are.
audible, ma'am?
Yeah, you're audible.
Yes,
But,
yes, you
Good
are.
afternoon,
yeah.
respected judges.
Yeah, you're audible.
My topic is a randomized control study of the combination of human chorionic gonadotropin and clomiphene citrate versus clomiphene citrate alone on the pregnancy rate in the primary and ovulatory infertility. So, the ovulation disorders accounts for 25% of the infertility, and 85% of those belongs to WHO group 2 anovulation disorder. Human chorionic gonadotropin is often administered to trigger the rupture of dominant follicle in clomiphene citrate or letrozole cycle, which mimics the endogenous LH surge. But there is paucity of the literature which shows the superiority of the addition of HCG trigger to clomiphene citrate ovulation induction cycles on the pregnancy rates in the women undergoing ovulation induction with the clomiphene citrate. So my research question was, does the addition of HCG to the clomiphene citrate ovulation induction therapy in a women with anovulatory infertility increases the pregnancy rate in comparison to women who are receiving the clomiphene citrate alone for the ovulation induction? The study was conducted in infertility clinic in the OPD of the Lady Harding Medical College and Srimati Sucheta Kriplani Hospital, New Delhi from November 2018 to March 2020. It was a prospective randomized crossover study. So all the women who presented to the infertility clinic were subjected to the workup, and those who were diagnosed with the anovulatory infertility were subjected subsequently to the inclusion and exclusion criteria. So women with WHO class 2 ovarian dysfunction between 21 to 30 years of age and BMI between 18 to 29 kg per meter square with normal hormone profile and no other identifiable cause of infertility were included, while those with any other causes of the infertility, any known hormonal disorder or on any hormonal treatment and FSH level more than 10 international unit per liter were excluded from the study. So total of 100 such women were selected and randomized into two groups of 50 women each to decide regarding the initiation of the protocol in the first cycle, and then subsequently alternatively the protocols were changed. They were subjected to the baseline ultrasound on day 2-3 of the cycle for the entire follicular count, endometrial thickness, and any residual cyst. One group has received clomiphene citrate 50 to 100 mg followed by HCG 5000 international unit intramuscularly when the follicle size reaches 18 or more in the diameter as determined by the serial transvaginal ultrasound, while the other group received 50 to 100 milligram clomiphene citrate alone. And time intercourse was advised 5 days after the last dose of clomiphene citrate on the alternate days in both the groups for 10 days. Each woman was followed for maximum of 4 cycles for the of the ovulation induction or till they conceived, whichever was earlier. And for each patient, two protocols were used alternatively. In each cycle, the length of the luteal phase and the serum progesterone 1 week after the ovulation was also documented. So the primary objective of the study was to compare the pregnancy rate in the two groups, while the secondary objective was to measure the luteal phase length and the serum progesterone 1 week after the ovulation. So these are the this is the table which is showing the patient profile and the hormonal profile in each group, the women who conceived. So the age, BMI, enteral follicular count, and LH-FSH ratio in both the groups were comparable. However, the women with proportion of the low enteral follicular count that was defined in our study as less than 10 was significant. The primary outcome, the present study, the overall ovulation rate was 80% and the pregnancy rate was 40.2%. In our study, the women conceived from CC were 18.1%, while CC plus SCG group was 22.2%. The results were comparable, however, not significant, statistically significant. This is the table which is showing the pregnancy rate and the pregnancy outcome. So, among the women who conceived, about the 90% was the rate of the viable intrauterine pregnancy in the group who conceived with clomiphene citrate, and 2 had missed abortion, while in CC plus SCG group 15 had intrauterine pregnancy and 1 had ectopic pregnancy. The secondary outcomes were as follows. Day 21 progesterone in CC group was 9.63 nanogram per ml, and CC plus SCG group was 10.82 nanogram per ml, while the luteal phase duration in CC group was 14.36 days and 14.32 days in CC plus SCG group. The results were again comparable in both the groups, however, not statistically significant. So, results of this study suggest that the combination of HCG plus CC is not superior to clomiphene citrate alone for achieving the higher pregnancy rate in women with primary and ovulatory infertility. According to the Cochrane review, not much studies have been done. Only 2 studies have been were found which were similar to ours, and they were also almost 10 to 12 years back, and one of which was by Yilmaz and others, and it has shown the addition of HCG to CC ovulation induction therapy does not improve the pregnancy outcome and mid-luteal progesterone level. However, it shortens the luteal phase duration. And a similar study was done by Agrawal et al. In 2011, which has shown the no difference of these parameters between the HCG triggered and spontaneously ovulating patient, which was a finding similar to our study. So these are the results of the study which was conducted by Yilmaz and others in our study. So results were quite similar. However, in our study, the luteal phase duration was also not affected by the HCG. So I conclude that it appears that the addition of HCG to the clomiphene citrate ovulation induction therapy does not improve the pregnancy rate and mid-luteal progesterone in the women with WHO class 2 and ovulatory infertility. Thus, the timed intercourse on alternate days from day 12 of the natural cycle, according to the HCG injection, would not result in significant time difference to affect the pregnancy outcome. Also, it would be cost effective and prevent the repeated visit to the hospital for follicular monitoring and HCG injections. Thank you.
Thank you, Dr. Purnima. Can I have one question from you? Can you hear me, Dr. Purnima?
Yes, ma'am.
Yeah, I just wanted
Yes,
to
ma'am,
know,
I can hear you.
apparently from your study, it seems that simple statistics of percentage calculation has been utilized for this study. But this seems to be multivariate because, you know, how many patients conceived on the dose of 50, on how many conceived on the dose of 100 milligrams, and which cycle is not very clear from the study. I mean, it is the overall results which have been given. Can you just elaborate
Yes, ma'am.
on that?
Ma'am, we have not calculated separately, like from which dose of the clomiphene citrate, which patient, how many patients have received. We have just taken one group of clomiphene citrate and another group of clomiphene citrate plus HCG. We didn't calculate it separately according to the dosage.
So it will affect the dose of clomiphene can affect the outcomes. No, so this becomes a multivariate study instead of just one variable of HCG alone. That was my first this thing query. The second you said was ovulation rates. I didn't find anywhere how you concluded that the patients ovulated.
Ma'am, we have first we followed her with the transvaginal ultrasound. So the findings of the decrease in the size of the follicle with presence of a corpus luteal cyst, fluid in the POD, and conversion of the triple layer into the homogeneous hyperechoic layer, plus the day serum progesterone 1 week after the ovulation, that was more than 3 nanogram per ml, was considered as a marker for the ovulation.
But it's not mentioned in your study. That's why I was asking. I pass on to the other judges for any queries. Dr. Sudha?
You have 30 seconds for the questions.
Dr. Deepika?
Yes, so.
Purnima?
Yes, ma'am.
But the number of patients that you had taken were very few, no? Your total number of patients were how many in each group?
Ma'am, 100.
Oh, out of the 100 group. But see, you have noticed 2 missed abortions only in the CC group, not
Yes,
in the
yes.
HCG group.
No, ma'am.
Yeah. Ma'am, time's up for the questions. Shall I call the next speaker?
Yeah.
Hello?
Yeah. Please
So,
do.
Shweta, are you sharing your screen? Dr. Shweta? Yeah.
We can't hear you, Dr. Shweta. Dr. Shweta, we can't hear you. Are you muted?
Dr. Shweta, please check your audio connection. And can we go to the next presenter?
Yeah, that's all. Shweta, if you're taking time, may I call Pooja Jain for her presentation? Pooja, if you're ready, please start sharing your screen.
Sure, ma'am, I'm sharing my screen.
Yeah.
Is it visible, ma'am?
Yeah. Carry on, Dr. Pooja.
Yeah, good afternoon, respected judges and all the audience. I'm Dr. Pooja Jain. I'll be presenting my study on outcome of intrauterine insemination with different ovulation induction protocols, a retrospective study. IUI combined with controlled ovarian stimulation is a commonly performed and efficient treatment modality for selected population, but still there is still no consensus on the optimal protocol. Just a second, ma'am. Sorry. So aim of my study is to compare efficacy of IUI with different ovulation induction protocols in women with anovulatory infertility. It's a retrospective study done at a tertiary care center over a period of 4 years from July 2016 to 2019, carried out with 1076 couples with anovulatory infertility, patent fallopian tubes, and normal semen parameters. Couples were subjected to IUI after different protocols of ovulation induction, which are summarized as follows. There were total 10 protocols which were used. All the stimulation was started from day 2 to day 5 of the periods. In first group, only clomiphene citrate in a dose of 100 milligram per day was given for 5 days. Another letrozole, only 2.5 milligram dosage was given from day 2 to 5 of the period for 5 days. Another group received only HMG in a dose of 75 international units per day and escalating according to the response. Another group, we used combinations of clomiphene citrate with either HMG or urinary FSH or recombinant FSH. Clomiphene citrate was used in a dose of 100 milligram per day for a total of 5 days, and then addition of 75 IU, starting with the 75 international units of the gonadotropins for a variable duration depending upon the response. When letrozole was combined with HMG, letrozone again with the dose of 2.5 milligram per day for 5 days, and addition of 75 IU of HMG for a variable duration, depending on the response. Then another protocol in which we used clomiphene citrate with injection leuprolide, Leuprolide was started in a dose of 0.1 milligram from day 21 of the previous cycle till day 2 of the menses, and then clomiphene was started in a dose of 100 milligram from day 2 for 5 days. Another protocol, we used clomiphene citrate in a dose of 100 milligram from day 2 for 5 days, followed by injection citrorelix 0.25 milligram subcutaneously for 1 or 2 days to avoid the weekend's IUI. Then in another protocol, we used clomiphene citrate 100 milligram per day again for 5 days, and tab metformin was started at least 1 month prior to the cycle stimulation in a dose of 850 milligram twice daily. Then the follicle growth was monitored with the use of transvaginal ultrasound from day 6 of the cycle, and then it was repeated every 2 to 3 days depending upon the follicle size. And ovulation trigger was given when at least one mature follicle was assessed to be 18 to 20 mm, and IUI after injection of HCG, which was 5,000 to 10,000 intramuscular, and IUI was done 36 to 40 hours later. And then results were compiled as clinical pregnancy rates, which were documented as beta HCG more than 50, after 2 weeks of IUI and presence of cardiac activity on transvaginal scan at 6 weeks of gestation. So the primary outcome in my study is clinical pregnancy rate as achieved by using ovulation and different ovulation induction protocols with first cycle of IUI. And statistical analysis was done by applying comparison of two proportions test. So this is the first table which shows pregnancy rate among different age groups. As shown in the table, pregnancy rate decreases as the age advances. This is the second table showing the comparison of pregnancy rate with the type of infertility patient. So the secondary infertility patient showed a statistically significant higher pregnancy rates than the primary infertility group. This is the table which showed different protocols of ovarian stimulation with IUI, and the rates, the percentage of the patient who got positive with clomiphene alone were 10.03%, with letrozole 10.5. HMG, letrozole plus HMG showed similar pregnancy rate, that is 12.5. CC plus urinary FSH 10.7, CC plus recombinant FSH 13.8, injection leuprolide with injection leuprolide it showed 10. I'm not able to see. And then injection citrorelix it showed 8.8%, and with metformin combination with CC it showed 10.2%. So there were total 1076 patients, and the mean pregnancy rate came out to be 11%. So pregnancy rate in my study varied from 8.8 to 13.8%, and it was highest with the combination of clomiphene citrate and recombinant FSH, and it was comparable when we used clomiphene alone, letrozole alone, or CC plus HMG, and clomiphene citrate plus urinary FSH and CC plus metformin. And as we all know that it decreases with increasing age, and it was higher in secondary infertility group compared to primary. Coming on to the evidence which is reported earlier, a study by Yildirim G. et al. In 2017, it showed that gonadotropins when combined with IUI achieved significantly higher pregnancy rates in anovulatory patients with history of prior pregnancy. Another study by Huang et al. In 2016 showed that in PCOS women, when undergone stimulation with IUI, the pregnancy rates were similar. They were the clomiphene, letrozole, gonadotropins were all equally effective. Another study by Jinyong et al. In 2016, it showed that in anovulatory women, there were no significant differences using different protocols. And another study by Pierre et al. In 2015 showed that HMG stimulation achieved higher clinical pregnancy rate compared to clomiphene in subfertile couples treated with IUI. So, conclusion of my study is that careful selection of patients after proper counseling and the method chosen for ovulation induction has a critical bearing on the success of IUI. Combination of clomiphene citrate and recombinant FSH showed highest pregnancy rate in my study, and using gonadotropins alone or as an additional stimulatory agent improved pregnancy rates of anovulatory patients compared to the use of oral ovulogens. Thank you.
Dr. Pooja,
yes, ma'am.
You've been calling it a study, but personally, I feel it is just a data analysis. It would be more effective if we knew what were the criteria based on which you decided which protocol or what drug or what combination is to be used, because then the results can be compared. This was just a basic data analysis. And apparently, even in your discussion, you do show that the results are almost similar as by others. But then on what basis, on what criteria, what choice and what combination was chosen? And how many cycles were utilized with one variable, or this thing is not clear from your data.
And this data was only after the first cycle of IUI.
Okay, okay. Dr. Sudha, any question you want to ask? You have muted yourself, Dr. Sudha.
So if
yeah,
Dr. Sudha, you have to okay.
Pooja?
Yes, ma'am.
So finally, your pregnancy rates are in the first cycle of IUI is around 11%.
Yes, ma'am.
On the average. So for PCOS patient, you're preferring gonadotropin usage. Other than that, you find that there's not much advantage of using. That is the conclusion of your study.
Yes, ma'am.
Okay, then just wanted to confirm. That's it.
I had a question, Pooja.
Yes, ma'am.
You have studied 10 different protocols, right? And it was a very interesting data analysis with the outcomes that is coming. Could you please explain why you used agonist and antagonist in certain scenarios? In certain patients, you have used agonist or agonist suppression, right?
Yes,
Could
ma'am.
you please explain why you used it?
Yeah. Ma'am, antagonist injection cetrorelix we used when the follicle was mature, but it was a like Sunday or it was a weekend.
So you used it during the stimulation, but you mentioned that you were using agonist beforehand as in a suppressive protocol. Why did you use that? What was the indication in those patients?
Ma'am, antagonist we used like later part just to avoid the weekend IUI. In agonist, we started leuprolide on the day 21 of previous cycle. That was done in those cycles where the LH and FSH values are a bit in higher range, or there was under some sus to just to suppress that. We used leuprolide.
So is that over? So may I call Sweta now to join?
Yeah, definitely.
Sweta, could you solve that mute wala problem? Dr. Sweta?
We can go on to the next otherwise.
Yeah, we can go to Dr. Pooja Unyal now. Dr. Pooja Unyal, please start sharing your screen.
Yes, ma'am. Good afternoon, everyone. Just share.
We can't hear you, Pooja. Any audio problem or?
Ma'am, am I audible, ma'am?
Yeah,
Yes,
you are audible.
Ma'am, is my screen visible?
Yes, it's visible. Just do a slideshow, please.
Yeah.
Okay. I'll just go to the slideshow. Good afternoon, everyone. Good afternoon, respected judges. I'm Dr. Pooja Unyal. I'll be doing my oral paper on comparison of clomiphene citrate 100 milligram with letrozole 5 milligram as a first-line treatment in women with oligomenorrhagic obese polycystic ovarian syndrome undergoing timed intercourse or intrauterine insemination. It's a randomized control trial. I can't change my slides. Yeah. So, polycystic ovarian syndrome is a common cause of anovulatory infertility and comprises of around 50% of women presenting in infertility OPD. Oligoovulatory PCOS comprises of about 80% of the patient with polycystic ovarian syndrome presenting with infertility, and they require ovulation induction, which we all know, and there are various induction agents available are clomiphene citrate, letrozole. In Easter 2018, there is no evidence of improvement of pregnancy outcome when clomiphene citrate is used for ovulation induction as compared to letrozole or vice versa in women with obese PCOS. In short, it doesn't specify anything about women which are obese and having this PCOS. There is a scope of improvement in as there is low quality evidence suggestive that one agent is better than the other in obese PCOS women, and therefore the study is conducted to add to the evidence. The aim and objective of the study, it was to determine whether pregnancy outcome in oligomenorrhagic obese PCOS women with BMI more than 25 kg per meter square are different when undergoing ovulation induction with clomiphene citrate 100 mg as compared to letrozole 5 mg. And to determine an ovarian stimulation syndrome rate, cancellation rate due to no response or cancellation due to hyperresponse are different in the two groups. Materials and method. The study location was a Department of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. It was a randomized control trial done in the period of 6 months, which is August and January 2020. The sample size was taken as considering a PCOS frequency of 15% by Rotterdam's criteria among infertile women, an obesity rate of 40%, and an average OPD footfall of 5 new patients per day, which are non-IVF. We expected to recruit 50 patients in the study period allocated. I'm not able to change the slides actually.
You're not audible. You're not audible, Dr. Pooja.
Yes, ma'am. Ma'am, I'm not able to change my slides.
Okay. You have the material in front with you?
Yes, ma'am. I have everything in my laptop, ma'am. I'm not able to change the slide actually. Yes, now I can. Ma'am, the inclusion and exclusion criteria. Women with PCOS inclusion criteria consist of women with polycystic ovarian syndrome by Rotterdam's criteria, in which 2 out of the three criteria were required, which are oligo or anovulation, hyperandrogenism, can be clinical or biochemical, and PCOS morphology. Second, the exclusion of other cause of menstrual disturbance and hyperandrogen were excluded. BMI was more than, for every patient was more than 25 kg per meter square. Oligomenorrhea, undergoing timed intercourse and intrauterine insemination. Exclusion criteria was women undergoing IVF, patients with bilateral tubal block, patient in which semen parameters were less than the WHO 2010 strict criteria, patient having grade 3 and 4 endometriosis, and lack of consent. Methods: women meeting inclusion and exclusion criteria were approached for consent to participate in the study. Consenting women underwent the following tests, which are the physical examination, BMI, hirsutism, BP measurement, waist circumference were taken into account. Investigation was done, which consisted of TSH, prolactin, serum free testosterone, FSH, LH on day 2, OGGT with 75 gram of glucose, lipid profile, AMH, husband semen analysis, and a baseline scan on day 2 or 3 to see the AFC count. Tubal patency test, HSG, was done for all patients. Randomization was done after baseline ultrasound scan on day 2 or day 3 based on computerized generated sequence in 1:1 allocation. To receive an arm 1, the patient received clomiphene citrate 100 mg for 5 days from day 2 to day 5 of the periods. And in arm 2, they received letrozole 5 mg for 5 days from day 2 to day 5 of the periods. Follicular monitoring scan was done from day 11 onwards till the day of ovulation. If no dominant follicle about 12 mm was seen 12 days after the last dose of oral ovulation, the follicle was not monitored further, a serum progesterone test was ordered, and a cycle was labeled as treatment failure when progesterone value was found less than 3 nanogram per ml. If follicles more than 3, above 16 mm was seen, the cycle was cancelled, no IUI was done, and couple was advised to avoid timed intercourse after explaining the risk of multiple pregnancy. Ovulation was triggered by HCG 5000 international unit intramuscular. Once 1 to 2 follicle between 18 to 20 mm are seen, a natural contact IUI was planned as per consultant protocol 38 to 44 hours later. Vaginal micronized progesterone supplement 200 mg twice daily was given for 2 weeks, and an UPT was done after 2 weeks. The outcome of my study, the primary outcome was clinical pregnancy rate, which was number of patients with positive cardiac activity upon total participant in that arm. Secondary outcome was ovulation rate, which was monitored by ultrasound. Mean number of mature follicles more than or equal to 14 mm. Mean endometrial thickness on the day of HCG. OHSS rate, in which there were patients presenting with symptoms like distension, abdominal pain, gastric symptom, reduced urinary output, and I categorized the patient as moderate to severe. There was cycle cancellation rate, multiple pregnancy rate, and early pregnancy loss rate. The analysis was done using a data analysis software, SPSS20, and probability value of less than 0.05 was considered significant. These were my observations. The demographic profile between the true group, which was given clomiphene citrate 100 mg and letrozole 5, were similar. There was no difference. The mean age, the duration of infertility, the type of infertility, the mean cycle frequency was similar between the two groups. The physical parameters which I took into account, the height, weight, BMI, waist circumference, those was also similar between the two groups. The investigation which was done, like AMH, lipid profile, cholesterol, all the
1 minute remaining. 1 minute to go.
Husband semen analysis and AFC count was similar between the two groups. The main significant difference was found in the number of follicles. I saw that the number of follicles was significantly more in clomiphene citrate group as compared to letrozole group, and the endometrial thickness was significantly higher in the letrozole group as compared to clomiphene citrate group. These two, which we all know, it helps in the endometrial thickness. Clomiphene citrate decreases the endometrial thickness, which was also in my study. The endometrial thickness was more in letrozole. The number of days of ovulation, the need for additional gonadotropin, they were similar between the two groups. The time intercourse in IUI was similar. Ovulation rate, beta HCG positive rate, and clinical pregnancy rate was similar between the two groups. There was no difference between the groups. Similarly, the OHSS rate was little higher in clomiphene group. 3 patients complained of having OHSS. Treatment failure rate was similar between the two groups. Multiple pregnancy rate was higher, though they were not statistically significant. and early pregnancy loss was also same. Comparing this to the previous studies, like Legros did in 2014, in which he compared, there was no study which I found, ma'am, which actually compared these two drugs in these doses in an obese patient with BMI. My study actually compared in a specific subset, like obese oligomenorrhagic PCOS. And we found that there was no difference in the ovulation of pregnancy rate when we are given these two drugs. Conclusion, our study concluded that the ovulation rate was similar when an obese woman was given 100 cc or 5 mg of letrose. Clinical pregnancy was more with letrose group, but not significant statistically, and multiple pregnancy-related adverse effects were more with CC group. However, it was a small study with a smaller subset of PCOS patients due to time restraint, and more data is needed to affirm the same. Thank you, ma'am. That's it.
Thank you, Dr. Pooja.
Thank you.
I just noticed that it is a study which has been conducted over a very short period also.
Yes, ma'am. Yes, ma'am.
One thing which was not very clear from the presentation as well as what we received is
Yes,
whether you carried out the IUI in per cycle was only once or twice, and what was the effect of the cycles, because we know that clomiphene does have a cumulative effect also.
Yes,
so maybe
yes,
in the subsequent cycles, the results may have been better compared to the letrozole. So
yes,
can you define that?
Yeah, ma'am. Ma'am, actually, because of the time restraint, it was a randomized trial, and usually when patient come in Gangram, they usually are not naive. They have undergone any infertility treatment previously. So I could only recruit around 45 patients, though my target was 50, and it was obese with having everything. Half of my patient actually went for IVF in between, so I was not able to recruit the number of patients. But ma'am, this was only taken for one cycle. I never followed for the second cycle for the study. It was for one cycle only. And ma'am, the patient IUI or time intercourse, it will completely depend on the consultant. They just say it themselves. There are 4 consultants in our department, and few things that if everything is fine, then you can just go for a natural intercourse. And someone say, let's do IUI. So it's completely that. But I didn't follow in the next cycle what happened. Clomiphene ka effect raha, nahi raha, ma'am. It was just for one cycle.
Thank you. It would be worth doing a randomized study on controlling both the parameters.
Yes, ma'am. Yes.
Dr. Aswasti, you want to ask anything?
Yes. Dr. Pooja, it was a very nice presentation.
Thank
I'll
you,
just point out a small error. In your title slide, clomiphene was misspelled.
Oh, sorry, ma'am. Okay,
Everywhere else it is fine, but in your title slide, clomiphene was misspelled. Then I would just like to know whether you have ruled out the BIA while comparing the two compounds, clomiphene and letrozole, in your subset. I want to know whether they have received metformin or not. Did you make a mention of that? Did you make a mention of that?
No,
That
ma'am.
is very important because
Yes,
there
ma'am.
are proven studies that are showing that clomiphene with metformin
is
is
better
comparable as letrozole. So if metformin has been grouped in used in both the groups, that is going to be a source of BIA. And when you are going to do a study, then you have to mention whether these things were there and what is the quality of your study.
Okay, ma'am. I'll keep that in mind, ma'am. Yes, ma'am. I haven't mentioned metformin because initially ma'am, if there's past history of any drug intake, I actually excluded it, even in RBS, and if she's having any drug taken. So I excluded
because
the
obese, most often they will receive
Yeah.
metformin, there is going to be a BIA.
Yes,
Nice
ma'am.
study. Anyways. Yeah.
Shanu?
Yeah. So
can we have the next speaker?
Dr. Shalini, is it going to be you or Shweta?
I will give a choice to Shweta first because she's having a lot of problems. So let her have first be given an opportunity in case she can.
So, Dr. Shweta, are you ready?
Dr. Shweta, you're still not audible, madam.
She's on unmute, but Sumit, can you please check with?
I've been calling her, madam. We've been checking on the details, but unfortunately, we're not able to connect. I'll call her again. We'll go to the next speaker.
Shanu, then let's call the next one. Let's not waste time. Let's call Dr. Shalini by then.
Yes. Good afternoon, judges. This is an open label randomized trial comparing letrozole and clomiphene citrate in infertile PCOS women. Most of our interest has been in ovulation induction in our department publications. So the study question was, we started using letrozole, how to titrate this drug because we were more comfortable with using clomiphene citrate, and why most of the studies were saying letrozole was better. So we wanted to see why did letrozole perform better in our studies, and what were the reasons which made it a better drug. So to compare the ovulation rates using different doses of clomiphene citrate with letrozole, we started comparing the impact on the endometrium and perifollicular blood flow, the endometrial thickness with letrozole and clomiphene citrate using various drug doses in anovulatory women, and we compared the pregnancy. This was a prospective randomized trial conducted in our department with institutional ethical committee permission, and we calculated the sample size considering that we had an 18% incidence, and therefore 80 women were recruited in the trial. PCOS women with confirmed anovulation in the baseline cycle and who met the inclusion and the exclusion criteria of the study, which meant exclusion of all other causes of infertility, anovulation confirmed, and normal semen parameters and normal HSG were recruited. And they were group A was clomiphene citrate and group B was letrozole. Informed consent was taken. And group A women received clomiphene citrate 50 milligrams for 5 days from the 3rd day to 7th day. And ultrasound was done on day 11-12 to look for the dominant follicle, which was followed up for disappearance of the follicle to confirm ovulation. If the women ovulated with 50 milligram, they were continued with the same dose for 3 more cycles. In case the women did not ovulate with 50 milligram, she was either given withdrawal bleed or we waited for the menstruation, and in this next cycle we gave her 100 milligrams. And if she showed a dominant follicle with 100 milligrams, she was continued with the 100 milligram for another 2 cycles. And if there was no ovulation with 100 milligrams, in her next cycle she received 150 milligrams. In the women who failed to ovulate with 150 milligrams, we called them CC resistant. Similarly, in the letrozole group, we started with 2.5 milligrams, and if they ovulated, then we continued the same for 3 cycles. If they did not ovulate, we gave them 5 milligrams in the next cycle. If they did not ovulate with 5 milligrams, they received 7.5 milligrams. And if they failed to ovulate with 7.5 milligram, we call them letrozole resistant. So the dominant follicle which was present, once the dominant follicle was seen, we looked at the perifollicular blood flow, and it was graded according to Chew et al. Grading, and grade 4 was when it was 100% perifollicular blood flow was seen, and grade 1 was when there was no detectable blood flow. Similarly, the endometrial thickness at the time when the dominant follicle was seen was graded, and endometrial thickness was measured, and endometrial layering, whether there was distinct 5 line or there was no layering, and the blood flow pattern was also looked at upon, and pattern C was when there was subendometrial and intraendometrial blood flow was present. So statistical analysis was done using SPSS Chicago version 18, and we looked at the various variables and the distribution or normality distribution and student t-test chi-square or Fisher-Stack, and the correlations were done using Spearman. Now when we compared the data between the 2 drugs, we found that the ovulation rates were comparable between the letrozole group and the clomiphene, whereas when there was a statistical difference between the multifollicular follicles with the clomiphene citrate, much less with letrozole. The pregnancy rates were exactly comparable between the 2 groups. The resistance rate was more with clomiphene citrate, but this failed to reach any statistical significance. Now we compared at the various doses. We found that at the starting dose of clomiphene citrate, we had 22% ovulation, whereas it was 42% in letrozole group. At 5 milligrams, the women who received 5 milligrams, there was 80% ovulation, 57% with 100 milligram of clomiphene citrate. Even at 150 milligrams, the ones who received,
I unmuted. Can you listen to me?
55% ovulation, whereas 33% in letrozole group 7.5. Now, when we looked at the endometrial parameters, we found that letrozole performed better, but the most important thing was that the vascularity was much higher in the letrozole group compared to the clomiphene citrate group. Now, when we looked at the 2 tables where we saw the low dose and the higher dose, because most of the women who did not ovulate with lower dose required higher doses, the ovulation rates were much lower with the clomiphene citrate as compared to the starting letrozole dose, whereas the pattern C, if you see, as we increased the dose of clomiphene citrate, the pattern C flow decreased, and there was distinct 5 line also fell down, and this was both statistically, even though we had the pregnancy rates comparable with these two drugs. The most interesting finding we came across was that as the clomiphene citrate dose was increased, the perifollicular vascularity decreased to 33%. Whereas when we compared letrozole, the ovulation increased with increasing the dose, but the perifollicular vascularity was just as comparable in both the groups. Now the pregnancy outcome, the pregnancies both had a comparable outcome, letrozole and clomiphene citrate. Even at the dose comparison, they both had comparable pregnancy rates. So now coming to the discussion, there has been the recent HVA 2019 evidence-based guideline, which says letrozole performing better than this. But when we look at the sub-analysis, the most important is 7 of these RCTs has high-risk buyer, and there was no difference between the two interventions in any outcome. So the conclusion was that letrozole and CC have been both effective. We cannot just shun away clomiphene citrate, but definitely letrozole has started performing better. Maybe it is effect on the follicular or the receptor level, which we need to perform more studies. But the problem is in our country, we are not getting permission to perform more studies, and therefore we are restricted to perform, await and not perform more studies. Even the ICMR is also trying to start more studies on letrozole. So thank you. With this, I invite questions.
Thank you, Shalini. I think these are quite expected results, but the extensive study you've done on the endometrium and the perifolliculars, flow is an additional parameters. I just wanted to ask, despite quite dissimilar results on these two parameters, which you thought would be, give you an answer why letrozole is doing better, despite very dissimilar results, the outcomes are more or less the same. So where do you think?
Actually, madam, that is the thing. I have not left my love for clomiphene citrate. We have been having so many successful pregnancies over the years. So we were looking for something convincing that this would give us some answers, but that is not given us. And most of my publications have been on clomiphene citrate. So I wanted to find something here. I would go on to do receptor studies for letrozole.
That's what I was coming to. That you still have a long way to find out the actual. Yeah.
Yes.
Okay.
So global data is also, there are only 3 meta-analyses published till now.
Dr. Susni, any other judges wanted to ask something? I can't see the judges anymore.
Ma'am, the meta-analysis, there is only one Chinese meta-analysis, then this is the 2019 meta-analysis, and one by Legro in 2014. The Chinese meta-analysis is not holding good quality. So even if we say letrozole we have a lot of studies, we don't have, and from India, we don't have at all.
Any other questions? I can't see the judges anymore. Can't hear.
I would just like to say that maybe Dr. Shalini, you felt that in spite of there being improvement, that is compared to clomiphene, better blood flow with letrozole, still the results were the same, right?
Yes,
so maybe when we are comparing these two compounds, we are putting a little more importance than needed on the vascularity and the endometrial thickness. Because in spite of clomiphene often showing a thinner endometrium, the rate of miscarriages, the rate of conceptions, all are almost always comparable. Clomiphene with metformin is quite a good drug, I think.
Yes, ma'am. I agree, because that is what I
Our next presenter is Dr. Shweta.
Yes, ma'am.
Yeah. Eventually, you've been able to join us, Dr. Shweta. Welcome. You've been able to join us.
Thank you, ma'am. Sorry for the disturbance, ma'am. Good afternoon, respected seniors.
Ma'am, you have to do the slideshow, Dr. Shweta, before you start. Please do a slideshow.
Okay. Ma'am, is it visible, ma'am?
Yeah. Okay. No, not as yet.
Ma'am. Ma'am, can you start, ma'am?
Yeah, sure. Take it easy, Shweta. Take it easy. Be calm.
Okay, ma'am. Good afternoon, respected seniors. I'm Dr. Shweta, and today I'm presenting seminar PPT on the combination of letrozole and clomiphene citrate versus letrozole alone for the ovulation induction in a woman with polycystic ovarian syndrome, a randomized control trial.
Sorry, we can't see your
I'm not
presentation.
able to see your
We can't
slides.
see your presentation, Dr.
Yeah, please.
Ma'am, I
It
think
easy.
I have
Please
already.
first share your slides peacefully.
Yes, ma'am. Okay,
We'll
ma'am.
wait. We'll wait. Yeah.
Okay, ma'am.
You have the buttons below, to share your screen.
Yes, ma'am. Yes, ma'am. I'm sharing, ma'am.
Yeah.
Ma'am, for me it is showing, ma'am. Is it visible, ma'am?
No, we can see it now, but make it full screen then.
Yes, ma'am. Ma'am, is it visible, ma'am, now?
Yeah.
Yes. Okay, ma'am. Ma'am, can you start now?
Yeah, sure.
Yes, ma'am. Okay, ma'am. I'm presenting a paper of the combination of letrozole and clomiphene citrate versus letrozole alone for ovulation induction in a woman with polycystic ovarian syndrome, a randomized control trial.
Just click on the presentation once.
Coming to introduction, polycystic ovarian syndrome is one of the most common endocrinological disorder in a woman in reproductive age group with estimated incidence of 5 to 10%. Out of all the couples seeking treatment for infertility, 30% of the cases are due to anovulation, and it is estimated that 90% of the anovulatory cases are due to polycystic ovarian syndrome. Letrozole, a third-generation aromatase inhibitor, has been proposed as an ovulation induction agent, both as an alternative to clomiphene citrate as well as a secondary-line agent in the presence of clomiphene resistance. And in this study, my aim is to compare the clinical pregnancy rate in infertile women receiving ovulation induction with a combination of letrozole and clomiphene citrate versus women who is receiving only letrozole alone. The primary objective is to check the clinical pregnancy rate, and the secondary objectives are the ovulatory rate, ongoing pregnancy rate, and ovarian hyperstimulation syndrome. Material and methods. This study is conducted in the Department of Obstetrics and Gynecology in AIIMS Rishikesh for a duration of 18 months, and the type of study is prospective randomized control trial. The inclusion criteria includes women who between 20 to 35 years of age with polycystic ovarian syndrome according to Rotterdam's criteria, and female coming with primary and secondary infertility, infertile women with PCOS, BMI of less than 30 kg per meter square, and patients who are willing to participate in the study and follow up. Exclusion criteria: pregnancy, patient who are already on other drugs for treatment of PCOS like OC pills, other known causes of infertility such as endometriosis, unexplained infertility, moderate to severe male factor infertility, deranged kidney and liver function test, uncontrolled thyroid disorders, uncontrolled hyperprolactinemia, and medical conditions not well controlled and not recommended during pregnancy, like type 1, type 2 diabetes mellitus, hypertension, and hypothyroidism. Among the patients which are selected, then they can be randomized into two groups based on the computer-generated randomized table. And once the patients are randomized, then we will divide them into two groups. Group 1 includes ovulation induction with letrozole 2.5 mg once a day for 5 days, and associated with clomiphene citrate 50 micro mg once a day for 5 days. For during the day 3 to day 7 of the cycle for 4 cycles. And group 2 includes only for group 2 patients who used to give only letrozole 2.5 mg once a day for 5 days, day 3 to day 7 of the cycle for total of 4 cycles. And till now I have we found 40 patients with infertility with PCOS, and among the 40 patients we have excluded 8 patients because they're not they cannot be included, and the remaining 2 patients are not willing to participate. So there are 30 patients. Among them, 30 patients are randomized into group 1, which includes letrozole plus clomiphene citrate of 2.5 mg or 5 mg and CC of 50 mg. Group 2 includes letrozole 2.5 mg or 5 mg. In the group 1, there are 6 patients become pregnant, and in the group 2, there are 9 patients become pregnant. Results and discussion. Out of the 30 patients, 15 patients were allocated to letrozole plus clomiphene citrate group, and 15 were allocated to letrozole group. And results were analyzed according to the intention to treat principle. And women who received combination of letrozole and clomiphene citrate, there are 6 of them got pregnant. That is 40% of the female got pregnant. And women who received letrozole, 15 among the 15 patients, 9 of them got pregnant. That is 60% are got pregnant. And it is statistically significant with a p-value of 0.043. The mean age group in mean age in group 1 is 26.5 plus or minus 1.55, and mean age group in group T is 27 plus or minus 1.76. The ovulatory rate in group 1 is 10 out of the 15 patients, that is 67% got ovulation, and in group 2 there are 11 out of the 15 patients got ovulation, that is 73% are got ovulated. And I have found there is one case of multiple gestational pregnancy noted in letrozole group, and one case of ectopic pregnancy noted in letrozole with CC group. But there is no no significant side effect is noted in both the treatment groups. Discussion. I have seen one study which is done in Iowa, in University of Iowa College in Medicine, and they have concluded that, and according to them, they have concluded that letrozole plus clomiphene citrate have higher ovulation rate and pregnancy rate when compared to letrozole group, and they also didn't find much multiple gestational pregnancies or any side effects in between the two groups. And there is one more meta-analysis of letrozole versus clomiphene citrate in polycystic ovarian syndrome. It is done in the university in China, and they have concluded that there is no much significant advantage of letrozole over clomiphene citrate. Limitations of my study is the small sample size and fetal outcomes are not evaluated. Coming to conclusion, the letrozole alone was associated with a high pregnancy rate compared with combination of letrozole and clomiphene citrate in a woman with infertile PCOS. Further studies are needed to evaluate the effect of live birth rates and fetal outcomes. Thank you.
Dr. Shweta, I have only one question to ask since you are a PG student.
Yes,
and must have taken your statistics studies classes also.
Yes, ma'am.
What is the minimum number and what is the formula which is required to know if you have to know what is there is a significant calculation?
Ma'am,
your number is too small, but
actually,
at least you should know.
Actually, this is my ongoing thesis, ma'am.
Okay.
And because of this corona, actually the OPD is closed since last 8-9 months. I'm not able to get the patients.
It's okay. But what was the number which was actually calculated for your thesis also? Because to calculate the clinical significance, you will have to know what is the number.
Ma'am, minimum 100 cases are required, ma'am.
Okay. Okay. The second question is that I wanted you to tell me the justification. We know that whenever we use any drug, for whatever reasons, we should start with the minimum dose and, for minimum days. That's the principle of, any treatment. Then how do you justify that without even trying the, outcome of letrozole alone? What is the justification for using them in combination with clomiphene, especially when we know that the clomiphene has some disadvantages for which letrozole was chosen as a better ovulatory drug, and with similar drugs, with similar, almost we can say results rather in many studies better also. So what is the justification?
There are many studies which are showing that letrozole is better when compared to clomiphene citrate, ma'am. At the same time, there are some studies which are also showing that there is no added advantage of using letrozole compared to clomiphene citrate, ma'am. And in one study, I found that combination drugs are better when compared to the single drug, ma'am.
I'm asking for the justification. We know that there are certain disadvantages with clomiphene. That's why letrozole alone has been chosen as an ovulatory drug with almost similar or rather better results. But then what is the justification for combination of two? Unless you've seen that, with one drug, the patient was not getting any results. And instead of increasing the dose of letrozole, you thought, let's add another one.
Ma'am, in my study also, ma'am, first I have given 2.5 mg, ma'am, and for first cycle, and if she is not get pregnant, then the next cycle I'm increasing the dose, ma'am. That Like that way, I'm trying to give 4 cycles, ma'am.
Not for the combination. A combination, you are giving both the drugs without
Ma'am,
evaluating the impact of one drug first.
Ma'am, in combination also, ma'am, for letrozole, I'm increasing the dose, ma'am, but in clomiphene citrate, I'm giving only 50.
Madam is asking why you decided to go for 2 drugs and 1 drug. Why you opted? Because other studies were done like that. Is that why you decided to choose based on a parent study?
Ma'am, yes, ma'am, because of the I have seen so many studies, ma'am. So, with the comparing with the parent study, I have and my guide has advised to do this, ma'am.
Any other questions from other judges? Are we wind up? Thank you, Shweta.
Thank you, ma'am.
Thank you, moderators, Shanu, for
thank you so much, ma'am,
for being very patient and still carrying
and
out this show
one
very
more
well.
request, ma'am, as we're going to wind up and make the scores. So could you please send a screenshot of your results ASAP, either to Dr.
On your
Monica
WhatsApp?
or to me?
On your
ma'am,
WhatsApp?
yeah.
I'll just be sending it.
Yeah.
Thank you,
Thank you
Shanu.
so much, everyone.
Thank you, other judges. It was nice meeting all of you. Thank you. Thank you, ma'am.
Please give me a moment to thank you all, Alka, Monica, Shanu, and all the presenters, Deepika. I can see Aswati. Thank you all for being there and participating in the conference.
Thank you, ma'am, for
the opportunity, ma'am.
giving us
Thank
this
you so much.
opportunity.
A very good afternoon, everyone. I'm Dr. Soumya Prasad, and on behalf of Fertivision 2020, I welcome all delegates and faculty for the first virtual Global Congress of Indian Fertility Society. We will begin our afternoon session with today's first keynote oration, for which I invite our Honorable Chairpersons, Dr. Sudha Prasad, Dr. Firoza Parekh, and Dr. Deepak Modi. Dr. Sudha Prasad, Madam is President, Indian Fertility Society, Organizing Chairperson, Fertivision 2020, and Director of Matritva Advanced IVF and Training Center, Delhi. Dr. Firoza Parekh is Director of Department of Assisted Reproduction and Genetics, Jaslok Hospital and Research Center, Mumbai. And Dr. Deepak Modi is Scientist at National Institute for Research in Reproductive Health, Mumbai. I request Dr. Sudha Prasad to kindly invite Dr. Jane Stewart. Over to you, ma'am.
Thank you, Soumya. Good afternoon to all of you. Today's first oration is from none other than Dr. Jane Stewart. Dr. Jane Stewart is the consultant in reproductive medicine and gynecology based in United Kingdom, head of department Newcastle Hospital, NHS Foundation Trust, and she is the chair of British Fertility Society. Her topic of oration is on mitochondrial PGD. We all are eagerly waiting for your oration, Dr. Jain. Please, dais is yours. Thank you.
Thank you very much. And I would like to extend a welcome from the British Fertility Society. We had a collaborative session yesterday, which I think went very well, and I hope will be the start of a long-going relationship. I'd also like to thank you very much for the honour of being invited to speak again. How's it gone? Please. So we'll skip over this because you've given me such a nice welcome already. You don't really need to talk to me about me very much. But the subject of my talk this morning is mitochondrial PGD. And you very kindly asked me to speak last year about the mitochondrial program, but I felt that it would be interesting this time to expand a little bit more about the pre-implantation genetic diagnosis program, which is a successful program and fits the bill for many couples in this situation where they're considering avoiding passing on mitochondrial disease to their offspring. And it's a program that we've been running for some time. So mitochondrial PGD, I'm going to talk a little bit about mitochondrial function. I'm going to talk a little bit about disease origins and the inheritance of mitochondrial mutations, some of the reproductive challenges faced by people who suffer from these disorders, the options available to them, and specifically more about our program of PGD or pre-implantation genetic testing. So this is the mitochondrial genome. It's double-stranded circular molecule. It's found in numbers in all cells, of course, within the mitochondria. It encodes 37 genes. It's not a huge amount of DNA, but critically there are 13 polypeptides or protein structures coded by this small thing that has of great importance to health and well-being. You're probably all aware that mitochondria are in all eukaryotic cells, all those then anyway that don't photosynthesize, so not plants, but in everybody else, everything else. It probably turned up in our cells 1.5 billion years ago from some form of proteobacteria that was engulfed and then was found to be useful to that structure in generating energy. And primarily mitochondria generate ATP, providing energy then for all of the big things that go on in cells, not just for movement and function, but for configuring big proteins, transmembrane potentials, and obviously therefore for a whole lot of cellular function in addition. Most of the functional genes that came from that proteobacteria however long ago have actually over time transferred into our nuclear chromosomes. So many of the proteins that are involved in energy production actually are still controlled by the nuclear chromosomes. But those 13 polypeptides, those 13 proteins, are all central hydrophobic components of the respiratory chain pathway. They form structures within those complexes, which mean that they are absolutely critical to energy production. And notably, mitochondrial ribosomes that do that protein production are all membrane bound because the products then are immediately embedded in the inner membrane of the mitochondria in order to function. So they're key components. This diagram just then covers the sort of structures there, and you can see that they're involved in all of the complexes that are involved in the citric acid cycle. So what about inheritance? Well, I've shown this slide before. It's a well-known slide. What we know is that the mitochondria that are in all of our cells are derived from our mothers. It's a maternal inheritance process. Although sperm have mitochondria, of course they do. They need them to get to the egg to do the fertilization process. They are specifically destroyed following fertilization, and consequently the resulting zygote and the resulting embryo contains mitochondria solely from the maternal line. And that's an important factor when you're thinking about inheritance and indeed about avoiding mitochondrial disease. There are hundreds of thousands of copies per egg. But mutations within those copies are common. There's probably a large number of people that go around with a very small level of mutations within the proteins or within the coding of the genome. They don't all turn into pathological problems. But there's a significant proportion of mutations that actually then will cause pathology. And it's believed that about 1 in 1,000 of the clinical phenotypes result from mitochondrial DNA mutations as opposed to nuclear DNA mutations. Just to put this in the real world, this is a photograph taken from a newspaper cutting from the East Anglian Daily Times, East Anglia being in the very southeast of England. It's a local paper, but this was a little boy who died in November of mitochondrial disease. And I think it's just really, I put it there to highlight that there's a very human problem here, although it may be relatively rare. People suffer greatly from mitochondrial disease when it happens to them. And this was a family who have a Facebook page that's chronicled the whole process of diagnosis right the way through to this child's sad death last month, and then wanted it to go into the papers in order to highlight this problem for people elsewhere because it's so little known. So what is the issue? Well, if you have no mutations, then your mitochondria in your cells, these are cells, the mitochondria are represented by the coloured blobs. If you are homoplasmic for wild type, then there's no issue. You pass on homoplasmic wild type mitochondria wherever you go. If you are homoplasmic for a mutation, in other words, every single mitochondrion carries that mutation, and that does occur in some mitochondrial disease, you will pass that on to every egg and therefore every offspring. Many of those homoplasmic conditions, because they are homoplasmic are relatively mild, they're compatible with survival, but they can cause quite significant problems for older children, for adults. And so, for instance, a very common one is a condition called LON, Leber's hereditary optic neuropathy, where people who are affected by it, and not everybody is, but if you're homoplasmic for this mutation, then you are at risk of developing early onset significant blindness. And that's a huge burden to carry for the rest of your life, but it is a risk in carrying that mutation on a homoplasmic level. The ones in the middle are those people who are heteroplasmic. So there's a term describing how those mutations are then transferred into eggs. So during egg generation, the mitochondria do not segregate in a uniform fashion, although they're effectively randomly segregating. There is a bottleneck process described in that process, which means that for a woman who carries a mutation, her eggs may not carry the same average level of mutation as she does in her tissues. And therefore she may have some eggs that carry very few, denoted by the red with one black blob, or some eggs that carry very many, denoted with the egg there with lots of black blobs and one normal one. And so it is a little like Russian roulette, because you do not know which of those eggs is going to create the zygote that's going to make your baby, and therefore you do not know how badly affected that child might be. And in general terms, the higher the level of mutation in some of these conditions, the worse the phenotype will be. And so it's a really tricky problem, particularly in families where there's no diagnosis been made yet, because they may have a child with a problem and that's the first they know of it, having had no family history at all, because nobody in the family thus far has had that level of mutation. So the reproductive consequences in this setting are that if you're homoplasmic, as I've already described, the mother will be 100% or near 100% mutation load, and all of her offspring will be. It doesn't matter about the father's contribution because his mitochondrial don't add anything, as we've said. But for one of those children, they may develop early onset blindness, but they've already had a second child by then, so there's no idea whether or not that child will be affected, but actually that second child may have no symptoms for their whole lifetime. So it's an incredibly difficult thing to try to predict for people, even in the homoplasmic group, because of the way that the diseases are displayed. But with the heteroplasmic group, it becomes, as I've said already, even more difficult, because whilst you might understand that the mother carries a load of mutation, depending on the distribution in her eggs, different offspring will have a different mitochondrial load of abnormal mitochondria, and they will be affected differently. So this family here is not atypical. A mother with a modest load who may know nothing about it, who has a child with a high load who dies at a young age, and it's diagnosed at that point, and she then might already have a second child by then, who may or may not be affected in this particular family. Probably not, because the daughter carries a very low load. You couldn't predict that, but because she does, is unlikely to be affected, but does need to contemplate what that might mean for her reproductive future. So family history is complicated, but it is also true to say that it's often the first child that precipitates the diagnosis in a family, which of course is heartbreaking when you're dealing with a child as ill as Charlie was. Because mitochondria are in every cell, if there's a significant mutation in your ability to produce energy in every cell, then there are a huge range of things that can be affected. And this is just really to illustrate that principle. There are a number of phenotypes, there are a huge number of mitochondrial conditions, but they can all vary slightly over time, but there are some distributions that are recognized and then recognized by OMIM number. Many of these may be produced also by nuclear gene discrepancies, but also by mitochondrial genome mutations. Lee syndrome is the condition that Charlie died of. Many Lee syndromes do not come from a mitochondrial mutation, but there are some very typical ones that will cause Lee syndrome. And Lee syndrome is a particularly severe type of mitochondrial disease. It causes severe neurological disease. It's a neurodegenerative process. It's often early onset, usually evident in the first 1 to 2 years of life. But the symptoms that displayed at that stage are often non-specific. So you may have a child that doesn't feed well, failure to thrive, might be a bit floppy, and then becomes later, has other neurological issues, dystonia and ataxias, but notably often lose previously acquired skills. Other things will come on top of that that help to make diagnoses later, but the diagnosis is often delayed because they're non-specific symptoms. It takes time for people to clock on that this might actually be part of the problem. In order to make the diagnosis, then identifying a mutation obviously is a helpful thing to do. As I've said already, most of them are a nuclear chromosome related, autosomal recessive or X-linked disorders. But there are over 33 mitochondrial DNA mutations that have been linked to the Leigh syndrome phenotype. So in women that carry mitochondrial mutations, it's not an unknown phenomenon. The key thing about mitochondrial disease is that there really are no effective treatments. There are lots of things to try to ameliorate symptoms, to manage conditions, but no effective treatments to reverse the changes that occur with mitochondrial disease. If you look at the Cochrane reviews, there's lots and lots and lots and lots of reviews of things, of people trying to do things, but no actual genuine treatments. I showed this picture of Casper last year when we were talking about mitochondrial disease. He's a little boy who died at just a few months old with Leigh syndrome. He had a greater than 98% mutation load. He was the first child in a family that was affected. Nobody knew anything about the mitochondrial disease in this family when he was born, but his diagnosis was made. He had the 3688 mutation, which relates to a protein in the complex 1 of the citric acid cycle, and consequently has a huge effect on his ability to produce energy throughout his cells, throughout his body, or did, and clearly it was not at that level of mutation really compatible with successful life, and sadly he died of that disorder. Another family who put that story in the public domain deliberately in order to raise awareness. So what are the reproductive options for families in this setting? Well, they can take a chance. They can conceive and have chorovilus sampling, and you can look for the mutation load in central tissue and consider a termination of pregnancy. You've got to know about the diagnosis, of course, beforehand, but that would be the same for anything else. Egg donation is an option to remove the genetics entirely, and it's certainly an option that some people might take up if they're not suitable for other things. I'm not today going to talk about the mitochondrial donation program. I spoke about that at length last time. It's a slow program and with small numbers, and so I have a little more to say on that, but I am going to explain more about the PGTA, the PGD program. With obviously the potential for being childless or adopting and fostering, and many of our patients have waited to think about family because they didn't want to go down the route of taking a chance. So they've waited until there was an ART related option available to them and are coming forward now. Sadly, coming forward at older ages, which makes it sometimes harder to treat them, of course, which is why egg donation then becomes something that they might then consider. For some of these couples, the risks aren't that high in terms of the risk of passing on a significant load of mutation. If the woman's not badly affected, she doesn't have a high load, she may not have a high risk of passing on a high load to children, but it's a high stake risk to take, because if you get that wrong, then you have a child who is significantly disabled potentially. We all know about PGD or PGTA. The process of it is an IVF process. You stimulate the ovaries, you collect the eggs, you do ICSI, you develop your embryos, you biopsy them, you select your best embryos that aren't affected, and you transfer an embryo, hopefully, to give a good chance of success. The key thing in assessing embryos for mitochondrial mutation is that it's not an all or nothing thing. We're not looking at, is the cystic fibrosis gene there in a double whammy or is it not? What we're looking for is the proportion of abnormal mitochondria within the cell that we biopsy. We still biopsy on day 3 for mitochondrial disease because that's very representative and probably less skewed in the day 3 embryo in a single cell than to try to take trophoblast, although there is obviously work going on to see whether we can change that in future to make it a little easier. But the single cell biopsy is what we currently do. And we know from research that represents all of those cells at that stage. But then the discussion with patients has to be, well, we have these embryos, these are blasts, they've grown onto blastocysts while we've been getting the diagnostic information. We've got these good quality embryos, but these are the loads within these embryos. And there has to be a counselling session, if you like, at the time of embryo transfer, when we have the transfer nurse, we have myself as the fertility specialist, we have the genetic specialist or mitochondrial specialist, and the embryologist all sitting in a room with the patients to discuss actually which is the most appropriate embryo to put back, if indeed there is one, and what that might mean for them for future. Obviously, if we have spare embryos to freeze, then we will do so. As a rule of thumb, if you're looking at mutation levels, if there is no mutation in an embryo, there is no risk, obviously, of developing mitochondrial disease. And our clinical laboratories are able to test to a very small level, so they can give a 0% pretty much. But if there's less than a 30% mutation level, then it's likely that the lifetime risk of whatever disorder it is will be extremely low. So we use that as a rule of thumb kind of threshold. However, it does depend on the load, the disease, the family history as well. So there is some nuance to add to that, which is why it's really important that we have the specialist with us as well, mitochondrial specialist with us. If you have a high level of mutation, there's a very high risk of severe disease, of course. There are reported series with modest success rate. Niche area, but 22 couples for 12 mutations, which I've listed on the right there. The maternal mutation load within that has been anything from 0 to 85% with varying symptoms. So some women are completely asymptomatic and others have quite significant symptoms, which of course has an impact on how we conduct their treatment as well, because we have to be careful with them for pregnancy and the effects of pregnancy on their condition, but also from the point of view of what we're doing treatment-wise. 10 of those couples had seriously affected children before we met them. We've undertaken 29 fresh cycles and 4 frozen cycles. In 6 of those cycles, we didn't replace embryos because the embryos that were available for transfer all had a high load. We had 1 couple where no eggs were collected. 5 of those couples have had 2 fresh cycles, one's had a 3rd fresh cycle, but in 4 of them, it's quite clear that it's not worthwhile carrying on with PGD because we're not seeing any low load embryos amongst the cohorts to make it a worthwhile thing to process. Those are couples who then might go on to have egg donation if they only had very few eggs or embryos, or indeed may go on to the mitochondrial replacement program. So just to give you a kind of example of the spreads that we see, that each of the little blue blobs represent embryos and the mutational load within those embryos. And these are, I'm going to show you 3 graphs, 3 of the commonest mutations that we have tested for. And you can see the spread in those. If you can read there's 5 patients represented in the bottom, but each of their cycles. So patient 1 has 2 cycles, patient 2 had 3 cycles. But you can see the spread of the mutational load in that, and therefore the complexity of making choices. Of those cycles, patient 5 had a successful pregnancy. You can see she had a very low load right across her embryos, which is really, really interesting. Of their embryos, and you can't predict that before you start, but that allows us to give these couples really useful information about their ongoing prospects. So for patient 1 and 2, there's no point in us proceeding to more PGD because we're not going to get a low load embryo. If you go down to on with the other ones, then with those couples, it is worthwhile pursuing further. Of course, patient 3 had a pregnancy in her 2nd cycle. And this is just another complete spread right across the board, which just again represents what we're seeing and the complexity of decision making that goes on. So 7 babies. The mutational load in the embryos of the total embryos from which those babies were derived, you can see. So if you look at the 4th one down, a complete range from 1 to 96%. That's absolutely a useful cycle of treatment. And don't necessarily represent what we've got in the embryo load, but you can see the couple at the bottom. The woman had a very low load. Her embryos were all very low. Some of these couples had quite high, highly badly affected children already. So from the treatment outcome, we've had 6 healthy pregnancies of babies and a sibling from a frozen cycle, a couple of miscarriages. Interestingly, also 2 later natural pregnancies, and those are important. And if I go back to that previous slide, if you look at the bottom one, you can see that particular individual has a low load, had across the board very low load embryos, and it would not be inappropriate to consider conceiving naturally. And that's happened certainly with one of our couples, in fact, Casper's mother, who had a daughter following on from PGD with a very low load, but understanding that her overall egg load was low, went on then to have a 3rd child who was not badly affected, albeit it was a low risk and high stakes. She opted to take that and got away with it. Another couple who had a similar pattern but didn't conceive with treatment then went on and had a successful pregnancy without help. So we learned things that allowed them to take chances at a later stage that perhaps were less risky. So overall, quite a decent live birth rate per embryo transfer or per egg retrieval, which is important obviously when people start the programme, but not everybody's had the whole process, of course. So the success rates in otherwise fertile patients are limited. If you tried to conceive, or if those couples tried to conceive, most of them probably would do so without any problem at all. It involves getting into complex problem, but it reduces the risk of having an affected child. But there are no guarantees. It is not Mendelian distribution, so you can't predict what you're going to get from your embryos, and consequently for some people they're disappointed because they might have a lot of embryos but only 1 or 2 that have a low load, and those embryos may not be good enough quality to replace. So we may try again for those couples and they may be lucky the next time, but obviously bring down the chances then. There is a balance between quality and load. They'd still offer prenatal diagnosis, although to my knowledge nobody's taken us up on that. Does it work? Well, 50% of those children, of those couples already had an affected child. 27% of those couples now have a healthy child. So I think, yes, it does in the right setting. I'm just finishing. It's not suitable. Eliminate the risk for the next generation, and some patients don't want to go down that route. I'll skip over that. Just by way of acknowledgements, these are all the various people that have been involved in setting up the programme over years. And I would like to thank you all for your attention, but also to wish you all the best for the festive season, at least over here. It's not snowing quite yet here, but it might yet. Thank you very much.
So there are 3 types of teachers. One who teaches and expects the children to do their homework and then gives a test, and about 50% get a grade A. Then there's a very good teacher who knows her stuff, and when she gives a test, 70% of the students get a grade A. But Dr. Stewart, with this lecture, all your students have got a grade A and all have done excellent. That is the nuance of a good
I hope so, thank you.
And not only have we thoroughly enjoyed the talk, but we have learned so much, because there are so many nuances in this particular disease that it's not that you do A plus B and get C. You may sometimes get a Y or a Z. So thank you very much. We are much enlightened, and we really express our gratitude to you for taking your time on a Sunday afternoon, Sunday morning, and spending it with us.
Thank you very much. It's been a real privilege.
Thank you, Professor Jain, and it was wonderful to listen to you. And I was just looking up that what's the incidence of mitochondrial diseases in India, and to my surprise, we have no clue. I mean, India is 17% of the world population, 1 in 8,000 is a huge number for India, but we have no idea what are the kind of prevalence of mutations. So I think it's time that we as Fertility Society must start at least looking for these, and with now the technologies available and the proof of concept there, that these diseases can be diagnosed and prevented from families. I think it's a wonderful thing that you have done, and congratulations for this, and thank you for spending your day with us. Thank you so much.
Thank you so much.
Thank you, Dr. Stewart. It was a wonderful oration to give us the insight of this mitochondrial PGD. Definitely, the parents who are really having the suffering of this mitochondrial disease will be benefited. And it will take, of course, the long time to reach to India, but definitely we will keep on tracking this point. Thank you so much for with us.
You're very welcome. Thank you so much. Enjoy the rest of all of your conference.
Thank you, Dr. Stewart, for the very exhilarating talk, and I thank our chairpersons for moderating this session. Now we would move to our next session, for which I invite Dr. Pancham Preet. Over to you, Dr. Pancham.
Thank you, Soumya. So coming on to the next session, I would let's learn some more pearls of wisdom from the stalwarts in the field. I would like to invite chairpersons for the session, Dr. Anupama Bahadur. Who doesn't know her, has a keen interest in infertility and an additional professor at Department of Obs and Gynae at AIIMS Rishikesh. I welcome you, ma'am. Dr. Ritu Jain, who is a laparoscopic surgeon and infertility specialist and a director at Vardhaman IVF Center, Gurgaon. And Dr. Anshul Agarwal, who is a senior consultant, BLK Super Speciality Hospital. I welcome all the esteemed chairpersons. I would request you to please take over the session and invite the speakers.
Thank you so much, Dr. Pancham Preet. It's my privilege to chair this session along with Dr. Ritu Jain and Dr. Achal. We would like to invite our first speaker, Dr. Yadav Ji, who is a consultant subspecialist, reproductive medicine and surgery, Deputy Clinical Director, Birmingham Women's Hospital, Honorary Senior Lecturer, University of Birmingham. So we would like to hear your views on the subject on improving quality while reducing cost of healthcare.
Thank you very much, and thank you for inviting me. The best part of presenting at this time is everybody's very attentive following Jane's excellent talk, and they're waiting for again eminent speaker Raj and other colleagues. So it's great that people are listening, and I hope will listen. This is a very offbeat or something totally different topic to the fertility and to the science. I'm talking more on the business side, and thus
switch on your video.
Sorry, video. I will check that. I don't know why it is gone. Okay. Okay. Yeah. Sorry. Thank you. So today we are going to discuss on the more on the business side, and thus the aim of this talk is improving quality while reducing the cost of healthcare. It's as I said, it's a topic outside the fertility, but it is important, and we will discuss why it is important and how doctors could be trained or adopt the knowledge and the science and theories in the business. So, and then I will present my study, and then we will discuss the take-home message. As I said, it's not as exciting as Jane's or upcoming talks, as we all are very keen to learn the science, but that's the point of this talk. When we start talking about doctors as managers, we always start thinking, oh my God, now I'm learning clinical skills, research, cutting-edge technologies. We have skills and experience, but then again, bureaucracy, protocol, etc., are pulling us back. But it's a reality of life. And I will discuss in terms of, because the privatization of the healthcare system in the UK, in India, and even in the UK, we need to save the cost to give the best quality to the patients. So it doesn't matter where the money is coming from, the public sector or where the money is coming from the privately or self-pay patients. They are funding their treatment. It is important to start thinking on how we could give the best possible care at the least cost to our patients. And that's the whole idea. But when we talk about doctors as the managers, as I said earlier, that we are very good following research evidence. We get excited to see anything new coming up in the science, in the surgeries. We want to always upgrade our skills in laparoscopies, in minimal invasive surgeries. We know the complexity in our field very well. But when it comes to the management, when it comes to the finance, we hate that. we love to outsource that. We want to hire somebody else, or the organization always want to hire somebody else, and then there is a gap between the communication. The professional managers don't understand the complexity in the medicine, and we as doctors don't understand the complexity in the business and finance. We are very good in following evidence-based theories and science in our practice, but we don't know any theories in finance, and we don't know any theories in the business or the concept that we want to follow. So we run it pretty much as ad hoc basis. And not many conferences and our webinars covers the business aspect of the medicine or the healthcare for doctors. There are no debates, no discussions, and thank you for IFS for giving me this topic to discuss in this particular Congress. So when we compare, and I'm aware of the fundamental differences in the UK private and public sector versus Indian private and public sector, but when we particularly compare the fertility field, the UK has 65% of funding coming from the private. Even if this clinic is the NHS one, the patients pay for the treatment, and that's the 65% of time. But when we compare that to the Indian business sector, again, it's quite same. 68% of people pay themselves for their treatment. So when I compare the fertility sector in the UK versus Indian whole healthcare system, they have quite similarities. I mean, it's only 3% difference in 3% of more people pay in India for their healthcare. So that's where I'm coming from. So what I'm going to discuss here make much more relevance to UK fertility sector, or even in the UK National Healthcare Service, plus the Indian healthcare sector. Future of Indian market. Indian healthcare market is going to be 372 billions by 2022. So there is a very strong demand. There is a rising manpower. The number of Indian doctors, I mean, it's in India, but even in the worldwide, there are so many doctors. So we have a very high skill set. We have very strong demand, and that leads to very attractive opportunities. The questions my colleague asked me, do you think that doctors could be the best business leaders? And my answer to that is yes, because by default, in every country, the doctors or the medical professionals are the cream of the society or the cream of the students. They choose to enter in this field. So they are highly motivated, they are enthusiastic, they are keen to learn, they are patient focused. But the problem is we hardly discuss the business in medical school. There is always a taboo that when the doctors talk about a business, it's always related to the money making or gives some form of ethical or moral questioning on that doctor's intention. But the point here is, unless we start thinking of a business, run like a business, improve the cost and improve the quality, then only we can give the better deals to our patients in terms of having more resources at affordable costs. And I have quoted these two US studies where high-performing hospitals in United States are led by the physicians and not by the professional managers. So I'll start with discussing my study. So this study was done as a part of my MBA dissertation at Leicester University. And we started with, we all know that there are financial constraints, let it be private sector, let it be public sector. We always have the financial constraints. But on the contrary, there are technological advances and the resource consumption is on rise. And patients are expecting high quality. So it's a paradox. We are getting newer technologies which are very high cost. Patients want high quality at the cheaper cost. And that's the constraint, that's the stress for every managers or the leaders in the healthcare sector to meet that demand. So with this, we started with the research question then, what is the relationship between cost and quality within the healthcare? How the efficiency or any other dimensions affect that quality? Does cost saving affect the patient safety? Because that's again, everybody started getting feared. Oh, managers want to cut the cost. That will affect our patient safety and the quality of care. And does cost saving affect the patient experience? Again, safety is one aspect. Patient experience is one aspect. Clearly, all we doctors keep patient safety as a top priority, but it's not just about safety. And when we talk about fertility, it also comes to the patient experience, or any for that matter, any surgery patient go, they need to have the great patient experience that they feel that they have been looked after, irrespective of the outcome. But again, everything has a cost. So with this study, we analyzed 5-year data at the University Hospital Leicester, which is a NHS public funded trust and a public funded hospital, a big teaching hospital with a millions of budget. And we studied all the variables. So we studied how much cost the hospital saved, and what were the effect on the patient safety, satisfaction, and clinical efficiency. And the main outcome measures were financial savings and the quality domains. So when we start about the quality, the problem in healthcare is it's not as straightforward. So yes, quality word is very good, but how we analyze or assess the quality. So these are the different domains of the quality. There are different institutes. So institute in USA has certain domains explained. NHS next stage review, that was a review set by the government of United Kingdom, and they have discussed the first 3 as a top quality domains. CQC, that's the Care Quality Commission of UK, which governs, regulates all the healthcare practice in the UK. They have set the safety, experience, and the value for money as a key domains in their documents. So in our study, then we just combined all these domains together to define a quality, and we kept the value of money or the cost as the variable domain. And this is the conceptual framework. So basically, as I said earlier, that the relationship between quality and cost is a complex. If we need certain amount of money to be spent to achieve the desired quality, in business term, that's called as the cost of the quality. But above and beyond that cost of quality, improvement in quality helps us to drop the cost. And this is how this complexity works. So I have divided this into 3 key domains: clinical effectiveness, patient safety, and patient experience. And obviously, all these things we all know leads to the reputation of the hospital, reputation of that particular clinic. So the goal, without a method, is nonsense. We all have the goal of having the best quality for our patient, but we need to have a method. We need to think through each process, how we achieve this goal, and how we achieve this goal at limited resources. So these are the key examples that how we could assess the safety, experience, efficiency, and leadership domains in the healthcare. Obviously, the list could be very long, and list is more specific to different areas in the healthcare. So I'm working in Women's Hospital, and we are Women's and Children's Trust. And when now we want to have the domains, and we are extending this work to the Women's Hospital to actually take it into the practice, the complexity I'm facing right now is having the different outcome measures for different specialties. Pediatric heart surgery has a completely different domains than the fertility or gynecology I'm working in. But it could be done. It could be done with a dialogue with the respective clinicians, that what is their safety that they want to achieve, what the experience they wish their patient to have. And we have also come up with the patient reported outcome measures. That means sometimes it might be relevant for us that we think that's the good outcome for the patients, but absolutely patient might be thinking something different. So for example, prolapse surgery, we need to ask a patient, is this acceptable outcome for them? Or is it the best outcome for them? Or is it the bad outcome than they expected? And this could be built into as a patient reported outcome measures. But without going into much complexity, first the starting point could be from the hospital side. So in this particular study, we used all the data we collect for the CQC inspections, for the hospital's annual reports, and we used those data. In my study, I did not use any patient-reported outcome measures apart from their friends and family test. Friends and family test in the UK is the test that we ask patient, are they happy to refer their friends or family member to us? And answer is very simple if they say yes or if they say no. So that's the friends and family test. I mean, there are other questions as well, but just to simplify, this is the key questions we ask. So the quality metrics, again, all these key performance indicators, we are very good again in the field of fertility, and that's why I think the fertility specialist could be the better business leaders, because we have the quality and key performance indicators inbuilt in our day-to-day practice. So all these KPIs we need to collect and then feed that into the quality domains, as I said, into 3 domains: safety, experience, and the efficiency. And then that can feed in from gynecology. As I said, this is the one of the slide I use for my presentation at Trust Board here. So from all these different departments, all these quality domains would be fed to the board's bigger quality domains. So once you go on the system, and if anyone in the world want to see what quality we're offering at Birmingham Women's Hospital, you could, and what patient safety we're offering, you just go on the drop down, click one by one, and then you could even break it down to what is the success rate of prolapse surgery at Women's Hospital versus what is the success rate of, or what is the OHSS rate of Birmingham Women's Fertility Center. So so this mechanism, you're feeding all these KPIs and domains into the big system, and then in the IT system, and then you could always dissect that down. So you have very focused area where you could focus on improving the quality, or if you need to do extra work. So the question is, does this save the cost? Does that help us? So with my study, we find a statistical significant relationship between these domains. So that's the good starting point. They are significantly related to each other statistically. It is suggested that costs saved by the unit vary due to clinical efficiency. So if any department or any area, our efficiency has gone down, the cost saved gone down. Again, no brainer. We all know if I'm efficient, I'm saving more cost. But it is very significant because it's affected 87.4% of the variation in the cost is just with the clinical efficiency. So if you correct the efficiency, you could correct a lot of cost saved. I mean, we all know, I mean, why we're using this webinar on online, because that has improved efficiency. IT improved efficiency. The past communication systems improved the efficiency. But this is what we need to think through the whole processes, that it could be the solution could be IT, solution could be in the infrastructure, solution could be just moving one clinic room to other clinic room to improve the flow, and solution could be to avoid the repetition of the task. 10 people writing the same notes and having the same lab forms, and then wasting the resources, human hour resources or the paper resources or any other resources doing the same task. So these are just the representative examples that could tell us that how we could improve the efficiency. So the cost saved in our study was 5 million per year. So it's a very good sum of money for one women's division in the UHL, University Hospital Leicester, to save. After a trade-off value, an improvement in the quality will result in reduce the cost. And again, this is very important for us to tell the managers, if we have anyone else as a manager, that after that, we need to have a certain cost of the quality. We need to have certain investment to give the best quality to the patient. But after improvement in the per unit improvement in the quality, we start dropping the cost required for same amount of work we are doing. That's where the efficiency comes in. Patient safety and experience is also positively related to clinical efficiency. So it doesn't mean that we are efficient means we are cutting corners, we are providing bad service to the patients, or patient's experience is getting compromised. So we checked all the safety domains and the experience domain as the standard indicators in the study. So what is the take-home message? Healthcare is better led by the leadership and management trained doctor, and I believe that, and I have huge respect for the other managers and the executives, and they are very good in their job. But my point here is not to replace them completely, but to have some form of understanding, some doctors being a bridge between the managements or the clinicians, not just doctors, embryologists, nurses, could be on the same road. And when I say doctors, forgive me, it's also all the clinicians or the people who are more patient-centric. They could be the best bridge between these two, because we know what exact the outcome measures we should be counting, or what are the relevant outcome measures for healthcare. We are patient-centric and patient-focused, so we will never compromise on safety and the patient experience when we are making any business plans. But it is equally important for us to understand the business concept, business theories, spend some time on that, and understand the efficiency and reflecting on how we could improve the efficiency. More you give of yourself, the more you receive. And this is what we all are doing with the conferences. So I have come up with these 4 P's to focus on. People, that's very key in the healthcare sector because we are a service industry. Partnerships, again, one unit, one hospital, one healthcare trust in the UK, or any one person cannot do everything without having a meaningful and collaborative partnerships. Processes are very important, and performance at each stage is again important. And reflecting on that performance, going back again, changing something, and coming back again to assess the performance, thus the cycle is important. So that's how I will explain this as one of the method. Obviously, this is not extension. There are big theories on the how to manage the strategies. There are big theories in the management modules, and management itself is a science. But we could adopt certain key concepts. So I would like to finish on the note, greed, for a lack of better word, is good. Greed for excellence, greed for patient safety, greed for patient experience, greed for quality and improvement in quality is good. Thank you.
Thank you, Dr. Yadav. That was a brilliant deliberation. I have just one question to ask. So as clinicians, as doctors, should we go in for an MBA as well?
Okay, it's a good question. So not all doctors can do the MBAs. And again, if all doctors do the MBA, then we need doctors to work on the ground as well. So we need to find a niche. We need to find the area of interest. As we discussed in our last talk, we all cannot do the mitochondrial donation program, and we do not have any aim of setting mitochondrial donation program. I mean, Newcastle is doing brilliant. So if I get a patient, I will send it to Jen. And this is how we need to have the teams. As we have teams of experts in every much each area, you go to Bombay and you name who is the topmost this or top 10. We have the names in our head, but those names are in our field. So if you say who is the best laparoscopic surgeon, who is best in the vaginal non-distant vaginal hysterectomies, who is the best in hysteroscopies, but equally we need to have, or within even team, that we need to have certain expertise to develop into the business. Again, if we are working in the part of bigger organization, it's better to nurture somebody's interest on that line so that could be the bridge. So even in my time, I can't spend all my time on the management and leadership activities, but at least we could have that meaningful dialogue or the debates and the discussions with the managers. But the MBAs in the doctors is very on rise, and in US, in UK it's still not very much. In India, again, I didn't get any statistics. I tried to search yesterday, but that's something to be. At least for the trainees or the newer generation coming in, it could be one of the opportunity to go in.
I request the questions to be just at the end of the session, if possible.
Mm-hmm.
Thank you, sir. It was a great talk. So I would invite the next chairperson to introduce the next speaker, please.
Good evening, friends. I have the honor to invite Dr. Raj Mathur, who is Clinical Lead for Reproductive Medicine at Manchester University Hospitals NHS Foundation Trust, Senior Fertility Consultant at St. Mary Hospital in Manchester. He's going to speak on very important topic, the clinical application of GnRH agonist trigger, safety and efficacy. We all have witnessed the paradigm shift to antagonist cycles, And here comes the role of GnRH agonist trigger. So we have Dr. Raj Mathur to elaborate on the subject. Dr. Raj Mathur, please.
Thank you very much. Let me try and share my screen. Can you all see my screen?
Yes, sir.
Thank you. So it gives me great pleasure to be delivering this talk. Fertivision is one of the events of the year that we all look forward to, and it's a real pleasure and an honor to be asked to speak today. I will start with a declaration of my interests, my conflicts of interest. I'm going to talk about GnRH agonist trigger by covering the following areas. A little bit about gonadotropin physiology at mid-cycle. Most of this will just be a reminder to you all who I'm sure are familiar with this. We'll then go through the pharmacological options that we have available for final follicular maturation. And then I'll focus a bit more on the agonist trigger, talking about specific indications for it, what are the risks and problems associated with agonist trigger, and finally some practical clinical questions such as how do you choose a patient, how do you monitor effectiveness, and quite importantly, should you do fresh transfer or freeze all when you administer an agonist trigger. So we know that in terms of physiology that GnRH is produced by neurons in the hypothalamus. These release GnRH in hourly pulses into the hypothalamo-hypophyseal portal system. So the hypothalamus and pituitary have a portal venous system, exactly the same as there is a portal venous system between the gut and the liver. In the pituitary, you have gonadotrophs in the anterior pituitary, and they respond to GnRH by releasing FSH and LH in hourly pulses. These gonadotropins then act on the ovary to induce follicular growth and also estradiol production. And you're all familiar with the model for estradiol production, which is the 2-cell 2-gonadotropin model. And that explains how the ovary produces estradiol. So as follicles develop, estradiol levels rise, and this leads to what is known as the LH surge. What this actually is a huge increase in the magnitude of the LH pulse and the FSH pulse that occurs in a physiological cycle. Typically, ovulation occurs 36 to 40 hours after the start of the surge. And the duration of the increased amplitude of both LH and FSH is as long as 48 hours. For 2 days, the levels of LH and FSH are significantly above baseline. In this slide, you can see the salient hormone patterns in a physiological cycle at mid-cycle. What you're very familiar with, I'm sure, are the ones that are in blue, red, orange, and green. So blue is your LH, red is your FSH, the orange is estradiol, and the green is your progesterone. I've superimposed on this in purple kisspeptin. Now, kisspeptin is a relatively recently discovered hormone, certainly relatively recently for me, because when I was in medical school, we didn't know it existed. What kisspeptin does is to mediate the stimulatory effect of estradiol on GnRH secretion. So that is how an increased estradiol leads to GnRH secretion. Kisspeptin neurons are present in the periventricular nucleus of the hypothalamus. They have estradiol receptors, which explains how they respond to estradiol. And further, there are two co-transmitters which influence kisspeptin. These are dynorphin, which is an inhibitor, and neurokinin B, which is a stimulator of kisspeptin signaling. Another point that I'd like to draw your attention to in this slide is you can see the LH surge in blue, but you can also see FSH levels in red. So there is very clear and very distinct FSH surge at mid-cycle in a physiological cycle. Why does this occur? What is the role of the mid-cycle FSH surge? Now, typically, clinicians have not thought that it is that important. We've thought that it's probably just an incidental event. So interestingly, just as we tend to ignore LH during ovarian stimulation, we tend to ignore FSH when it comes to trigger. Okay. But there is basic science evidence that the FSH surge is important. It's involved in resumption of oocyte meiosis, and it is involved in the development of LH receptors in the granulosa cells, which is important for further luteal functioning. So there may be groups of patients where the FSH surge is clinically relevant. I'll move on now to what the therapeutic options are for final follicular maturation. So broadly speaking, I've listed 4 options. You have HCG, recombinant LH, GnRH agonist, and kisspeptin. Now, HCG, of course, can be used in an agonist or an antagonist cycle, as can recombinant LH. We know that HCG has a very similar structure to LH because the alpha subunit is exactly the same and the beta subunit is 85% similar between the 2 hormones. However, there are also significant differences, which you will be aware of. We know that HCG has a very long half-life compared to LH. HCG binds to the LH receptor with more potency and more avidity than LH itself. We also know from several studies, which are summarized in a Cochrane review, that recombinant HCG and urinary HCG provide similar outcomes. There are studies on using recombinant LH. We know that if you use subcutaneous recombinant LH, the half-life is around 21 hours. It has been shown to be effective in causing final follicular maturation as well as inducing ovulation. The European recombinant LH group multicenter study showed a similar efficacy for recombinant LH as it did for HCG, but it needed quite a high dose and the pregnancy rates were lower. The other 2 options of GnRH agonist and kisspeptin can only be applied in an antagonist cycle. I've got a reference at the bottom here, which is from Endocrine Reviews in 2018 by the group of Valjit Dillo from Hammersmith in London. And if anybody's interested in the recent advances in this area, I would recommend that as a very good text to go to. Talking a little bit more about GnRH agonist trigger. As a basis for understanding how this works, we need to realize that the GnRH antagonist does not cause downregulation of the pituitary. We commonly say, oh, how is she having pituitary downregulation? Is it by agonist or antagonist? Strictly speaking, that is wrong. The antagonist does not downregulate the receptors. The receptors remain present and they remain responsive to GnRH. So when these women are administered GnRH agonist, that has a higher affinity for the receptors than the antagonist. So it displaces the antagonist from the receptors. It causes receptor activation and a release of FSH and LH. In other words, this is like an LH and FSH surge, and this is sufficient to allow final follicular maturation. We know that there are various types of GnRH analogs that have a longer half-life than endogenous GnRH, and you're familiar with using these. They've all been used as a trigger in varying doses, which I have listed here. However, the gonadotropin surge following agonist administration is significantly different to the physiological surge that we have seen previously. If you give agonist, there is a very rapid rise in LH. The peak occurs within 4 hours, and then there is a decline, and the LH returns to baseline at about 24 hours. On the other hand, we know that the physiological surge lasts for 48 hours. It has an ascending phase, a plateau, and a descending phase. So the area under the curve, as it were, for the physiological surge is much greater. As a result, although the GnRH agonist-induced LH and FSH surge may be sufficient to mature the egg, it may not be sufficient to establish proper corpus luteum for luteal functioning. In this diagram, you can see the area under the curve with various trigger agents that are used in clinical practice. So on the x-axis is the time, and on the y-axis is either serum LH or serum HCG. You can see that HCG has the greatest area under the curve because HCG levels are still detectable in the blood even 1 week after injection. The lowest area under the curve is that of kisspeptin 54. Now, this is not an agent that is available for routine clinical practice. It has only been used in research trials. And GnRH agonist causes LH levels that are in between the 2. We also know that FSH levels are significantly higher in women receiving GnRH agonist compared to HCG trigger alone. So this is a study from 2018 in which they measured levels of hormones after giving either HCG or HCG and GnRH agonist. And as you can see, FSH levels were nearly double if agonist was also administered. And this is closer to physiology. This then leads us to the potential advantages of a GnRH agonist trigger over a HCG trigger. The most well-documented advantage, I think, is a reduced risk of OHSS. And this is because the LH surge with this treatment is of a much shorter duration and lower LH activity than you get with the HCG trigger. We know that endogenous LH has a much shorter half-life, has much less stimulation and much less sustained stimulation of ovarian granulosa cells. In the luteal phase, there is earlier luteolysis, and the amplitude of the LH pulses is also lower with agonist. If you look in vitro, you can look at angiogenic factor production by granulosa cells, and you find that it is reduced compared to HCG. And also the GnRH agonist tends to induce PEDF, which is anti-angiogenic, in addition to VEGF. Serum levels of VEGF don't differ that much, but follicular levels of VEGF were lower in women who received GnRH agonist compared to women who had received the trigger with HCG. The other advantage is the potential for improved oocyte maturation because of the concomitant FSH surge that you get with the agonist, which you don't get, of course, with HCG. From this, we can derive certain indications for GnRH agonist trigger. And the three main indications that I put there are high responders, undergoing fertility preservation, such as transgender and oocyte donors. I will add one note of caution about transgender patients. Particularly, we need to be careful that the transgender patients are not on puberty blockers. So a number of them may already be on GnRH agonist long-term treatment to block their pubertal transition. Of course, in those patients, the agonist trigger will not work. So I speak from experience here. When you get a patient like this, please do not put them on the antagonist regime with an agonist trigger, because the agonist trigger will not work in these patients. So you have to be careful of that. The main aim for using agonist trigger in clinical practice is to reduce the risk of OHSS. And this is now shown through a Cochrane meta-analysis that had nearly 1,000 women, which showed that the risk of OHSS with the agonist trigger would be significantly lower than with a HCG trigger. But what are the risks and problems with using agonist trigger, and why don't we use it for all patients then? One problem is a lower ongoing pregnancy rate with a fresh transfer. To some extent, this can be counteracted by using low-dose HCG. I am not going to go into detail here. There is what is known as the European model of Peter Humaydan, and Human Fatemi has spoken about this recently at this conference as well. I will say that although low-dose HCG can increase your pregnancy rates, but it does put back a risk of OHSS, particularly in high responders. The other risk is a failure to mature eggs, and we all worry about this. The likelihood of genuine failure to mature eggs, the likelihood of genuine empty follicle syndrome is actually quite low, probably around 1.4 to 3.5% in the literature. There are some risk factors. Women whose hypothalamo-pituitary ovarian axis is already suppressed are at a higher risk. So women who've got a low basal LH level, who've been on combined oral contraceptive pill for a prolonged period of time, or in order to program their antagonist cycles, and women who've got a diagnosis of hypogonadotropic hypogonadism. I've already mentioned about previous GnRH agonist use, such as for puberty blocking or endometriosis treatment. You can also measure LH levels and progesterone levels 12 hours after the GnRH agonist trigger. And a low LH level or a low progesterone level both predict a higher risk of not getting any eggs. So what happens if you're doing an egg collection and you find no eggs? I think the only alternative here is to rescue this with a HCG trigger and delay egg collections. If you start egg collection on one side, it is important to communicate with your laboratory to see whether they are getting eggs from the follicles that you're draining. If no eggs have been obtained after a certain number of follicles, or maybe even one side, then please stop, trigger with HCG, and redo the procedure. And the final risk with GnRH agonist trigger is that even if you have freeze-all, you're not actually dealing with a zero risk of OHSS. There is a low but still definite risk of OHSS present. The first clinical quandary that I think we should deal with is, how do you choose patients for a GnRH agonist trigger? Should this be based on the ovarian reserve? So you make the decision before you start stimulation? Or should it be based on ovarian response? In other words, do you make the decision depending on what you find the response to the ovaries? So we carried out a study in Manchester, a retrospective study, which is in press and should be published shortly. This was carried out, led by my colleague Akanksha Sood. So we found there were 24 cases of severe or moderate OHSS, approximately 1.6% incidence. The majority of these were in patients who had received a HCG trigger. There was one with a HCG rescue on the day of egg collection. And there was also one case in a woman who had only got the agonist trigger and freeze-all, so had not had any HCG at all. We observed that cycles where OHSS occurred had a higher AMH, higher antral follicle count, and more eggs than cycles without OHSS. We also found that estradiol levels were not different between the two groups. This indicates that estradiol is not a predictive factor for hyperstimulation syndrome. This is something that has been described before for long protocol agonist cycles, but we have also now shown it for antagonist cycles. If we look at the actual statistics of the parameters of ovarian reserve and ovarian response, this is what you see. So we found that if you look this on the left, you have the ROC curves, the receiver operating curve analysis for the specific parameters. And just to remind you that if a parameter is mapping very close to the central line, the reference line, that means it has no value or no significant predictive value. And the closer the parameter is to the top, the better the predictive value. So you can see clearly here that this parameter, which is serum estradiol, has virtually no predictive value in determining the risk of OHSS. On the other hand, this parameter, which is AMH or anti-Mullerian hormone level, basal, has quite a good predictive value at determining the risk of OHSS. Egg number has a reasonable predictive value in determining the risk of OHSS, but of course, egg number you only know after you have administered the trigger. So it is less useful than AMH. So based on this study, we can say that you're better off making a decision for GnRH agonist trigger, basing it on the ovarian reserve, which you know before treatment starts. The big advantage of this is that you can counsel the patient in advance, make the treatment plan in advance, so the patient is less likely to feel disappointed if she needs to freeze her eggs. So it becomes a planned freeze-all rather than an emergency or rescue freeze-all. The next question, of course, is having administered the agonist trigger, should we freeze all the embryos or should we do a fresh transfer? We know that OHSS occurs in early and late forms. The early form of OHSS is strongly related to ovarian stimulation response, and it is precipitated by the trigger, whereas the late form is precipitated by pregnancy. So we know that early OHSS prevention can be achieved by changing the trigger, and by and large, that is what we see. However, in order to eliminate late OHSS, you might reduce it a little bit by modifying the trigger, but you won't eliminate it unless you eliminate pregnancy. So there is no doubt that the safest thing to do in high responders is to not transfer a fresh embryo, freeze all the embryos, and proceed to segmented IVF. But this also has some drawbacks. There is an increased time to pregnancy, and the patient may not be willing to wait. There could be an increased cost to the clinic or to the patient. We know that frozen embryo transfers are associated with certain increased risks, including preeclampsia, particularly if they are done without the presence of a corpus luteum. And also, a successful freeze-all depends on a good quality, high quality embryo freezing service. So we need to balance all these things against the risk of OHSS in deciding whether to use freeze-all or fresh transfer. I will now move on to some randomized controlled trials that have assessed this so that we can make a better judgment as to what we should be doing in this respect. A study by Chen et al. From China was focusing on women with polycystic ovary syndrome by Rotterdam criteria. And they found with an antagonist regime that the freeze-all group had a much higher, had a higher live birth rate after the first transfer. It also was associated with a lower OHSS risk, as you would expect. However, in the freeze-all group, the preeclampsia risk was increased. And again, in this study, the frozen embryo replacement was carried out using hormone replacement therapy, so they did not have a corpus luteum. Another study, this time from Iran, had fewer women, and this was based, they chose women based on ovarian response rather than ovarian reserve. In their study, about 1 in 7 women did not actually start treatment, and we don't quite know why. There was a significant proportion of women who were due to have a fresh embryo transfer, but then were changed to freeze-all because of risk of OHSS, and 5 women who were meant to have freeze-all who withdrew their consent. And they found no significant difference in the live birth rate between the two groups. Shapiro study also had some issues. They randomized patients based on ovarian reserve, a bit like we would do, so with an AFC greater than 15. They found no significant difference in clinical pregnancy rate between the two groups. However, the fresh group had superior embryo quality, and this is obviously a significant confounder, and therefore I don't think that the two groups can be properly compared in this study. And again, they did not talk about OHSS risk in this publication. So this brings us to the most recent publication. This is from the group in Brussels, the group of Christophe Bloquel, who has already spoken at this meeting. In this study, they recruited just over 200 women based on their ovarian response on the day of trigger. They randomized them to either they gave them all an agonist trigger. They randomized them to either fresh ET with a small dose of HCG or freeze-all and later transfer in a HRT cycle. So their clinical pregnancy rate was not significantly different whether they had fresh transfer or frozen transfer after freeze-all. And using a intention to treat analysis, the difference was not significant. And importantly, moderate to severe OHSS occurred in nearly 9% of cases in the fresh group versus 0 patients in the freeze-all group. So I think this study is probably the best conducted study so far, looking at the question of whether we should do freeze-all or fresh transfer if we give an agonist trigger. In summary, a GnRH agonist trigger, we should understand, produces a very different hormonal profile to a HCG trigger and a different hormonal profile to that which is seen at the natural mid-cycle gonadotropin surge. The differences between the two are subtle but important. We know that there is an FSH surge concomitant with the LH surge if we give an agonist trigger. Is there a benefit to this? We are not sure, but potentially there is. GnRH agonist trigger is indicated in situations where it is crucial to avoid the risk of hyperstimulation syndrome. So these are women with a high ovarian reserve, women who are donating eggs for the use of others, and other situations such as transgender patients. There is a risk of empty follicle syndrome, but it is probably no different.
So I'm sorry to interrupt, but we are running out of time now.
Thank you. I'm going to finish now.
Wonderful.
I'll conclude by saying that fresh embryo transfer offers a good pregnancy rate, but carries a risk of OHSS. And we should take into account all these factors in deciding which of the two options to go for. Thank you very much.
Thank you, Dr. Mathur. Now over to next chairperson for the next speaker, please.
Are we taking any questions, Soumya, or are we moving on to the next presentation?
Next session, ma'am. We will go to the next session. After the third talk, we'll take the questions.
Okay. So it's my privilege to invite our next speaker. He's Professor Alan Thornhill, the country manager for iGenomics, UK, also the senior scientific advisor at iGenomics International, and honorary professor in reproductive genetics, Department of Biosciences at University of Kent. He'll be enlightening us on when to use endometrial receptivity testing. Dr. Allen, Professor Allen.
Thank you very much. I'll just show you that that's the real person in the flesh. I'm sorry I can't be with you in the flesh. I'm giving you a talk from not sunny UK. It's raining and a bit cold, but I'm happy to be here, and I'm very pleased to have the invitation. So let me share my screen. And just tell me when you can see the full screen. Okay, sorry. There we go. Yep, is that working now?
Yes, please continue.
Okay, perfect, thanks. Okay, so here's my sort of mini CV slide, and my declaration of interest is obviously that I work for iGenomics, so you can choose to believe or not believe anything I say, because it is going to be heavily influenced by the work of iGenomics, because they have really dominated this field of looking at the endometrium. So really what we're going to do is focus on the maternal contribution to implantation. I've worked most of my professional career as a scientist or clinical embryologist looking at embryos. And today we're not really talking about embryos, we're talking about the endometrium, the soil, if you like. When we talk about the embryo, we're talking about the seed, and the endometrium, think of it as the soil. So we're focusing more on the soil. And the Chief Scientific Officer of iGenomics, Carlos Simon, has given many talks in this area and is very interested in different aspects of the endometrium, as you can see from this slide. Today, we're focusing purely on this omics aspect of analysis of the endometrium, and specifically endometrial receptivity. And there's a lot of work being done, not just by iGenomics, but generally in the field. So you should know that there is a burgeoning and already highly developed field of endometrial assessment using objective methods. So what do I mean when I'm talking about endometrial receptivity analysis? Well, really, we're trying to identify the window of implantation. And the standard window of implantation, the dogma, if you like, is that it's open at 5 full days of progesterone exposure, or LH+7 or HCG+7 in natural or modified natural cycles. So think of that window being there for a certain period of time, and that's an unknown period. But the standard timing, which is what we normally use in medicated cycle or a natural FET cycle, is 5 full days of progesterone exposure. So we know that for some people it's longer, and we know for some people it's shorter. Now, we don't have a huge body of data on that, because you'd have to do a lot of testing to determine that, and you'd have to do it like the way we used to do photographs, where you do different lengths of exposure to see whether it was a short window or a long window. But it's thought to be around the 48-hour mark as a standard. So what we're looking for with this test, though, is it's a very simple test, sophisticated type of analysis, but to get a simple answer. And it's to see, to identify people where that timing is displaced. So the window isn't where we expect to see it at P+5. It's either earlier than that or later than that. So that's the principle. And around 30%, that number is sort of slightly changing over time. It might be getting slightly higher with more tests that we do. But certainly with women with recurrent implantation failure, it's between 30 and 35% of women with that particular problem, if you like, after IVF, have a displaced window of implantation. And so that's the people we're trying to pick up. That's our diagnostic yield, if you like. So when that window is displaced, and we try and transfer an embryo at the standard time, the P+5 time, the window is likely to be closed. So it's unlikely for that embryo to implant. That's the concept. Now, it's not binary, but it just means the chances are much less likely. But if we do a personalized embryo transfer based on the individual window of implantation, then we've got much more chance of implanting. Now, a nice analogy that I've heard recently is, think of the embryo as a surfer. And that surfer is trying to catch a wave, try to catch that big wave so that they can surf into the shore. Think of the wave, catching the wave, as being the open window of implantation. So if that fantastic surfer who's a world record holder, i.e. a high quality embryo, misses catching that wave, then they're not going to surf into the shore and they're just going to wipe out. So that's the way you should think of this window. Now, as I said, there's a lot of work has been done on this. This is one of the seminal early papers identifying a transcriptomic signature. So looking at RNA from different genes to identify when the endometrium is in this receptive state. Now, there was lots of different types of analysis done before that, many of which were subjective and visual. And I'm not going to go into those, and they have their value. But using an objective, reproducible, reliable, and accurate test is much more likely to give an accurate idea of when that window is open. And what we're doing is, this is a very complex tissue, as you know, it regenerates every month in women normally menstruating. So it's a very special tissue and very interesting tissue. And this is just a list of the genes that have been used in this particular assay. And they're involved in lots of different aspects of cellular development, angiogenesis, and so on, all kinds of things that might be related to putting the tissue in the right state to receive an embryo to allow implantation. Now, that's not to say there might be certain genes that are more important than others in this list, but from a basic science point of view, I would say I think it's unlikely that just one gene would be the thing we can look at and get a decent answer from. Now, some people have tried to do that, and hats off to them. If they can find one gene that is responsible for receptivity or is the marker for receptivity, that's fantastic. But I just think that sounds a little unlikely given the complexity of the tissue and what it's trying to do each month. So surprise, surprise, we're looking at multiple genes, and in this case, about 250 genes. And as you'll see for some later work, this work, in fact, is recent work that's been published, is looking at RNA sequencing at the single cell level. And so if you consider all the different cells as part of the endometrium and which ones are most likely to be important for receptivity, we've showed transcriptomic profiles which are linked to receptivity or non-receptivity, pre-receptivity and post-receptivity, as we call it, at the single cell level. So we've given some actual proof at the single cell level that certain cells and at certain stages of the cycle, we can see that receptivity or non-receptivity. This is a standard endometrial biopsy cycle, which is how you get the tissue to do the test, which is alongside or as part of a regular medicated hormone replacement therapy cycle. So we'd have 10 days of estradiol preparation of the endometrium, then followed by progesterone, as you would do in a normal HRT cycle. We'd need to do a vaginal ultrasound, show a triple layer of 6 millimeters or more. It is possible to do this test when the thickness is lower or higher than that 6 millimeters, so it's not a magic number, but it needs to be consistent. And we tend to ask people for a progesterone level of less than 1 nanogram per mil, endogenous progesterone, basically because this is about an exposure to progesterone type of analysis. So we don't want there to be endogenous progesterone, which might confound the results. And the endometrial biopsy is performed at P+5, which actually means 120 hours, 5 full days of progesterone exposure, plus or minus a few hours. But this is really critical because our algorithm on our test is very sensitive, and as long as you can provide the number of hours, we can give you a very accurate result. But if you do a biopsy much earlier, what you're most likely to see for most patients, given that 70% of patients are receptive, you're most likely to see pre-receptive. So you've not really helped the patient by giving them almost like an artificially pushed early receptive result or pre-receptive result, because you could have guessed that anyway. And the danger of doing that is you might have to do another biopsy to get a more accurate result and try and find exactly where the window lies, the receptive window lies. So as I said, it's a 248 gene test. It started on microarrays, has now moved on to sequencing, as many molecular tests have. And using complex bioinformatics, because no human can look at the results from 248 genes and sort of say, oh, this one's underexpressed, this one's overexpressed, this one's about right, so I'm going to say she's receptive. This is a complex data analysis using classification and prediction from those different expression levels of the genes. And there have been many publications at the basic science level, at the preclinical level, and even at the clinical level. I'm going to be providing the data from the recently published and long-awaited randomized control trial performed by iGenomics and lots of participating centers. But this is just to show there is a body of data that leads towards where we are today, most of which has been done, at least clinically, on failed implantation patients. At least that was what the primary indication was. So if you went away from this talk saying, why would I use an endometrial receptivity test? One answer would be for failed implantation. But I hope by the end of the talk that I can convince you that maybe that range of indications is expanded based on the data that we've got. And those publications I showed you or listed previously, they were performed by iGenomics and commissioned by iGenomics, if you like. These are a number of publications that have come out where people are just users of the test and have published off their own bat, so not promoted or commissioned by us. So a kind of warts and all type of analysis, if you like, and one that I particularly like, given that I've told you that the primary indication was failed implantation, which we know can mean anything from 2 to 3 implantation failures in a deferred embryo cycle, but it can also mean that PGTA has been used or not been used. It can mean the embryo quality might not have been that good. So it's a bit of a mixed bag, let's say. But I like this one because this is a high quality center in Canada performing both endometrial receptivity analysis and PGTA, but not necessarily at the same time. And so what you can see here is recurrent implantation failure patients who've had euploid embryo transfer, i.e. PGTA, that's the green bars. You know, they've got pretty good success rate, but when they've used a personalized embryo transfer as well on top of doing the PGTA, so we've removed the confounding factor of abnormal embryos, which predominantly fail to implant, we get an uplift. Now, it's not significant. This isn't a clinical, a randomized clinical trial. I'm not trying to pass it off as a trial. I'm just trying to show you that this is very interesting data showing that people are getting good results from PGTA, and then they're adding on this, you know, looking at the soil, the endometrial receptivity analysis, and they're getting even better results. And that's what we would expect. We would expect to see an uplift if there was a displaced wind of implantation, and we're putting a good quality embryo into a non-receptive uterus most of the time. So in summary, in terms of the number of tests being done, this is not clinical trial data. I'm just telling you the warts and all experience that we've got so far. Many patients using an endometrial biopsy at P+5, and this is the kind of breakdown of results. About 63% receptive, 30 to 37% non-receptive, because as I told you, it was a bit lower earlier on. And then of the non-receptives, predominantly 90% pre-receptive. And in most of the cases, we don't need to do a second biopsy. So about 5 years ago, it was about 30% of cases you need to do a second biopsy to get that, to really pin down that window. And now, because of the algorithm, the strength of the algorithm, 90% of the time we can just do one test and predict what we should do next in terms of staying the same or doing more or less progesterone exposure. But this is the real meat of the talk, and this is the 5-year multi-center randomized controlled trial, you know, high quality trial comparing personalized using ERA, frozen without using ERA, and fresh blastocyst transfer in IVF. And the key thing here is IVF at the first cycle, so not after multiple failures. So these are day 5 or 6 blastocysts. IVF patients at their, my colleagues call it first appointment. To you and I, we should say the first IVF cycle. And that's doing personalized embryo transfer after ERA, whether that was a receptive or a non-receptive result using cryopreserved embryos, or FET, just using cryopreserved embryos, but not at a specific time, just using the regular procedure that the clinic would normally use, or a fresh embryo transfer. And the primary objectives were live birth and cumulative live birth rates after 1 year of transfers, because not everybody you know, would get pregnant in the first go, obviously, with any of these techniques, and but most people would have frozen embryos in the bank, so to speak. And then a list of secondary objectives, as you would expect: implantation, biochemical, miscarriage, and so on. And I'm not going to say too much about this. No particular surprising inclusion and exclusion criteria, except to say removing things that are, you know, would obviously be problems in terms of endometrial pathologies, multiple implantation failures, which, as I said, is usually the indication for doing this test, but in this study would be a contraindication, lots of miscarriages and so on. What's quite interesting in the post-randomization exclusion criteria is the fact that PGTA was neither inclusion or exclusion, which could have been a problem given that I've been, you know, saying how good a PGTA could be for making sure we're only transferring euploid embryos. But when the analysis was done, only 2.5% of cycles in each of the groups was PGTA anyway, so it has little or no effect. But it's a very interesting point, and we have got a trial ongoing looking at both PGTA and ERA in a randomized setting. So these are the numbers. What's interesting is it's reasonably good numbers for this kind of trial. But as we see from the allocation, the intention to treat, we get quite a lot of people at the per protocol analysis that have dropped out. And this is one of the limitations, as I shall say later, but it's also not surprising to me. It's disappointing for me, but it's not surprising since I've been offering the test in my affiliate, because I speak to lots of healthcare providers, not just doctors, I mean nurses as well. And it's clear that sometimes they either don't understand exactly what they're supposed to do, even though it's quite a simple test, or they choose to do something different. Now, in a treatment setting, obviously you have to do the best thing for the patient as you see it on that day. In a trial setting, you should either drop out of the study or you should follow the protocol. And unfortunately, a lot of these dropouts from ITT to per protocol analysis are dropouts because of not following the protocol. So we end up with a much smaller number, and that is a limitation of the study. And obviously we designed it with intention to treat, so that's important to have that as an outcome. But the reality is, if you want to see whether after you've actually done the treatment and the test that you designed the study for, what results you get, I'm going to share those with you. So there's a lot of data here, and I'm conscious of that, but really I just want to point out that almost every positive outcome you would be looking for, so we're looking at the PET column here, is significantly better after doing the ERA test and doing a personalized embryo transfer than both the deferred frozen embryo transfer or the fresh transfer, with one exception, the live birth rate on the first transfer. But in terms of cumulative and pregnancy rate and live birth rate, it's better in the personalized embryo transfer group. Now, don't forget, this isn't failed implantation patients. This is first-time IVF. So that is really potentially a game changer. And this is just to, to focus down on the outcomes that we're most interested in. And that's just pointing that out for you there. Let me just skip through this in the interest of time. So the take-home messages are that live birth rate, even though, but per protocol analysis, even though not significant, certainly a decent improvement in percentage point increases versus FET and fresh embryo transfer, but statistically significant improvements in cumulative live birth, cumulative pregnancy rate. And maybe we should just, even though I think live birth is a bit of a stretch to ask of a test that's looking at implantation, that's often the outcome people want when we talk to patients. So that's often what studies are designed for. But those are hefty percentage point increases. If anyone came along with any other kind of test or improvement or culture media or device and were offering that kind of percentage point improvements, I think most clinicians would bite their hand off and take that. Pregnancy rate and implantation rate, but no surprises there. And we would expect to see some synergy between all of those different positive outcomes. So interestingly, a similar clinical outcome between FET and fresh embryo transfer, perhaps not surprising given some of the data that's starting to come out, and obstetric delivery and neonatal outcomes not different. So to answer the question, the talk title, when to use endometrial receptivity analysis, well, perhaps the issue now is it's not just failed implantation. So we've got many users around the world who are very happy when when their patients are drinking at what we call the last chance saloon. What am I going to do next? So perhaps do an endometrial receptivity test and see whether that's been the problem all along, which seems like it's a bit late to be doing it then. The question now is whether this should potentially be a frontline test. Now, I know the naysayers are going to say, we need more data, but this is pretty interesting first stab at a randomized trial to see whether this is a test that could be used by lots of patients. So the limitations and reasons for caution are, as I've said, this unexpected 20% dropout rate, which is largely because of non-conforming to the protocol versus the 30% initially planned. And then really just to say that this is the first randomized control trial using ERA and providing proof of principle evidence for the potential of using this type of diagnosis for the workup of a couple at the first appointment, i.e. the first IVF cycle. So not just for failed implantation. And just this is really important. And I know this looks like a marketing thing, and I don't want it to come across as that, because I just think this is an important point. It's not to say, I'm not convincing you to use this test at all, and I'm not convincing you to use the iGenomics test. What I'm asking you to do is that when you're offered a test, you ask yourself the question, what is this test? And is there evidence that backs up this test? And if the answer is no, or I'm not sure, then you should, potentially think twice about it. So this is just to give you an example of things that are being marketed at the moment, given the success, in terms, at least the commercial success of endometrial receptivity analysis. So
I'm sorry to interrupt, sir, but we are running out of time, and we'll.
Yeah, this is my last slide.
Okay,
Yep.
okay, sir.
More is not necessarily better, but I think in terms of, analyze genes, I made the point earlier about, is it about one gene or a couple of genes or 250 genes? Answer, I don't really know, and I don't think anybody really knows. But the point is, when you look at publications and clinical validation and evidence, most clinicians I speak to, that's the first thing they say is, where's the evidence? What evidence do you have? And yet people are willing to buy tests that have virtually no published evidence because they're cheaper, or perhaps they're cheaper. So this is not a sales pitch. I just want you to ask the question. I always go to customers and colleagues and say, have you asked these questions? If you've asked the questions and you've got a decent answer, be my guest, do what you think is right for the patients. But that's what I would just ask is, don't use imitations if something is better on the market. Use the thing that has the best evidence. If you don't want to use it, that's absolutely fine, but don't use a weak version of a test. Just to say thank you to my colleagues. This, I'm offering the test and supporting the test in the UK, but I've not done any of the research towards it. But thank you for your attention.
Thank you very much, Professor Allen, for this wonderful presentation. We have a couple of questions for you. This one is from Dr. Sudha Prasad, and she wants to know if you think the window of implantation differs in every menstrual cycle. Is it different in different cycles?
Okay, we don't have exhaustive data. It's a similar answer to this thing about how big is the window, because I told you that the window can be big and it can be short, but we'd have to measure every single patient that we did any tests on. We'd have to do that for that patient. So that's it's an indirect answer to this question. So we've done a number of cases in different cycles for the same woman, and it seems like, not every month, but we have done it for some a smaller selection of patients where it's been every month. And with all other things being equal, i.e. it's the same preparation regime, they've not had any surgery or not had any major disease, we see the same result every time. But that's not an exhaustive number of patients. It's not thousands, it's probably in the low hundreds. So our answer is, yes, we think it's the same every cycle.
Does she announce?
Sorry?
Yeah, so if you think it's the same, once we do an endometrial receptivity assay and the patient doesn't want an embryo transfer for the next 2-3 months, how long does the test result hold good?
Yeah, so we've got data for 5 years so far. So I can't, obviously I can't answer the question, is it 10 years, is it 20 years? And I think you would all agree, depending on the starting age of the patient, that might not be very relevant if it was 10 or 20 years on. So I can't give that answer. But I can say it's certainly within the time span that people normally are doing IVF for, maybe over several years. So we've got data from 3 to 5 years, and it looks like it's the same. But I think it's always important, if it is 3 to 5 years later or 2 years later, that when you then want to do the transfer, just check in with whoever's offering you a test and just say, these are the things that might have changed, because people always miss out key bits of information. Maybe they've had some surgery, maybe they had chemotherapy, maybe something else has happened, and these are all things that might have an effect. But all other things being equal, if you use the same stimulation, the same medicated regime, we should get the same result. That's the data we have so far.
So if everything else is same, we can safely use the same result, say at least within 1 year.
Absolutely. But this is important, and I'm stressing it because I've seen lots of non-compliance in this. And I love it when someone calls me and says, I just wanted to check, so someone will call me and say, I'm about to do a completely different medicated regime for this patient because we now think this is better. Can I use the same result? And I say, no, you can't use the same result. It might work, but our test is somewhat meaningless in that context, because the test has been The result has been generated using a particular medicated cycle, which means the endometrial tissue has been exposed to a regime of progesterone, which we need to replicate to get the same result. Okay, that's the point. I'm not saying it wouldn't work and they wouldn't get pregnant. You know, when we didn't used to do the test, when nobody even cared about this stuff, people still got pregnant. So we're not trying to make claims that this is what makes people pregnant. No, this is what identifies people who have a displaced window of implantation. So you see what I mean? So what I want is someone coming to me and saying, I'm doing everything the same as 6 months ago. Is the test still good? Yes, the test is still good.
Yeah. So the next question is that should we be checking for microorganisms before doing this test? Does an unfavorable microbiome affect the window of implantation?
Well, that's a different talk, and another talk that I and others from Genomics and other people give as well. The answer to that is probably yes, but we're still learning more about that. But we don't think it affects the window of implantation. You know, remember, window equals timing, but we do think it can create an unfavorable environment. So briefly, two versions of the unfavorable environment. One, which I think any clinician on this call would pretty much say, I would have no problem with this concept. One is pathogenic bacteria. So that's one. So if you see a pathogen, or if you're aware of a pathogen, most people are going to do something about it, even if they can't see the symptom. And the truth is, with chronic endometritis, we can't always see the symptom, right? So that one is one of the things we can pick up with a microbiome test. The other one is lactobacillus dominans. So very simplistically, if we think of lactobacillus as healthy bacteria, we've got compelling evidence, although it's a small amount of evidence, and we've got trials ongoing as well, that say if you have a non-predominant lactobacillus environment in the endometrium specifically, then that's not so conducive to pregnancy. Again, it's not binary, but the numbers are pretty compelling. It's something like 56% of the small sample, 56% live birth rate in the group that had lactobacillus dominant versus 10% in the non-lactobacillus dominant group. So this microbiome assessment may well be another puzzle piece in this endometrial factor puzzle, but it's not window of implantation. It's implantation, but it's not a window. It's more like, what's the environment like? What's the soil like?
Yeah, so it's more of the receptivity rather than the window.
Yeah, exactly. It's not timing. It's something else.
Correct. So Dr. Nina wants to know if we can somehow find out about the receptivity using fewer genes than 248 and thereby reduce the cost without compromising results.
Okay, so here we are. We're back onto cost. I understand about costs, but if you understand next generation sequencing, it's almost never today, and this is a really important concept I want to get across. That's why I'm making a bit of a point about it. It's almost never about the number of genes anymore. I could look at 1,000 genes and it would probably cost the same. So it's not about the number of genes that makes the test cheaper. And somebody offering a 1 gene test, it's probably more expensive to do it in the lab than it is to do the test we're doing, because the test we're doing uses sequencing reagents at scale. And so it's not about the number of genes. So, sorry to be commercial about it, but if you're looking at a test, you should look at the evidence and the quality of the test, not really at the number of genes based on how much it might cost. The number of genes these days is not really a factor in terms of cost. So I don't know if that really answers the question, but I'm trying to make that point really clearly. The test that has 1 gene.
We have some questions.
Yeah, it's not 100.
We have some questions for Dr. Raj Mathur also. Yeah. So may we go to Dr. Raj Mathur, please? Sir, what is more physiological as per you? Is it the agonist trigger or the dual trigger, considering the luteolytic effect of LH and the implantation rate? And what cutoff? Do you really check the adequacy of LH trigger always in your cycles with progesterone and LH? And what cutoff you choose to change to freeze-all strategy, or changing your fresh or the freeze-all transfer? Freeze-all.
Thank you. That's a number of questions. So there's no doubt that an agonist trigger is more physiological than other triggers, but it is not physiological enough, because although it causes an LH and FSH surge, the LH surge doesn't last as long as it would in a physiological cycle, and that was part of the point I was trying to convince. I think a HCG trigger is not physiological because it is for too long and too sustained. So we genuinely don't have a properly physiological trigger available to us at the moment. But between these two, agonist is probably a little bit more physiological and safer. We tend, in my practice, we don't do progesterone or LH levels after administering the trigger because the patient would have to come back 12 hours later. Many of our patients travel a long distance and we can't do that. The other thing is that we actually have a very low risk of empty follicle syndrome, perhaps 1% in our clinic, 1.5%. And we've now understood that if we start an egg collection and we find no eggs, then we just stop and re-trigger them and carry on doing it that way. Did I answer all the questions? Was there another?
No, sir. There is one more question from doctor. This is, what is the role of kisspeptin in stimulation? Do you have you used this and alone, or because ROC is very short in this, or along with HCG? What is your experience?
Okay, so kisspeptin is not available for clinical practice. It's only available as a research molecule. It has been studied in at least 2 good quality randomized trials by Valjit Dhillon's group. So it's not something that is currently, you can't go out and prescribe it. Yeah. And they only used it for trigger. It's not required during stimulation, only for trigger.
Have you used any difference in the trigger with triptorelin, buserelin, or with leuprolide in your practice with respect to the results or the LH levels after, in the adequacy level or the maturation level? Your experience?
So my experience is 99% with buserelin, and we're quite happy with it. We used to use quite a low dose of only 0.5 milligram. But then after speaking to colleagues in the US who were using a higher dose, we've started using 2 milligrams for the last five years or thereabouts, and we are happy with that. So 2 milligram buserelin.
Do you use any cutoff of E2 values for deciding that which dose of, like how much you would use buserelin, number like 2000 or 2500 or 4000? Do you go accordance to the E2 levels or something else?
No, the E2 levels are not predictive of the risk of OHSS, either in long protocol or in antagonist cycles. So we tend not to go by them. Of course, when your E2 is, say, 20,000, you also have a lot of follicles, so you need a decent scan. And if you've got high follicle numbers and it looks like you will get 20 eggs or more, then we would definitely do an agonist trigger. And if on the day we get more than 20 eggs, we would most likely advise a freeze-all. If you're surprised you get less than 20 eggs on the day, then that is the situation where we might say, have a small amount of HCG and have a fresh transfer. And again, when they come for fresh transfer, we specifically ask them about OHSS symptoms. If they've developed OHSS symptoms by then, we will vitrify the blastocyst.
Thank you, sir.
Sir, Dr. Yadvaji, I have a question for you, sir. Dr. Yadvaji.
Yes, hello.
Yes, sir. So how important is the spending capacity of the patient salient when we want to build a good practice?
So this is what the whole idea, sorry, I don't know why. Okay, I'll just start a video again. So this was the whole idea of the talk, is reducing the cost and improving the quality, because end of the day, spending capacity is important, or how much we charge patient is important. Yes. So yes, this is important, but when we are targeting a market, it is very important to know your customers first for any business. So we need to know our patients, which type of population we are going to cater, how much they could afford, and what personalized treatment plans we could make it. I mean, we could do all the tests in the world for all our patients, but that is very, very important, that what we need for these targeted patients and how much they could afford to give them the best outcome. And this is where the reducing our cost and improving our efficiency ultimately help our patients to reduce their cost of treatment or their cost of the service.
Okay.
So that's yeah. So that's why it's very, very important when we are considering any in our local setting. That's ultimately important thing.
Yes, thank you, sir.
I think one more for you, Dr. Jeev. Dr. Mathur has a question. How do we include patients and ensure their interests are respected in the management decisions?
Yes, that's the very important, and this is absolutely important for not just management decisions, research decisions, trial decisions. And now there is a drive towards including patients before having any grant funded for the research. So taking that into the model of management and leader and setting up service, end user experience and their expectations are ultimately important to have the good name for the business or the brand. So therefore, then I mentioned shortly on the patient reported outcome measures, which we are moving towards as a NHS trust, as the Birmingham Women's Hospital. And we are going to ask patients as a patient reported outcome measures that what they exactly thought of the process, what their problems are, because sometimes what we perceive may not necessarily what patients have seen. It's a communication is always what it is received. So therefore, it is very important. So how we include that? Number one, we do their patient experience survey. We check their safety, and we see that whether what they feel about their outcome of that particular intervention when they came to us or the treatment. So this is why it is very important. I think patients are the key stakeholders of everything what we do. So, but these are the ways that patient-reported outcome measures, patient-reported friends, family test, or whichever test you use to analyze their experience and their pathways. And patients most of the time tell us that what is the right thing or what they would have or what they expect. It's just like, and now it's and with this online and presence and the social media era, everything is on reviews. Patients, before telling us, they will tell 10,000 other patients that this is what is happening in this particular setting. So this is far more important now than before.
Yadav, I have a question for you. Considering that you run your quality management system and brilliantly, you've sort of put in place in Birmingham, how easy is in the NHS when you have so many managers who've already overtaken the last 2 decades to strike a balance? Because I understand as doctors, we are good at managing, no doubt. We've not gone through a finance degree or an MBA degree, even given that I may not do it. At my age, I think I can still do without an MBA. But I want to ask you how easy it is to strike a sync in NHS, considering, that the system is so much, the last 3 decades grown with managers, nurse manager, in every situation. How easy and difficult is it?
Thank you. So first is why this happened. This happened because how the healthcare set. I always give this example in my talk or the managers. Once come a doctor started seeing a patient, then doctor felt a need of a nurse, the researcher, the scientist, and then the set. And then they thought, I need a receptionist. And then, I need somebody to manage everybody's rota because I can't do everything. And then the category of manager come. So actually, we always need to remember this. This is how the patient care started. But now it become other way around, that then the manager comes and we all are working for the managers. Now you ask a question specifically for the NHS. So it is difficult because, as you rightly said, it's heavily becoming bureaucratic. But this is then the right time that there is a balance, and then the clinicians coming and, show me the business plan, what we are thinking here, and what, unless we challenge the business concept in the evidence-based manner and in the manner that, and we don't talk their language, and it's nothing against doctors versus managers. It's a bridge. Unless, because when I learned management, I also started seeing the complexities that the managers are facing. So basically, we need to speak each other's language, and that's the way forward. So how we can improve in the NHS? NHS is heavily investing on the clinical leadership and management. Now it is becoming mandatory for all trainees to have at least some management form of courses before they become consultants. There are training for, and as we were talking, we were even discussing on the BFS forum that whether we could have quite similar type of courses for the trainees. But yes, I mean, these are the ways that unless we do it, yes, then we have to listen to somebody who does it.
So, quick question for Dr. Mathur. Anyone was saying something?
Dr. Mathur, is dual trigger able to prevent empty follicle syndrome? And what is the time gap between GnRH agonist and HCG in dual trigger? This is from Sapna.
Thank you. I can't give an evidence-based answer to that because there are not sufficient studies actually examining that, because actually empty follicle syndrome is not rare, but it's uncommon. The risk of empty follicle syndrome, 1 to 3% with HCG or with agonist trigger. Sure, try a dual trigger that is, it's no harm. If you've had a patient with empty follicle syndrome in the past, try a dual trigger in the next cycle. And likewise, in our practice, we do use a dual trigger in a specific situation, then that's not so much for avoiding empty follicle, but this is in patients who have had a very low proportion of mature eggs in their previous cycle. So particularly patients who have ICSI, where you know how many metaphase 2 eggs are present. And if in their previous cycle they had, say, 10 eggs collected, but only 3 were,
I'll ask them to upgrade you.
we tend to then use a dual trigger next time. The hope being that because of the FSH surge, they'll have a higher proportion of mature eggs, and we give both at the same time. So we don't have a gap between the agonist and the HCG, we give both together in that scenario.
Thank you.
Thank you.
So any more questions? I think we are almost to 5. Thank you so much, sir. Thank you, Dr. Raj Mathur. Thank you, Dr. Allen, Dr. Jeev. It was really an overwhelming and exhilarating. We really enjoyed the whole session. Thank you all the chairpersons for coordinating it so well. I would request Dr. Soumya to take over the next session for the OR3.
Thank you. Bye-bye.
Thanks. Bye-bye.
Thank you, Dr. Pancham.
Thank you. Bye-bye.
Now we will have the oration of the local organizing committee, for which I invite our respected chairpersons, Dr. Sonia Malik ma'am, Dr. Pankaj Talwar sir, Dr. Ajit Awasthi sir, and Dr. Sushma Chandra ma'am. Dr. Sonia Malik ma'am is Program Director, South End Fertility and IVF Center, Delhi. She is the past president, Indian Fertility Society. Dr. Pankaj Talwar is Head Medical Services Department of Fertility and IVF, CK Birla Hospital, Gurugram. And Dr. Ajit Awasthi, he's former Head Senior Professor, Department of PGI Chandigarh, Department of Psychiatry, PGI Chandigarh. Dr. Sushma Chandra ma'am is President Narchi Jalandhar chapter, and she's the Director of Chawla Nursing Home Maternity Hospital, Jalandhar. I invite Dr. Sonia Malik ma'am to kindly invite Dr. Umesh ma'am for the talk.
Thank you very much, Soumya. Thank you very much to the organizers for giving me this opportunity to introduce a friend, somebody who's very dynamic and has been the backbone of this meeting that we are just witnessing. Dr. Umesh Jindal has been a pillar of the Indian Fertility Society. Can I have a slide, please, Soumya? We all know her now. All of us attending this conference know her well. However, for the sake of introduction, she's the consultant and director of the Sant Memorial Nursing Home at Chandigarh. Besides that, besides being the organizer of this chairperson, she has been the vice president of the Indian Fertility Society from the year 2016 to 18, and has actually spearheaded the program, the ART, the teaching program, the ART fellowship program of the organization, and we are very, very thankful to her. She started that in 2014, and actually we have now handed it over to Amity, but this was her brainchild, and actually the society is really, really thankful to her for taking us through a path of learning. And today she has chosen a very unusual and unique topic, but very pertinent to the practice of infertility, vaginismus. We know that there are lots and lots of couples who are suffering from this, and this problem is actually in parallel to the male ejaculatory dysfunction, but not talked about as much. So thank you, Dr. Umesh, and here the dais is yours. Please start your lecture. Thank you. We are very, very willing to hear you talk about this.
At the outset, thank you, chairpersons, Dr. Sonia, Dr. Pankaj Talwar, Dr. Awasthi, and Dr. Sushma Chawla, my good friends and my old colleagues. And I wish to thank Indian Fertility Society on behalf of my team and myself to give us the opportunity to organize this wonderful conference. And giving me an opportunity to share my experience and my feelings for a topic which has been neglected not only by the society, by patients, but the doctors as well. There is a cause and effect relationship between sex and fertility. Doctors as well as patients are restricted by their inhibitions, preferences, and experiences. It's considered incurable and it's practically never discussed. There is a strange conspiracy of silence of multicultural, conservative Indian society against female sexual desires and expressions. The incidence of vaginismus varies from 2% in general population to 47% in sex therapy clinics. We reported an incidence of 1.4% in over 5,000 infertile couples. Even now, every month, 3 to 4 couples report with this problem. Recently, D'Souza et al. Reported incidence of 1.07% in a sample of 425 IVF and ICSI and 226 frozen embryo transfer cycles. We investigated these sexual problems way back in 90, and at that time also, out of 100, 3 women complained of superficial dyspareunia and 5 were labeled frigid, a term which is no longer acceptable today in today's vocabulary. Why physicians avoid sexual history? There is a perceived or actual inability to treat vaginismus. In medical schools, sexual medicine gets only a passing reference even in gynecology MD courses, and there is no formal training. It is considered a psychiatric problem, and we try to shrug off our responsibility. Busy clinicians are unwilling to spend time which is required for patient listening and counseling. There is a personal discomfort talking about sex. They have their own beliefs and preferences. But at the same time, the importance of sexual history in infertility clinics cannot be less talked about. Most gynae interventions require vaginal penetration of instrument, fingers, and transvaginal probe. We all know that inadequate sex is a common cause of infertility. One may prescribe timed intercourse or abstinence without realizing their problems. I have built strongest rapport with those couples whom I counseled for vaginismus and treated correctly. We cannot manage their infertility without understanding the impact of vaginismus on their all aspects of life. We investigated the social problems of infertile couples again in 90s, and disharmony with in-laws were prevalent in nearly 1/3 of patients, and this amounted to taunting, grumbling, abusing, making them social outcast, even physical abuse and threat of abandonment by in-laws. The extreme was that 4 of the men had already remarried out of 100 at this stage in order to get a baby. In India, the Indian Penal Code recognizes denial of conjugal rights as a ground of divorce, and many couples are at the verge of divorce when they come to us. The social problems I have already highlighted, but many of these adjusting couples live under same roof as friends. The woman may be a psychological wreck with altered body image, decreased self-esteem, becoming an introvert and not talking regarding her problem to anybody. These women suffer at the hands of medical community also. Doctors label them as psycho, as uncooperative, as overreactive and anxious, and many times shouted at for gynae examination in the examination rooms by the unaware doctors. The ART specialist has to wear the master cap to manage all these multiple aspects of this problem. Many times you need family counseling to buy time for cooperation and for treatment. Genitopelvic penetration disorders are dyspareunia, that is marked difficulty or pain during vaginal penetration because of anatomical distortions or malformations, infections, etc. And vaginismus, the extreme fear of pain, thwarting any attempt to penetrate, usually because of phobic anxiety, but may be related to past mental or physical trauma. Both these conditions have been clubbed in the DSM-5 together because of gross overlap between the two. A physician sensitive to the body language and psychological cues can pick up signs of vaginismus, telltale signs of vaginismus. Non-consummation of marriage or significantly infrequent coitus in young patients, dyspareunia without obvious organic cause, extravaginal deposition of semen or partial penetration are almost clear pointers. No intercourse when advised timed coitus. Secondary onset erectile dysfunction in male partner are again indicators which may help in the diagnosis. A woman who is asking for pain injections, general anesthesia, even for examination, ultrasound, IUI, and embryo transfer is a sure case of vaginismus. She may have hesitation or plain simply refusal for examination, and very innocently, many of these women who want help, they warn the doctor of her inability to cooperate and request not to be shouted at. D'Souza et al. Recognized the need of care for this invisible population. They sent questionnaires to 228 IVF centers and got reply only from 5.7% of these. The cause of difficulty encountered at the time of transvaginal ultrasound and embryo transfer was again ascribed to anxiety, ovariation, operator's gender, partner presence, etc., not recognizing the underlying cause. The PLICIT model is a proposed conceptual scheme for the behavioral treatment of sexual problems. P stands for to give permission to go ahead to describe her sexual problems, assure confidentiality, privacy, and willingness to listen carefully. Limited information is given at the first encounter regarding the anatomy of genital organs and physiology of sex. Myths and misunderstandings and wrong concepts are dispelled. Specific suggestions are given relevant to her problem, and a tentative treatment plan is charted out. Referral to an intensive therapist is done if needed in a particular case. The goals of treatment for the physician and the patient are different here. While patient is focused on a baby, the physician has to walk through the course of handling complex social and marital issues, and the first target is to get cooperation at examination. Mutually satisfying course is the endpoint for many of these couples, and they achieve pregnancy through the natural route. Individualized, improvised treatment plan has to be made for each and every couple. Grading of severity of vaginismus was initially reported by Lemont. We are following the same, but with a little modification. Grade 0 is when two-finger insertion can be done with little persuasion, but at the end, there is a plain, simple refusal of examination, and there is varying degrees of crouching, adduction, and a lot of coaxing is required for examination. The components of treatment of vaginismus include, the first is the most important is counseling and education. You have to counsel them regarding anatomy, physiology, and physiology of phobias, and you have to counsel them to develop a positive attitude towards sex and libido. The counseling of male partner is very important. You have to address their concerns regarding performance anxiety, and maybe masturbation is a good practice if it is acceptable to them. Stepwise pelvic floor relaxation is the main medical intervention which we do. Kegel's exercises are taught, and gradual desensitization by fingers insertion or dilators is done. And the couple is given some task. The most important is increased communication to build a strong relationship, and stepwise learning of intercourse by splitting intercourse into small steps. The management plan includes weekly sessions of 15 to 30 minutes each, a flexible approach depending upon severity, level of participation of the male partner, and degree of rapport developed with the couple is made. First few visits were devoted to reassurance, confidence building, explanation, and desensitization. These are gradually replaced by task assignments as part of stepwise learning of intercourse, and minor hymeneal incision was performed for borderline rigid hymen in a few cases. The confidence building involves by making them believe in themselves and the physician by saying it is possible and it is going to be painless. Initial first visits involve assessment of severity and of social and psychological factors, the anatomy of physiology of intercourse and pelvic floor, especially pelvic floor, is explained with the help of diagrams or models. Principles and steps of treatment of pelvic muscle relaxation, desensitization, task assignment with treatment and time requirements are explained, and they are given weekly appointments. The second visit again is for confidence building, improving communication, teaching Kegels exercises, and she is given a task for self-touch and fondling of external genitalia and finger insertion if acceptable. The couple is encouraged to have non-penetrative sexual contact and masturbation, and any attempt at vaginal intercourse is prohibited. After 1 week, the progress is again assessed. One finger vaginal examination is usually possible, and Kegel's exercises they start to do. She is more reassured and more confident. Then we give a task for external genital contact by male partner, but you have to reinforce the fact that vaginal intercourse should be prohibited to discourage at the failures again. At visit 4, we can see the road to recovery. Progress is usually good. 2-finger vaginal examination, to and fro movement, and Kegel's exercises are now acceptable and are being done. Transvaginal ultrasound may be possible, and task is given by the finger insertion by the partner. Short-term sildenafil is prescribed if required for secondary onset erectile dysfunction. Again, the attempt at vaginal intercourse is prohibited. The last few visits, 2-finger vaginal examination is possible, and levator relaxation is assessed. The male partner is counseled about his role, because at this point, his role is very crucial. The couple is advised vaginal penetration at intercourse, and it is stressed that endpoint is only insertion and not ejaculation, because that is the bottleneck. Once insertion is achieved, everything will follow. So we encourage woman up position, and frequency of intercourse should be increased. At follow-up, any residual problems are detected and counseled. The workup of infertility should start as soon as possible, except in very young couples in whom resolution of vaginismus is highly likely to achieve conception. Only 20% of couples would require some form of ART, either IUI or IVF, to achieve pregnancy. We reported our results in 2010, and over 4,000 women, 78 women presented with vaginismus. The duration of infertility was 2 to 97 months, a median of 29 months, and over 90% had severe grade of vaginismus. The presenting complaints were equally divided among non-consummation of marriage, dyspareunia, incomplete penetration, and infertility without apparent sexual dysfunction. Of these, 73 women agreed to follow up, out of which again 10 dropped out, highlighting the importance of initial counseling and confidence building. So out of the 63 who agreed, who finally started follow-up, 60 achieved full resolution of vaginismus, and again there was a dropout of 3. And of these, 42 women continued with us for pregnancy, but 18 were lost to follow-up after that. But probably they did achieve intercourse as well as natural pregnancy in majority of these cases. In milder cases, the patient couple may require 2 to 4 visits, but in severe cases, 5 to 8 visits may be required. Of the women who continued with us for pregnancy, 25 or 60% achieved natural pregnancy, 5 through IUI, 3 through IVF, and unresolved infertility was there in 9 patients at the time of reporting. Secondary onset erectile dysfunction was there in nearly 50% of couples. Counseling, reassurance, and short-term sildenafil was quite effective, and only few tablets were required. In long-standing cases, the men may develop a secondary decrease in libido as well as psychological hostility toward their female partners. 3 of our cases in whom male partners refused sexual intercourse or referred to a psychologist, pregnancy was achieved through IVF in these cases. Immense social pressure to conceive is still there, although we have come a long way from that social pressure which we saw in 90s, but this is the major complaint of most of the couples. If the infertility is of short duration, the couples are more interested in sex, but none of them is willing to be referred. Moreover, credible sex clinics are few. Thus, simultaneous treatment of infertility is a strong motivating factor to continue treatment in infertility and gynecological clinics. Although a psychological problem, we did not go into the detailed psychoanalytic techniques, specific questionnaires, pharmacological agents, or biofeedback machines. These were not used. We relied on behavioral modification as described. Serial ultrasound for follicular monitoring is a good tool for desensitization and keeping on the motivation. A sensitive and positive attitude of the physician is all that is required. Finally, the take-home message: sex is a complex interplay of mood, relationship, hormones, and several other interrelated factors. Goal of treatment in vaginismus remains to resolve social and marital issues, cooperation at examination, achieve mutually satisfying intercourse, natural or ART pregnancy. Placid model of assessment and counseling is a very good tool. Counseling and participation of male partners is of paramount importance, and cooperation at examination in almost 100% and natural conception in nearly 80% can be achieved in just 4 to 8 visits. And in the end, I would like to thank you and IFS once again and Dr. Pankaj Talwar for giving me an opportunity to consolidate my thoughts and share my experience in this chapter in the ART textbook, which is in press by the Indian Fertility Society, Vaginismus, Dyspareunia, and ART. And I would like to thank my Jindal IVF team for supporting me through so many years and helping me to organize this conference. Thank you very much.
Thank you very much, Dr. Jindal. That was an amazing talk. Actually, it's a Waterloo for all of us. As a clinician doing IVF from nearly 18, 19 years, that's one disorder where I don't know what to do. At my end, the amount of incidence which I face every day is around 2 to 3%. What you brought out is around 1.4%. So it's an unspoken disease about which we don't have much of clarity. And that's the reason we keep referring all patients to you for handling vaginismus. So on behalf of everyone, we would like to thank you for putting your hands into the hornet's nest and talking about the topic. But before we move ahead and take queries from all, I got 2 small queries for you from my end, if you permit me. One query is that in our OPDs, we get a lot of males who come to us before their marriage, and they talk about having some sort of sexual disorder. Have you, since you're running a clinic in on the vaginismus, do you get any young girls coming to you before marriage that they're having such a problem?
Yes, I did have. And in fact, she came to me after reading my article, which was published in Fertility Sterility. and she was going to get married, and she was very apprehensive regarding all that. And we have some experience in treating women who do not have partners. So in these cases, counseling, explanation, and then use of dilators many times give them confidence to, achieve, go through the experience of sexual intercourse very successfully.
Thank you very much. Thank you very much. Dr. Sonia Malik is around. Ma'am, would you like to say thank you to her and say goodbye?
I would thank her, and I would say that vaginismus is a problem beyond fertility. It means that, you have to actually, they would be assigned to a life of misery if they are not able to perform even after they've had a child. So it goes beyond that, and I'm sure Umesh has brought up such a beautiful part of it. Thank you very much. Dr. Sushma, please, would you like to say something? And Dr. Ajit, before we finally conclude. Dr. Sushma, please unmute yourself. Dr. Sushma, unmute yourself.
A very good evening to you all. I congratulate Dr. Jindal for such a good topic. I think this thing is really ignored most of the time. I think childhood abuse is one of the reasons for many, many children, many girls to have this, because I'm looking after JJ board, and I think I've seen a girl getting pregnant at the age of 13. So many child abused girls are really afraid of having sex. So I think this is one of the important causes. And I think a very nice doctor, a very gentle doctor, a very sweet doctor, and a very accommodating doctor can definitely help such children. I think we have seen so many people. One patient came from Germany. For 8 years, they never had any contact. And they were quite happy otherwise. But once they came to me, then they came to know they never had a real intercourse. So thank you very much, Dr. Jindal. I congratulate you for everything, and very nice topic. Thank you so much for the opportunity.
Well, thank you very much. I'm honored to be here. Rather, I'm the odd person out in this whole gathering. And it is really such an honor to be present and to listen to such erudite presentation from Dr. Umesh Jindal. I just brief comment. I feel very good as a psychiatrist that Dr. Jindal is a trailblazer. She has taken interest in a field which I think it is the gynecologists and obstetricians who can address very competently if they train themselves a little bit into it, Psychiatrists, there will always be a barrier for women to reach them for addressing these kind of problems. No doubt we have enormous experience in dealing with female sexual dysfunctioning, but I can assure you that even among psychiatrists, it is those who are interested in female sexual dysfunctioning that they see these kind of problems, and people come to them. So all I can say, it augurs very well for the suffering silent women who are who don't know where to go, and professionals like Dr. Umesh Jindal can definitely provide them easy access, comfortable access, and competent handling. Thank you very much once again for this beautiful oration, Dr. Umesh Jindal.
Beautiful.
Thank you,
We
Dr.
have 2 minutes to go. May I ask Dr. Sudha Prasad to make the final comments?
I
I'm
was
very
listening.
conscious of the time management.
Yes, I was listening, and Dr. Umesh, it was a wonderful topic you have chosen for oration, that nobody will choose it, rather. I must tell you, and openly we have discussed about it, and you have given the absolutely enlightening points how to manage this vaginismus. And I must tell you, your girls are beautifully managing the time, and nobody is left behind, whether it is a foreign speaker or our Indian.
Certainly.
Yes.
So it's excellent, I must tell you.
Congratulations.
Thank you, chairpersons, Dr. Sudha, Dr. Avasthi. And in fact, it was Dr. Avasthi, when I was, very young, we were together in PGI. I referred one patient to him, and the patient came back after 1 month, and she was all right. And that intrigued me, that how did he do it? So I delved into it. We are facing the problem every day in the infertility clinics. So I went deeper and deeper, and today I'm here sharing my experience here. And I really thank you all for the interest you have shown in the topic. And I wish that you will also help these women who are really suffering, really suffering.
Thank you very much,
Should
Dr.
give you a
Umesh.
good hand.
Thank you very much.
Thank you, Dr. Umesh ma'am, for the enthralling talk. And I thank our chairpersons for moderating the session. Thank you so much, ma'am.
Thank you.
So now we take a short coffee break of 30 minutes. Do visit the exhibition halls and the stalls, and don't forget to take a selfie at the photo booth. We'll be back sharp at 6 p.m. Indian time for the much anticipated panel discussion on dilemma in third-party reproduction. Thank you so much, everyone.
A very good evening to one and all of you. Welcome once again to the first virtual Fertivision extravaganza. I'm Dr. Ashwati, and I'm very excited to introduce the much awaited panel discussion, the INSTA panel discussion on dilemma in third-party reproduction. Let me introduce the moderators to you. I invite Dr. Himanshu and Dr. Kaushal Kadam as the moderators. Dr. Himanshu is the director of Bhavishi Fertility Institute, Ahmedabad, Gujarat, and Dr. Kaushal Kadam is the director, Korean Fertility Clinic, Mumbai, India. And there is an assortment of expert panelists for us here. I will introduce them to you. Dr. Samanti Sankari, consultant, Srishti Fertility Center, Chennai, India. Dr. Rita Bakshi, founder and chairperson, International Fertility Center, New Delhi, India. Dr. Deepak Goenka, director, Institute of Human Reproduction, Guwahati. Dr. Shivani Sachdeva, founder and director, SCI Healthcare, New Delhi. Dr. Samit Shekhar, executive director and embryologist, Kiran Infertility Center, Hyderabad. Dr. Sudhir Aija, co-founder and CEO, Zoe Infertility, Mumbai. Dr. Anita Mani, infertility specialist and laparoscopic surgeon, Gift IVF Center, Cochin. Ms. Radhika Thapar, head and chief vendor, Fertility Law Care, Gurgaon. Welcome all of you panelists, and I hand over to the moderators to start the panel discussion. Himanshu,
good evening, all of you. It's a very nice pleasure for us to be here as a part of INSTAR session in the prestigious Fertivision 2020. First of all, I thank IFS for giving this opportunity to INSTAR, and I would like to justify the topic of dilemma in third-party ART in the coming 60 minutes of discussion. Fortunately, I have a galaxy of people who are stalwarts in this field, and fortunately, we have non-medical people here also who are part of this team, so that because this is becoming more and more legal and complicated subject rather than simple medical practice. So with that, I would like to start with the discussion saying that sperm donation was practiced for many, many years, because the moment we could realize that semen comes out of the body of a male partner, goes into the female partner and produces the pregnancy. And then the practice of sperm donation by various methods was practiced for many years. So first, very simple and basic question, is sperm donation legal in India? Anybody can answer the question. Legal. So Radhika, you can answer whether it is legal in India.
Yes, sir, it is legally permissible in India.
Okay. Now, when it is legally permissible, that question is that the sample should be a quarantine sample. Sudhir, you can, because you are running an ART bank, can you just explain what is a quarantine sample? What do you mean by quarantine sample? Of course, after the COVID times, people, even the lay people have understood what is called quarantine, but it was comparatively a newer word till recent past. So can you say what is a quarantine semen sample?
So basically it is covering the infectious stage where there's a window period. Even if a patient or somebody is tested and if they come, say HIV negative or HBsAg or HCV negative, there is usually a window period. They say it is 3 months minimum. The last ART bill had recommended 6 months of quarantine period. So be sure that you take a semen sample, freeze it, and post that you can use that sample only after 6 months. When you have to retest the same person again to be 100% sure that the patient has not converted into positive infectious.
So, but at the same time, let me ask Dr. Anita Mani, is still a fresh semen sample being used for sperm donation or not?
No, it is not used. Only quarantine sample, which is frozen, is used.
Dr. Bakshi? Please unmute when you speak. Dr. Bakshi, please unmute when you speak.
Sorry. Yeah, if I'm using from a semen bank, definitely a quarantine sample. But if there is a patient who is with me and who is being, repeatedly, suppose I'm doing an IUI and, he's already tested. And then if he gives a fresh sample, then yes, we can use a sample there.
Okay, so the whole idea of quarantine sample is that we want to eliminate the period of incubation for the high risk infectious diseases, and that is what is the basic idea, and that's why the quarantine sample is recommended.
The diseases like HIV and HPSAG,
correct, ma'am,
should be.
And do you repeat the tests for donor every 6 monthly? When you're using the donor repeatedly?
It works like that you test the donor, he's negative, you freeze the sample, wait for 6 months, call the donor again, test him again. If he turns out to be negative, then the sample which was frozen before 6 months is labeled as quarantine. And that's how it has to work. Yes,
sir, I would like to add one point here. This particular concept of quarantine, we should reconsider in the event or in the light of a new development in the detection of the antigens in the HIV. The whole concept of this quarantine came when we were not able to do the testing for antigens for the HIV. Nowadays, we in our institute, we are testing all our patients, all our donors for antigens also, HIV antigens. So when we are testing for HIV antigens, we don't need to quarantine the sample. So
but are you sure about the HCV, VDRL, HBsAg, etc. as well?
Yes, sir, definitely. We are very, very sure about
the antigen test of all of them?
Not all of them. Yes, some of them definitely. HIV we have started. HBsAg antigen we were always doing. HCV we are doing. VDRL we are doing. But because of the development in the science, we have to reconsider about the quarantine aspect. Definitely, it is a matter which we can debate always.
No, I take your point that at the moment where the routine practice is being done, the quarantine is a good idea because it's easy to freeze and thaw recovery is also very good. So that's not a problem. But by chance, we should be open to the scientific development that if by chance we develop some testing methods where the quarantine is not required, we may change our policy.
Yes.
Now the question, Dr. Sankari, I would like you to answer. Is that a couple is there, which is a common story in Indian culture, where a couple approaches us and says that they need sperm donation, and they have a family who is the male partner in that particular couple is fertile, he has children, the couple doesn't mind giving sperm, and both the couples are okay with the sperm donation. Can you do that?
Yeah, I severely will object to this because later on there may be complications, legal complications, and also the person who donated the sperm may come and claim that's his biological child. But in UK, they bring the known donor, like a known couple also for egg donation and sperm donation. But in our country, I think it is not possible.
Kaushal, would you like to say anything?
No, that's it. So basically, that is why in India, we do not advise or recommend taking, a known donor sample. So as per our ART guidelines, we are not allowed to do that. What we are supposed to do is take the semen sample from a sperm bank, and which is from a donor who is anonymous.
Ma'am Rita Bakshi, would you like to say why it is so? Yes, Samit, would you like to say why that guideline says like that?
Which guideline about which part?
A known source of donors.
Yes.
Should not be there. Means the donor should always be anonymous. Why is that?
It is for the precise reason that Dr. Samundi had mentioned, that there can be legal complications later on with the donor claiming rights over the paternity of the child. That is the biggest legal complication that can occur. And apart from that, there are other civil issues also that can crop up.
See, in general, donor foregoes all the rights on donation, whatever donation. Let's say it's an unknown donation, then also the sperm donor gives away the right, egg donor gives away the right. And there is no right on the child which is born through sperm donation or egg donation. The only difference here is that the source is known and the source is unknown. Right claiming is legally not allowed because that's a format which we are following. Radhika, would you like to comment on it?
But there is no particular act as of yet which prohibits this. So unless there is an act, it can always be legally challenged. That is what I believe.
Correct. Radhika?
You're right in a way, sir, but the fact is that no matter the law would say that it's a donation, you can't claim the rights, but till one reaches to that conclusion or knocks the door of the court, the idea is basically as far as how much, in what ways you can crystallize the right of a child. At the end of the day, it is the welfare of the child which is paramount consideration in a matter of child, right? Here, whatever surrogacy or IVF or whatever procedures are happening, a child is born out of it. So courts always want that with the minimum effort, the rights of a child should get crystallized. Now, what happens is in an anonymous donation, you can't identify the donor, or the donor cannot identify the party or the child. So that helps in protecting the child welfare quite a lot, rather than knowing a person and identifying the child. This is the house and this is the child where which is born out of it. So the chances of a known donor making it scenario complex, taking it to a litigation level, and then resolving it through a court, I think the Indian law wants to bypass all and make it a happy thing for both the parties. Your donation is done, your
Uh,
child.
I would like to add a little bit more about it, Radhika.
Yes, sir.
I remember a case. First of all, why sir has asked very specifically, why do we think this such law has been made? I do remember when this guideline came, I think 10 years back in 2010. At that time, there was a word used, family fabric. The fabric, whole idea of a family can go into the dilemma when we use the known donor. Most common request is my elder brother or my younger brother can give the semen sample.
Yes.
And I have come across a couple who has done something like this in another clinic, and they came to me 10 years after for a second child. And the wife was very, very clear. She doesn't want any known donor. I asked them, what happened? First time you took a known donor, and now you are talking about an unknown anonymous donor. And they told her that was the biggest mistake we have done. Now my son has two fathers within the family.
That's what
When
exactly I go for.
exactly this is what we want to avoid. When my son is sick, my brother-in-law is equally worried. He should be worried as an uncle, not as a father. So this type of family fabric disturbs when we take the known donor.
Correct. And that is what, what I try to tell to my patient is that, look, today everything is good. Your relations are good, everything fine. You don't realize, but there are two separate families. And there is means if it's a male partner, he has a female partner, he has his own children, she has her own children. And today you have all good relations. Tomorrow the property difference is there, the wealthiness difference is there, educational qualification difference between his children and your children is there. You have to think of what can happen after 25 years, 30 years, 50 years. And that is where this is definitely a good idea not to have an own donor. Now, in this COVID times, of course, this is the most relevant question, that have you started IVF practice yet? All of you, please, self-egg simulated cycle. Everybody has started practicing self-egg simulated cycle. I have started now.
Yes.
So I think everybody, to best of my knowledge, have started sooner or later, because this COVID, we used to believe that there will be a pre-COVID time and there will be a post-COVID time. But it appears to be that there will not be a post-COVID time. It will be without COVID and with COVID. We will be now staying with COVID, maybe less or more, we don't know, but we are going to stay. So we have to learn to live with it. And that is why everybody has adjusted to that. Not only doctors, even the patients have now adjusted to the fact that COVID is going to last and we have to start. So that's how slowly, of course, the days are not the same as they were. And that is where there is a difference, no doubt. But people are trying to, adjust to what we call as new normal. But then again, so far as the side effect stimulated cycles were concerned, it was much easier because the patient was deciding for himself or herself. So it was easy that it was an informed decision taken by what we call as educated or understanding patient. But when we start stimulating egg donors for egg donation cycles, because we all exhausted our frozen eggs, because it lasted for such a long time that whatever amount of frozen eggs whosoever was having, to best of my knowledge, almost everybody has exhausted their capacity of using frozen eggs. So now if you want to go for donor egg cycles, you have to stimulate the donors. Have you started stimulating the donors as well?
Before that, can I just come in?
Yes.
With regards to the self-stimulated cycles.
Sure. Yes.
So initially, within the strict lockdown that was there for 3 weeks and the subsequent couple of months, patients were very apprehensive because the cases were rising. Now there's a little bit of a different kind of apprehension in patients opting for IVF, is that they are wondering if they become pregnant and the vaccine becomes available in, say, January or February, can they in a pregnant stage take the vaccine? So that's a concern which is still keeping some patients away.
You're right. That is one question mark. And becoming pregnant and taking care of pregnancy is universal for everybody, whether it is a self eggs or donor eggs. That apprehension part is a real important part. I 100% agree, and that's why still, so many patients are not opting for treatment. Even I have heard that a few of them have postponed their natural planning of pregnancies as well. But at the same time, there's a good news also that some of the patients of long-standing infertility during the lockdowns, they conceived naturally as well because of the reduced stress, maybe staying together, maybe some differences, we don't know. And that keeps on happening, but that's something which is good that some of them got results as well. But this apprehension part is certainly there. But my question would like to answer, Kaushal, would you like to answer that? Have you started stimulating the egg donors?
Yes, in fact, we have started stimulating egg donors, of course, taking due precautions. And in fact, what we have done is initially get the COVID testing done for the donor before we start the stimulation, and have one more test done just prior to the egg retrieval. So when we are doing just prior to the trigger. So when we are doing the estradiol, progesterone for the donor, and on the day of the trigger, we repeat the COVID test so that before the egg retrieval, we get the result, and then we are able to proceed with the egg retrieval. Of course, the dilemma still remains that if the donor becomes positive by the time the retrieval is planned, I think we have no choice. But if we get it too late and we have to do the egg retrieval for the donor, we just have to do it. So has anybody else faced similar problems here?
Anybody like you can, because this is a very relevant question. Anybody can comment on this, that what precautions you take, that's the thing, because she has already answered that part.
Yeah,
what
because
additional precaution you are taking if you are stimulating the donors?
Yeah, as Dr. Kaushal mentioned, we do the same thing. We do a test before starting the stimulation and right before the egg pickup. And obviously the mask and the sanitization, everything. But luckily in the last 3 or 4 months, we have not come across any case where a patient has either tested positive before or right before the retrieval. But yes, I have come across few patients who have done cycles with other centers where they did turn up positive right closer to the egg retrieval. And the doctors...
We must be cancelling at least 5 cycles every month on the day of HCG. That is the situation. And they are absolutely asymptomatic patients, except for a few who got symptoms, just as a routine. So Anita, any difference here?
Yeah, we have actually just restarted doing these cycles, and what we are doing is that we are asking them to actually be separated from everyone. Basically, we are providing them
Very important.
quarantined accommodation, so they will not come in touch with anybody from the starting of the injection. So since we have 2 weeks after that, we can safely go on and do the egg retrieval without any problem. So we are not testing them on the day of HCG because they've already been separated from everyone.
Deepak?
Sir, we are quarantining all our donors, and we have made a contract with our self-stimulated patients also. On the day of HCG, we are doing RT-PCR for all our self-stimulated as well as donors. For the self-stimulated cycles, we have written in our contract consent form, if they are positive, cycle will be cancelled, and whatever the drug amounts they have spent, they have to lose all that. So it is better to stay isolated during the stimulation. For the donors also, we have made something like this consent only. We are providing them quarantine facility. And in spite of that, if they become positive, we have told them if they become positive, cycle will be cancelled.
Ma'am,
So,
Samudhi Sankari, ma'am?
If they're found positive just before the egg retrieval, we can go ahead and do the egg retrieval and freeze them. And probably advanced tests like NAT test can be done if the coronavirus is present in the eggs, and then it can be used actually.
I think that will be very, very risky, ma'am.
Sir,
exactly. We do
Dr.
not
Bhaveshi,
know.
I think Dr. Sankari is, different, let me say, in all, because even I will agree with you that we have also cancelled cycles. But seriously speaking, why should we be cancelling cycles? Because we are delivering COVID positive patients. We are not asking anybody naturally to stop a pregnancy. So if a donor does turn positive, or let's say, I'm not even talking about donor, let me say if a patient herself turns positive, then why are we really? I think it is time to look at that.
Please give that answer. Anybody wants to give answer to what Rita Bakshi ma'am is saying? Why are we cancelling cycles?
I would like to
so I 1 minute, I'll just finish on that, sir, because till now we haven't found the viral penetration into, I mean, there are of course controversial reports here and there, but more or less virus has not been found to be penetrating both the egg as well as the sperm, and repeated washing as we are doing, and ICSI procedure and separately culturing embryo does make a difference in as far as COVID is concerned. So I think we are also cancelling, not that I am different in that manner, but I think it is high time that we look into this also, that maybe, when if we can deliver COVID positive patient and not see any vertical transmission even there, then I think it is time to look at this also instead of cancelling cycles rampantly, because there are a lot of people asymptomatic who are coming positive.
Let me say that because we can discuss this more, but I think what the ma'am is saying is right in that way, that we used to, when lockdown was declared, there were only 1,000 cases in the country and no patient actually affected, and still we cancelled the cycle which were ongoing actually, because we did not want any patient to get exposure to hospitals, visits, etc., etc. Now, we know that any procedure done on the patient or any risk involved in surgically, etc., increases the risk of complication to the patient who are COVID positive and increases their possibility of getting severe problems. So that is one reason or valid reason to avoid doing anything in those particular patients. But as the time passes, I don't know, because the patients also will be tired. We also might be tired. We may be more happy. We might be vaccinated. We might be already immunized because of the COVID infection, this, that, and all. Maybe our thinking might change. So let's wait for that time. Have you started the surrogacy cycles as well?
Of course, yes, sir. We have started.
Course, yeah. Now, this was a question which was, I just wondered, anybody can say, well, what is the minimum age for sperm donor and egg donor at the moment recommended?
As per the new,
Sudhir, you can say.
As per the new,
yes, Samit?
As per the new bill that was tabled in Lok Sabha, the ART bill, the sperm donation age is between 21 to 55. And
egg
for the
donation.
oocyte donation, it is between 23 to 35 years.
Yes. So that
That
is
is a bill.
age. Yes,
That is
Radhika.
a bill. That is a bill. Why
Yes.
are we considering the bill till it doesn't become a law? I think as per the guidelines, we must be working right now also. Until it does not become a law, we are not obliged to follow it. So the guidelines age is the recommendation which should be governing right now.
This
But
probably
though
we
the law
discussed.
says that between 23 and 35, but we would
Yes.
prefer to have an egg donor below the age of 30, at least by 31.
Yes, that is a usual thing, ma'am. Today it is possible because our egg donors are paid egg donors. They get married early, they finish their childbearing early, and they are ready to donate at that stage. You know, India is also changing, and the days will change where you will not get egg donors who have finished their family by 30. So fine, that we will have to be flexible as the time goes. The whole idea of keeping the age limit is to have good fertility. You know, that is our voluntary selection, and that was what actually I was coming to. Precautions we have already mentioned that some of you have already started quarantining them from the day you start treatment of that people. What we do is that we do counseling, not provide them quarantine accommodation, but we tell them that if you get infection, you are going to lose whatever you are doing. So it's better that you remain, we all know what are the precautions. So those precautions are already discussed. So I think that is all. But any difference apart from providing them quarantine accommodation or something, or screening them for RT-PCR before starting on day of HCG, in recruitment, stimulation, monitoring of these patients, any differences which you have done in view of this pandemic?
So, if I may.
Yes.
So, apart from what all the other experts on this panel have suggested, we have also started doing, apart from the RT-PCR, the COVID antibody test, which is fairly reliable. And it has been found that a lot of the patients and oocyte donors have already been exposed to the virus, and they are showing the IgG positive. So by doing that, you have a little bit of comfort that this patient has already been exposed to the infection, and the chance of reinfection being very, very rare, you can be a little bit on the safe side by proceeding on those patients.
Yes, I think that's a good move.
But,
It's a good.
Dr. Samit, I have even heard of cases where a few of them, in spite of showing antibodies, have got COVID infection. So I feel that one should be doing the RT-PCR, much closer to egg retrieval, at least for the donor, and much closer to the transfer for the surrogate mothers, and not rely just on the antibody testing.
I completely agree.
Right?
Radhika, you were saying something?
I think what Dr. Samit is saying is also making relevance, and what Dr. Kaushal is saying is also making relevance. How it is making that is because with antibody formation, at least you know that how immune the person has become, or how good the person can cope up with if the infection happens. And the number of days of at least some immunity being building up. And what Dr. Kaushal is saying, that's an extra step that we are taking. At the end of the day, we are these donors and surrogates are also being human beings. So we are seeing them, we are monitoring them, so that there is no lapse in between also if getting an additional test done to see that they are safely, the procedure is done. So I think both the points are relevant.
I agree with Samit also partially, and Kaushal also, because what you are saying, Kaushal, is right that the reinfection rate is much higher than what is claimed to be by literature or even by ICMR, because we see so many people reinfected. But what I have observed is that the reinfected people are the people who are exposed to very high viral loads. Means mostly the health workers, doctors, and people who are working with COVID positives. The normal population, the reinfection rate is comparatively lower. And that is where, what Samit is saying makes sense, that you are at least more reassured as to very less chance of last moment cancellation. No zero, but much lesser chance.
Much lesser.
So,
I would like
what we do one more thing, yes, just a moment. We do one more thing is that we reduce the visits to the hospital. We try to finish everything at one go rather than, stepwise. And we try to take people who we feel are conscious and capable of understanding what COVID is and what precautions they are likely to take, which is over and above what they were doing in the routine times. And even for cell patients, the same. Yes, Deepak, you wanted to say something.
Our anesthetist, usually they also work in, especially in my institute, anesthetists who are working with us, they are also working in the ICU, and they have treated a lot of COVID positive patients. So nowadays they have started asking all the patients who had earlier for COVID positive, they have recently started asking for the PAC, elective PAC, for even for ovum pickup. Earlier we were never doing the elective PAC. The logic is that COVID, post-COVID lung can have a serious complications. So nowadays, electively they are asking, please do PAC for all the past history of COVID positive patients. This is one additional thing we have added recently.
So that's very interesting. Yes, that's very interesting observation that those who have suffered from COVID and recovered and are now willing for treatment, we should be careful that their lungs have actually recovered well, and they are likely to face the anesthesia procedure and pregnancy, of course, safely.
The level of
So that was
antibody also is important. If it is about 10, I think we can easily take them up actually. And we can also do this rapid antigen test also to doubly confirm whether they have the antigen. There is one antigen test also. After RT-PCR, on the day of the egg retrieval, we do the antigen test also.
One more thing, I agree with Kaushal that we have made 2 separate consent forms for the patients. Every patient visiting the hospital signs a consent form that I have voluntarily come to hospital. Tomorrow I turn out to be positive. I will not blame the hospital, because hospital can have doctors who might be infected, staff who might be infected, other patients who might be infected, and we don't know because we are not knowing that somebody is infected or not. So that is not the responsibility of the hospital, just in case you turn out to be COVID positive next day. And the same thing for the any treatment, that this is the time where by chance they turn out to be COVID positive and the procedure is cancelled, as you said, they may have to lose money in between or whatever losses they might have to suffer with the knowledge they are doing it. So normal egg donation, egg donor selection criteria, Samundhi ma'am, would you like to elaborate? Pre-COVID times when we were practicing with ease and comfort, what were the egg donor selection criteria you used to use?
They should be free from any contagious diseases. Of course, all the infections should be ruled out, and they should undergo a genetic counseling if there is any problem in her parents and her grandparents and herself. If there is any, she has any genetically affected child. And mainly these are the things we see. And also we see the AMH sometimes. If the ovarian AFC, if it is not amicable, then we also do the AMH. If it is lesser than 2.5, then we can ask them to, we can cancel that egg donor, because we need at least 7 to 10 eggs when we do the egg donor cycle. And and also whether the history of pregnancy, the previous pregnancy, and whether they had any problems during pregnancy, and the child's health also should be looked into.
Sudhir, want to add something?
No, that's basically less than 30. I don't know many clinics do.
Preferably, yes.
We do take donors who do not even have children at times, especially the educated donors who are keen to donate. So we do undergo intensive testing for them. But yes, we do take donors sometimes when they do not even have children, though the guidelines do indicate that ideally they should have children.
I think pretty much everything has been covered by the previous 2 panelists. But one thing I would like to add is that when we were discussing about known or related semen donors, I think the practice of having a known or a related oocyte donor is much more rampant in clinical practice than semen donors. So we get a lot of patients who bring their own.
Okay, that was my next question going to come. So suppose if that is a situation, what would you do?
I think we have done such cases where, women, they bring their younger sister or their elder sister, and they say that, they want to be my oocyte donor. So
because POF is becoming very common today. Premature ovarian failure or premature ovarian insufficiency or severe poor ovarian reserve is becoming very common. And sometimes the entire family has it, but sometimes the entire family is not having, and the elder or younger sister has finished the childbearing and is willing. And egg donation is little difficult process also compared to sperm donation, and the variety of egg donors, selection availability is not as good as sperm donors so far as the egg donors are concerned. And that is where the difference in this particular, considering sperm donation and egg donation comes up. So Samit, please complete what you were saying.
Also, sir, in India, patients the recipients are very, very concerned about how their child is going to look after birth. So they want the child or the progeny to look as similar to them as possible. So that is why they find it much more convenient and much more reliable to have a known egg donor, especially like a sister or a sibling or a cousin, rather than some unknown donor.
Sir, I would like to highlight a
Yes.
legal case here. So we don't do known donors in our clinic, but I do know of a legal case that had come to us through a friend of mine, where a sister-in-law has filed a case against the family and the doctor clinic and has asked for divorce. Obviously, there will be other reasons, but she also claimed that she was coerced to donate eggs to her brother-in-law. So this was an interesting case.
This happens, that is what we previously also discussed. But see, we cannot go by the rare cases which might happen. That happens in every situation. The moment husband and wife have dispute, they claim that ART clinic did forcibly ART on me. My husband took me to the ART clinic and forcibly forced me to do a donor egg. This is something, they are rampant things and that can come up. What is more important is logically or really. And I differ with Mr. Sudhir that we take donors only who have children, because we never know that lady is going to have pregnancy or not, because infertility is not predicted. And by chance, if she doesn't conceive easily, she feels that because she donated the eggs, now her egg pool is less, this, that, and all. And those situations we really want to avoid. So preferably, I never take a donor who never had a child, except for she never wants a child. So now
I would like to add something,
coming to,
sir.
yes, Kaushal.
Yeah, no, adding on to what Sudhir was saying and about that case, in fact, if at all we do get, a couple who is saying that they would use the elder sister or the younger sister's eggs, I always make it a point to counsel the sister with her husband, and always ask to discuss it within the family, whether everyone is comfortable with the entire thing, have the consent so that we are safe, and then only proceed further, because yes, a person may say yes and may have doubts and may refuse later on. So it's always better that the younger sister or the elder sister discusses within her family and her husband, and only then proceeds with the
Not only
procedure.
that, Kaushal, we need to counsel them about the future things as well, because they are just out of
Absolutely.
emotion. They are making a spontaneous decision which they don't realize that what the implications can be in future as well. So that we need to definitely. Yes, Radhika.
So that is the reason family adoptions have failed. Family adoptions
Correct.
here is a kind of, this the way if you turn it around, Uh, uh, irrespective it's a known donor, sperm donation or a oocyte donation, complications are bound to arise because family nexus in India and family is India is very emotional. So I would never suggest anybody to, adhere to such practices.
I agree with you, Radhika, but so far as
Yeah.
family adoptions are concerned, I know at least 3 to 4 people in very close circle, and they are very happy with the adoption, life going very well. So I don't say that family adoption has completely failed. Maybe there are again instances where it might have caused problems. This we have already discussed. As per the new guideline, the donor has to be ever married and having at least one child, which we already discussed. Now, this is one more provision which is so funny that the donor can, in the new ART guideline, which is still mentioned, you know, in the old guidelines, it was mentioned and we thought that this is a mistake and it will be removed. But this is still there that she can donate only once in her lifetime and not more than 7 eggs can be retrieved from her and remaining eggs should be frozen. Now, where to freeze in her ovary or taking out and freeze it in your lab? I don't know what the meaning of this is. It's really complex. So anybody wants to answer on this as to what do you say? Rita Bakshi, you would like to say?
Yes, sir. I think I agree with you. This is the most hilarious, I should say, what they have put in the bill, because I do think what they mean is probably give only 7 oocytes and freeze the rest outside. But this is absolutely irrelevant. And why should the egg donor also donate only once in her life? I think, I mean, that's probably kind of exploitation, or they are thinking of some other, except the medical part. I mean, that's not what is in the mind when they are saying only once. It's the same thing as in surrogacy. They are saying even donation, they've said only once in a lifetime. So according to me, both are absolutely.
Yes, when it was in the previous guideline, we thought that it will be removed, but it is still there, and it's really not acceptable.
Yeah.
But one more provision is that single donor, one donor can supply only to one intending couples. Now, how is it possible? Nowhere in the world this kind of situation is there. How and why they've done is really not, it's beyond understanding and imagination of anybody, right? So now one more thing is proposed is that there has to be a what is called an ART bank. The normal practice today is that IVF clinics do manage their own sperm donors, egg donors, or surrogate mothers. The advantage is that there is no in-between agency and the cost is less. Not only that, IVF or ART has spreaded in our country, and it is IVF clinics are available in the cities where the population is somewhere around 50,000 to 1 lakh of people as well. Now, if we propose the ART banks and make it compulsory that everything should be sourced, and one more important thing which I'll say in my next slide is that there is no mention of surrogate mother. So ART banks are going to exist, but they are not going to work on surrogacy. So would you like, Sudhir, because you are running an ART bank, I think, so would you like to, are you happy with this?
It's an interesting question for us itself, because I agree with you that the clinics are running an open programs nowadays. It's easier, faster, quicker. But I think the ART bank helps to regulate this process and exploitation of the patients and the clinics by the donors. There will be a central register where you know which donor has donated how many times, how the response would be, what the testings have been done. This kind of history that you will get from the banks will be much more better moderated and information passed. The second thing I think ICMR did good in this information was they made it compulsory, and the present bank has to be run by a MD gynecologist. That was the latest, at least the bill that I had read.
No, but ART bill doesn't say that.
Okay,
because a very nice panel, sir. Just a gentle reminder that we have 10 more minutes, sir.
It says 18 minutes. Okay. No,
Yes,
it's
sir.
41.
10 more minutes, sir.
We are going to finish at 7 or earlier?
7, sir.
Okay. So, okay, let's run quickly to please ART. Radhika, is there any ART law in India at present?
So at the moment, no ART law. We have the guidelines, which have ethical bindings on the doctors.
And that is where we are likely to have this ART law, which is called ART bill, which is presented already in Lok Sabha. Now, what will happen next? After this ART bill, which is already presented in Lok Sabha, what is the next course of action expected? Means, what is the process expected? Radhika, can you tell?
Technically sent to the joint committee for the, that should be our insistence that the way surrogacy was sent for the comments of the stakeholders. And then it will come back with the report to the Lok Sabha, and then the voting will happen. And then it goes to the Rajya Sabha. Rajya Sabha also has the option to send it to the parliamentary joint committee surrogacy was sent to, in both the session, in both the houses, it was sent to committee. So if ART bill is also sent in Rajya Sabha to the ART, to the committee, then again that committee will send a report. Then Rajya Sabha will again review it. And the bill which originates in Lok Sabha, only it can be passed by Lok Sabha. Supposingly Rajya Sabha put some questions to it, it has to send back the bill to Lok Sabha for its voting again or its approval again.
So
it's
that
back
is
and
going
forth.
to be the process, and we expect that anytime now that process likely to be completed. Touching the subject of surrogacy, is gestational surrogacy still legal in India? Because that is a question so many people ask me, because a lot of things are being printed in the media, so people think that surrogacy stopped. Samit, is it legal?
Yes, of course it is
So
legal.
surrogacy is still completely legal, and after that is likely to be the surrogacy bill after the ART bill, and that ART bill and surrogacy bill, when they will be passed, they will be laws. And
Yes.
once they are laws, then we will be abided by the laws. As of now, we are abided by the guidelines. Now, that is where the biggest controversy in the surrogacy is what is called commercial, compensated, and altruistic. Can anybody just quickly elaborate what is that?
Commercial,
Yes, yes.
commercial surrogacy is one in which the surrogate mother gets a compensation as money, and she's an unknown person to the intending parents. Compensated is one where the delivery charges, the maintenance charges during pregnancy, everything is given at the time of delivery. An altruistic is one where a known person who is either a relative or a friend who comes forward to help this couple, intending couple, without any compensation.
But yes, Samit, just before you answer, altruistic surrogacy normally where it is practiced is still given the compensation for the losses and all, whereas the bill which says is that it should not be covering even the expenses or fees or remuneration or cash or kind. Means if a person loses the job or cannot work for some time or whatever it is, the patient or the person cannot be compensated. As per the new bill. Samit, what you want to say?
So, sir, if as all of you are aware that the bill was referred to the Select Committee of Rajya Sabha, and then they tabled the report in February this year to the Rajya Sabha. As per that bill, altruistic surrogacy is in no charges, expenses, fees, remuneration, or monetary incentive can be given. Only medical expenses and prescribed expenses and insurance cover to the surrogate mother or the dependent or her representative. So prescribed expenses, these I think will be prescribed in the rules, that once it becomes an act, then it will be prescribed in the rules. Then we will know what kind of insurance can be provided, whether the insurance can be in the form of any compensation by the commissioning parents or insurance as in general insurance, which is provided by the insurance regulator in India.
So we'll have to wait till the definition comes up. One more thing is, this was there in guideline, which is there even in the bill, that the intended couple must be genetically related to the baby. So embryo donation surrogacy should not be done. At least one partner's genetic material has to be there. And no genetic material can be stored for surrogacy. Now, this is something which is, I don't understand what they want to say. Rita Bakshi, ma'am, would you like to say what does this mean?
Absolutely. I think this is again, if there are extra embryos, I don't know what they mean, because they can always come back after some time for another baby, or,
even a failed cycle.
Pregnancy fails. But what do they mean by saying genetic material can be stored? I mean,
So
this
is really ambiguous. The age of the surrogate mother is 25 to 35 years. Sudhir, would you like to say this is something which is, the age limit, upper limit at least should be more than what 35 is prescribed? What do you say?
Practically, we don't use surrogates beyond 30, 32 years. Medically, they have enough research and the claims have been made that even surrogates above up to 40 to 45 years are good. But I think as clinics and banks, we should be responsible to see to it that we don't want to create any pregnancy complications. So we should avoid and try to keep it below 35.
And the most important, Radhika, it makes it compulsory to have a infertility certificate. That means an intending couple has to be medically certified infertile. Now, whether this is legal,
So
it's such a big trauma to a couple that they go to a medical officer, get a certificate that they are infertile, and then they can go for surrogacy.
yes, sir. So basically, these are first of all, infertility. One is not very comfortable discussing with everyone. Even a patient has to get that extra, this thing to even discuss with the doctor. So this is something that they are, unable to fathom, and the government is trying to control all such things to show that so that the doctors do not get into any kind of malpractices, that they're putting all these kind of clauses in it. But having said that, some people, as you said, they are able to conceive naturally during the lockdown. So if a doctor is giving infertility certificate and tomorrow the patient for some reason is able to conceive,
Yeah,
there will
happens.
be a lot of chaos in
Happens.
that also.
Moreover, the infertility certificate, sir, can be taken to the court of law, and that can become a theory for
Divorce, so many other things. So, Radhika, again, one question for you. Can today, when the surrogacy bill is not still passed, a single person, a male, can be offered surrogacy?
Yes, sir, can be offered surrogacy.
Okay, so everybody says
We
yes.
have to but look on
I
all
think
the
it is only allowed for women, not a single woman, not for a single man.
No, it is allowed, ma'am.
That is as per
allowed.
the bill. Currently, we are allowed to offer surrogacy to singles, right?
Okay, now the so-called best practice altruistic surrogacy, it's considered to be the best practiced. What are the drawbacks of altruistic surrogacy? Would anybody like to say, Anita or Deepak or
Yeah, talking about altruistic, I don't think it is practical for several reasons. Because there is a likelihood that family members might be forced to do altruistic by either their husbands or mother-in-laws, for one. Another thing is that currently surrogacy people are offering only because for the compensation mostly, and it would help them financially and for their livelihood. We would find a big deficiency in surrogate mothers if we go for altruistic surrogacy for that reason. And maybe few more other practical problems.
I
So
fully agree.
today,
And before we
we are
conclude our panel, yes,
So
yes, Deepak, you were saying something.
yeah, just elaborating
Not
what
only
Dr. Anita has told. Today we are listening in the newspaper, we are reading in the newspapers that such and such Bahu was burned for the dowries. So
Yes.
tomorrow we will start reading such and such Bahu was burned because she refused to carry a baby for their daughter.
Yeah.
So these are the real problems. We don't live in a utopian society.
Yeah.
We have to be more practical.
Perfect.
So
Radhika, before we conclude, I would like to your word on penalty clauses, because it's so scary to read the penalty clause part of the bills. Would you like to say something on that?
Sir, exactly. The penalty clauses are not in a put across in a fashion, which could be acceptable to the medical practitioners. Because at the end of the day, I don't know why everything has been started viewing as if the doctors are holding the knife to do a crime. It's not holding the knife to, cure some defect. It's something like, with a criminal this thing. And there is a saving clause in the bill also, that within the 2 years of the passing, we have to challenge. Supposingly, they don't listen to us now, but once it becomes an act, within the 2 years time, whatever objections or whatever practical difficulties that we get, we must report to them so that they have a relook at the bill and can be considered again. So I think, once it becomes a law, we have to be very proactively looking into the flaws which are not workable, and we have to work it out and put across to the people, to the ministry or to the ministry.
Okay, so we are now approaching end of our session. So I would like and request everybody to just make a concluding remark, starting from Deepak. Would you like to give any message?
Third-party reproduction, what we are talking about, is a practical thing. It's the need of the society, and we have to look at this, all the aspect, whatever we have discussed, in a practical solution. And we don't live in, again repeating, we don't live in a utopian society. So let's not expect something very unpractical things. Let's be more practical, which is feasible for all of us. including the patient, including the doctor, including the third party.
Okay, Rita Bakshi, ma'am. Dr. Rita Bakshi, please unmute yourself. Okay, Rita Bakshi, we have probably lost. Anita, would you like to give some concluding remarks?
I think if we are not able to do commercial surrogacy, many couple who are unable to have children will not be able to have children. So it will be a really sad state. And I think that commercial surrogacy should be allowed to continue. Thank you.
Samit?
I think both the bills, the ART bill as well as the surrogacy bill, has been drafted without inviting the comments or with discussion with the relevant stakeholders in detail. Several clauses in both the bills is whereby the government is telling, couples and violating their right to privacy and telling couples how they should be having a baby instead of leaving it to them to decide.
Okay, Sudhir?
I think I agree with what Dr. Samit just mentioned is we need to have open discussions, including all the stakeholders, and that's when the bill should be allowed to be passed. But I guess that's not what's going to happen.
Dr. Sankri?
I think surrogacy should be practiced much as Dr. Anita said. It is a help from one being to another human being. And those who come to help another human being, they come out of a poor socioeconomic group. And whatever compensation they get, they use it to develop their family. We have seen it with our own eyes. They really develop very well with the compensation. But
Rita Bakshi?
Yes, sir. Sorry, I got zoomed out, sir. So, when we went to the Joint Parliamentary Committee, I think the committee also agreed that, this is the need of the hour. So, I think that was very refreshing for us. And we were really looking for a very favorable bill, although the bill has come out nearly in the same way. I think we are also looking for our Indian counterparts to also, be allowed, our OCIs and, the people who have been banned for doing surrogacy right now. And also that, I agree with Dr. Sankari. I think these are here to stay. And I hope they don't make it so difficult that things go underground.
Radhika?
So I would like to say the final word with 2-3 pointers. First of all, altruistic surrogacy, when we are talking about, all I would say is that we have to give respect to the dignity of labor. If we are not paying her any compensation, then it is violative of Article 23, which itself says that you cannot put anyone to labor without giving the due compensation. So I think this bill will fall flat because it will not be able to meet the touchstone of Article 23. Secondly, egg donation does not have any mention in surrogacy bill. I don't know why the government is thinking that the lady who wants to have a child through surrogacy has a problem of womb only, right? People also do not have egg reserves or poor quality of eggs, so that should also be looked into. Thirdly, the egg donors, when we are saying that they should be married and should be having a child completed their family, I believe that basically the health of the donor is very important, and certainly to prevent the exploitation, we can curb down the number of times they are making the donation. But let us or the medical practitioners also make the society have the advantage of the technology, and do not take the whip in a hand to set up the society in a very moralistic way. I think if we are trying to balance yeah, so legal and ethical things should be looked into, and then a bit of autonomy should be given to the patient. That's what I would like to say.
Yeah, exactly.
Kaushal?
That's what, just to sum it up, yes, I agree with all the panelists here today. And the ART bill, I mean, third-party reproduction itself plays a very important role in all ART procedures, anywhere, all over the world. And I think the ART bill really needs some amount of revision, especially where we require clarity regarding egg donation and about they donating just once in their lifetime, and having one child at least of 3 years, I think revision is required there. Also, regarding only 7 oocytes being retrieved is something that is very difficult and needs to be looked into. As far as surrogacy is concerned, yes, definitely, I think all of us here agree that we would want a compensated surrogacy at least to be allowed by our government, and not just altruistic surrogacy, because yes, that calls for exploitation of the surrogate. And also, what we would really want is revision in the sense that couples who already have one child should be allowed. There are a number of cases where there is secondary infertility and they are not able to conceive. So that should also be allowed, and not only those who have one child who is either suffering from autism or some other psychological or physical disorder. And yes, I think the stakeholders' call should be taken into consideration and should be consulted before it really gets passed. All we can do right now is hope for the
Okay,
best from our
Kaushal, thank you
government.
so much, because I see the moderators waiting and for the clock to tick. Thank you all panelists doing a wonderful job. I would say only one thing, that anything, any law or anything is to be made, it has to be progressive. It should take care of today's requirement and the future development, changing mindset of the society, and all the fabrics, all the stakeholder, all the thinkings, all the kinds and everything, and then make the law rather than a very conservative and retrograde kind of situation. Thank you all. Thank you, organizer. Thank you, IFS, for giving us this wonderful opportunity. All the panelists. Thank you so much. We take your leave.
Thank
you, Dr.
you.
Himanshu.
Thank you.
Thank you, Dr. Kaushal. That was a very well moderated, interesting session. We are glad to have had the discussion with all of you.
Thank you.
Thank you.
Thank you.
Thank you.
Good evening once again. Now we are going to have another international academic session that is going to have speakers from the Middle East Society. And I invite the chairpersons for the session. Our chairpersons are Dr. Sunita Chandra, Dr. Maninder Ahuja, and Dr. Lakshmi Srikhande. Dr. Sunita is core fertility specialist, Morpheus Lucknow Fertility Center, Lucknow. Dr. Maninder Ahuja is Director, Ahuja Hospital Infertility Center, Faridabad. Dr. Lakshmi Srikhande, she is Director, Srikhande Fertility Center, Clinic, Nagpur. Welcome all chairpersons, and I invite Dr. Sunita Chandra to invite Dr. Joni Awad as the first speaker for his talk. Sunita ma'am, over to you. Dr. Sunita Chandra, could you please invite the first speaker?
Definitely. I'm sorry. I'm really sorry. So a very good evening to all of you. And I'm really happy to be here on this second last session of Fertivision. Now I invite Dr. Johnny Awad, Director AUBMC, Haifa Idris Fertility Center, Lebanon. He is Chief Scientific Officer, Middle East Fertility Society. And he is also Consultant Adjunct Faculty, the Massachusetts General Hospital, Boston. He is going to speak on pre-IVF treatment of endometriosis, what, when, and for how long. So Dr. John Awad, the dais is yours. Please go ahead.
Hi, everyone. I'm going to try to share my slide.
You need to minimize this and open your PPT, sir.
Yeah, it says you cannot start screen sharing because other participant is sharing. Okay, good. I think I'm on.
Just
Hi,
introduce slide.
everyone. I'm trying to put myself on a slide mode, but it is not going the right direction.
It's on the top red row, 4th tab, slideshow.
Yeah. Can you see my screen?
We can, sir. We can see your presentation, but it has to be on a slideshow to continue.
Yes, but the slideshow is not working. Let me see.
It's on the top of it.
Right next to the animation tab, sir, on the left-hand side.
Yeah.
Yes, yes. The next to it, yes.
Yeah, it's not responding. I'm going to try to turn it off. I'm going to try to open it again.
Sure.
Great, perfect. I think we're in order. Do you have
We can't
my,
no, we can't see.
slides there?
No, we can't see your slides, sir.
Can you see them?
We can see your screen, sir.
We can't see your slide. I would request you to share again.
Okay, let me do that.
Open your presentation and then share, sir.
Good.
Yes.
Perfect. Please continue.
Yes.
Great.
Yes.
Perfect. I would like to thank the organizers and the chair people for inviting me to this very interesting conference and a very interesting topic in reproductive medicine. Am I all right? Because I cannot see myself, but you can see me, correct?
We can see you, sir. You just
Great.
need to click on the presentation and continue.
Perfect. Perfect. Great. Thank you very much. And so this is endometriosis, I believe, is a very interesting topic in our field as reproductive endocrinologists. And we see lots of it. And oftentimes we are faced with a struggle of what to do when patients come to us with
Sorry, are you moving your slides, sir? Sorry, we can't see your slides moving. Are you moving your slides?
No.
Okay, good. Great. And so this is the typical situation where a young woman, a young couple come to you because of infertility, because of the presence of bilateral endometriomas. Now, everything else is perfectly normal. Semen analysis is good. Tubal patency is established. What to do with this young couple? Do we go about telling them to try to conceive more on a conservative basis? Do we give them medical treatment? Do we treat surgically, or do we advise them to go to ART? I think this is the kind of dilemma we always deal with, especially when we're dealing with stage 2 or 3 endometriosis. And interestingly enough, endometriosis in particular, because it involves surgery, and we as reproductive endocrinologists and surgeons have a weak point for surgery. I think it looks more like a throw a ball in front of a little kid and you're certain this kid will run after it. And this is the itch we get when there's the opportunity to do surgery. Unfortunately, dealing with endometriosis entails very intense risk-benefit analysis. We oftentimes disregard the evidence and disregard, in fact, the physical harm, the financial harm, the emotional harm that our intervention could incur. And before we move on to the pre-IVF treatment of endometriosis, I would like to share with you some basic data, which will be very useful later on. What is the natural clinical course of early stage endometriosis, treated or untreated? This is a high level study back in 1997 in the New England Medical Journal that tells you when these women with early stage endometriosis were randomized into diagnostic laparoscopy and no intervention versus surgical excision of endometriosis, the 36-week cumulative probability of getting pregnant improved from 17% to 30%. So statistics would tell you there's a 70% chance of improved pregnancy. But what is it, this statistics to our patients? In fact, when we counsel our patient, what we need to tell them, the added benefit, the actual benefit of surgery is the observed effect of doing doing the surgery minus doing nothing, the placebo. And that amounts to only 12% chance, additional chance of getting pregnant over 9-month period following laparoscopic surgery. So when you share this kind of information, even though this study have shown statistical significance of our intervention, then the patient is going to tell you an added 10% over the next 6 months may not be enough for me. Is there some other option? Now, when we look at endometriosis stage 3 and 4, things get a bit more complicated. This, unfortunately, we have no high-level evidence studies, but this is one of those studies available by our dear friend Pierre Corsignani from Italy that showed that when you treat advanced stage disease surgically and watch these women expectantly over time, the chance of conception, the cumulative probability of conception is about 50% over the next 36 months, that is 3 years. So over the next 2 years, it's 40%. But when a patient, especially a young patient belonging to the millennial generation, which is different than ours, will tell you time is important to me. What is my cumulative probability of getting pregnant? Over the next 6 months, the answer comes back 12%. And that's only the observed effect that is not the actual benefit, because unfortunately, we have no credible studies that show what is the placebo effect, the effect of watching and doing nothing and getting pregnant at the same time. So this is a case series where all these studies were put together and the number 50 comes back again. However, remember, these case series are limited by the lack of controls. But also, we as surgeons are proud people. We will never publish our paper unless we have positive findings. And we as editors of a journal are unlikely to publish things of disinterest to our readers. That's why we're likely to publish positive results. And because of this reason, the 50% is really an inflated number. But please keep that in mind. So for patients who are counseled properly and are told that a 50% is not point, it is over 36 months, most women will tell you, doctor, do we have something other to offer us? Now, the medical treatment of endometriosis and its impact on the natural clinical outcome has been reviewed by multiple meta-analysis. And we have level 1B evidence to suggest that if we suppress ovulation for 6 months using birth control pills, using GnRH agonists or denazole, there's absolutely no benefit on the natural conception rate. This is another study that showed by Pierre Corsignani that, again, when you treat women surgically for endometriosis, and then you tell the patient, you know what, I've done a great job. However, there are some lesions over the bowel, over ureter. I did not want to expose you to a high risk, but let me give you a GnRH agonist for 6 months to control these remaining lesions. When this practice is done, compared to conservative doing nothing, there was absolutely no benefit. And so when, again, evidence are clear on that medical treatment of endometriosis for the purpose of improving natural conception is not only devoid of any proven benefit, it has adverse effects, financial cost, physical harm, hot flushes, headaches, weight gain, bone loss, depression. On top of that, the number needed to harm is 21. You're depriving a woman out of every 21 women you treat. So that's something that should be abandoned. Now, your patient is convinced that she wants to go for IVF, but her question remains, doctor, would endometriosis untreated affect my clinical outcome with IVF? And there has been several systematic reviews and meta-analysis. Of course, these are mostly observational studies put together in a systematic review that has shown that early disease does not impact the outcome of IVF. This meta-analysis in particular will tell you that advanced stage disease could influence the clinical pregnancy rates, implantation and life implantation rates with IVF, but not live birth rates. But however, knowing that there is an association does not mean cause effect, and treating surgically on the basis of such data, epidemiological data, does not mean that we can restore the fertility of these women to pre-endometriosis level. This is a meta-analysis showing how would a treatment of endometrioma versus no treatment of endometrioma impact the outcome of IVF. It shows that surgical treatment of endometrioma does not appear to improve live birth rates, neither clinical pregnancies, neither miscarriages. All what it did, it increased the cancellation rates as a result of a lower number of oocytes and as a result of lower FSH baseline, that is lower ovarian reserve. So no benefit, all the harm could be there. This is a study that showed all the meta-analysis on the topic that are present so far. And it shows clearly these 5 meta-analysis that looked at the impact of endometriosis over the outcome of IVF, and most of them did not find any correlation, at the exception of 2 meta-analysis that showed specifically that advanced stage disease could, we're not certain, but could influence the outcome. Now, what are the prognostic factors during an IVF cycle in a woman with endometriosis that could affect the outcome? The multivariate analysis have shown that a low ovarian reserve and previous surgery for endometriosis are independent parameters that will affect negatively the outcome of IVF. So whatever we're doing to manage this, try to avoid reducing the ovarian reserve, or influencing or doing a previous surgery. Now, this is where the role of surgery comes into play. Would surgery of endometriosis improve the outcome? And unfortunately, we only have one randomized trial to answer this question that comes from Turkey, and it has shown that treating surgically endometriomas prior to an IVF cycle compared to doing nothing would only increase the dose requirement of gonadotropins, prolong the stimulation of the days of the cycle, would not, and reduce the number of oocytes, but would not improve fertilization, implantation, or clinical pregnancy rates. And the data are clear on that. Even when you look at meta-analysis that included non-randomized trials, you can see how treating an endometrioma versus leaving it intact pre-IVF did not affect live birth rates, neither clinical pregnancies, did not reduce miscarriage rates, did not improve cancellation rates. All what it did, it reduced the ovarian reserve and reduced antral follicle counts. So there's all harm, no benefit. In this study in particular, which is a meta-analysis, it looked particularly at the number of oocytes. And pre-treatment, surgical pre-treatment of endometriomas reduce the number of oocytes by about 1 to 3 following surgical treatment without any improvement in the reproductive pregnancy efficiency parameters. And again, it shows all the harm. This meta-analysis looked at the ovarian reserve post-surgical correction. And it shows that once you treat endometrioma, your AMH will drop by 1 to 2 points. Even when you look at women with a baseline AMH above 3, and you say these women are really have very good reserve, ma'am, you can afford to do that surgery. You drop their AMH by 1 to 2 points. So that 3 could then become a 1, and then you have to have lots of explanations to do to these patients. Now, this is a nice study from out of Turkey that showed that in women who had, on the average, an AMH of 1.78, 6 months post-surgical treatment, that dropped to 0.7. So that really emphasizes the risks on the ovarian reserve. But when they looked at the parameters that affected this drop, they found that particularly the risk factors were treatment of an endometrioma above 5 centimeters or treatment of bilateral disease. So whatever we do, we should stay away from these two risk factors. Again, we reach the point where we've been taught that through medical schools and through our fellowships that medical treatment will only work when you give it pre-IVF. That is, if you downregulate these women for 3 to 6 months with a GRH agonist, you improve the outcome of an IVF. And this is this is a Cochrane database review dating back to 2006 that showed that GRH agonist pre-IVF treatment would improve the clinical outcome by 4-fold. That's impressive. That's really evidence 1A, which is really top level. And based on that meta-analysis, ASRM, ESHRE, and all the others societies have promoted, right, a pre-treatment with the GRH agonist pre-IVF for women with advanced disease. But the problem with these is that we always go for the conclusions and we never look at the way the studies that were included in these meta-analysis. And if we look at these 3 studies and dissect them in order to understand better the value of such a recommendation, we go to the first one. This is the one by Dicker back in 1992. They looked at women with advanced stage disease. They randomized them into 6 months of GRH agonists and then compared them to a control of women who received menotropins alone with no kind of GRH analogs, no antagonists, no analogs, no agonists. And that's totally different than what we do today. And we know that back in the early 90s, late 80s, when the agonist was introduced, the success rate of IVF increased significantly from 5% clinical pregnancy per cycle to 20-25. So we know an agonist has an impact on the outcome. And so that study appears to put the control group at a major disadvantage. And this is shown in the results. So you can see how an improvement of 25 to from 4 to 25% cannot be explained on the basis of the GRH prolonged suppression, but on the basis of an agonist used in any way or in any form. And therefore, this study should really be excluded and cannot be considered for any credible data. This is the second study utilized. Women
I'm
went
sorry
through...
to interrupt. We are running out of time, so if you could find out.
Okay, so then in this study as well, I'm gonna skip then. Okay, we're gonna skip those if you wish, and this is only to tell you that all what we need to do is really to look at these data in details and make sure that they are credible. And in fact, this is the next Cochrane review in 2019 that have shown clearly, putting these studies together, that the merits of long-term GRH agonists for the pre-treatment of endometriosis was really, in fact, uncertain. And I'm going to rush into the take-home messages. And so now, if your patient comes to you with advanced stage disease and she's above 35, then our advice would obviously be go for IVF. Time is not on your side. But if she's a younger woman with a bad ovarian reserve, then again, you would tell her time is not on your side and you would go for assisted reproductive technology. Now, if this woman is young, has a good ovarian reserve, but she's got bilateral endometriomas, previous surgery for IVF, or tubal disease or pelvic disease, then certainly you would avoid surgery and say go for assisted reproductive technologies. Now, the point is, if a woman has no pelvic pain, she's young, she has a good reserve, unilateral endometriomas, she has tubal patency, no previous surgeries, normal male parameters, then this woman has two options. And you would counsel her by telling the couple, I would like to offer you a 50% chance of conceiving after surgery over the next 3 years, or I would offer you the same percentage over the next month with assisted reproductive technology. And I think the patient will not have a difficulty to choose. Thank you very much.
Thank you, Dr. Johnny, for the wonderful, wonderful journey of various surveys of pre-treatment, IVF pre-treatment with endometriosis. And because of shortage of time, we'll be taking all the question answers at the end of session only. And I again thank you for a very, very detailed description of all the IVF, pre-IVF treatments. And our next speaker is none other than Dr. Michelle Abu Abdallah. And as it's a Middle East conference only, and he is the chief consultant of Middle East Fertility Clinic and executive director of the Middle East Fertility Society. And he is reproductive endocrinology, adolescent endocrinology, andrology, and fertility specialist certified from the McGill University, Montreal, Canada. This is to inform all the audience also that he is not feeling well, but he has been kind enough to send his video, and there won't be any questions from him at the end of the session, but the other speakers, of course, will be answering the questions. So please put your questions in the chat box so that we can answer at the end of the session. And over to you, Dr. Michelle. And
Dear colleague at the Indian Fertility Society, I'm pleased and honored to participate with this webinar on behalf of the Middle East Fertility Society. I'll be talking today on how to deal with the poor responders. Learning objectives of the talk. It's to allow the audience to review the evidence from the literature and the various stimulation protocols that are proposed for low responders. And secondly, evaluate the advantages and disadvantages of various strategies for low responders. I have nothing to disclose, and I start with the definition of the low responders. There are no common accepted definition for low responders. However, the criteria may include any or more of a poor ovarian reserve, low number of mature follicles, low peak estradiol level, high gonadotropin dosages, or prolonged days of stimulation, and finally, a prior cancelled cycles due to poor response. The ASHRAE consensus on the poor ovarian response definition. At least two of the three criteria should be met. First, advanced maternal age, that means equal or greater to 40 years, or any other risk factors for poor ovarian response. Secondly, a previous poor ovarian response, that means an outcome of equal or less than 3 oocyte with a conventional stimulation protocol. And thirdly, an abnormal ovarian reserve test, like for example, taking into the account the AFC or AMH. AFC between 5 to 7, AMH less than 0.5 to 1.1. Another definition of response groups from a major US academic private center. The definition for low responders is an outcome of equal or less than 4 metaphase 2 oocytes. If we're talking about normal response, then we're talking about 5 to 19 metaphase 2 oocytes. And if we're talking about higher, we're talking about greater than 20 metaphase 2 oocytes. Regarding the low responders group, the age is ranging between 36.5 and above, plus or minus 4.2 years, and FSH levels of 7, and a BMI of 25.1. Also, estradiol at the time of HG could be accountable. For the low response, a response is considered low when it is less than 300 picogram per ml. Normal, it's between 300 and 600, and high is greater than 600. There are many suggested strategies for poor responders in vitro fertilization. One of the strategies, which is very common, it's increasing the doses of gonadotropin. Secondly, is adding the GnRH agonist flare protocol. Thirdly, adding the GnRH antagonist protocol versus the agonist. And lately, the fourth one is a luteal phase estradiol priming. Also, some groups, they may add growth hormone, they may give androgens as a pre-treatment in preparation, or some, they go to the other extreme, which is a natural cycle in IVF, or finally, a minimal stimulation protocol, which is a trend lately in Europe and other places. How would you improve the probability of pregnancy in poor responders undergoing IVF? Well, going to the literature, the systemic review, and the meta-analysis, that included 22 eligible randomized controlled trials with evidence of poor response. Of course, abstract not published as full manuscript in peer-reviewed journal were excluded from the study. The intervention without significant differences for pregnancy in poor responders, where one is the short GnRH agonist versus the long GnRH agonist protocol. Second is the use of clomiphene citrate, FSH, and antagonist versus the GnRH agonist protocol. Third variation is the GnRH antagonist versus a short GnRH agonist protocol. And the last variation, a short GnRH agonist protocol versus the natural cycle in IVF. Also, in the literature, some they are studying to stop the GnRH agonist protocol versus non-stopping. Stop versus non-stop long agonist protocol. Others used the recombinant versus the urinary FSH. And others have recurred to the conventional insemination versus ICSI. Some studies have shown the use of aromatase inhibitors, transdermal testosterone, acetylcholinesterase inhibitors, and L-arginine. We also, in this package of studies, we've seen 5 studies who added growth hormone to their protocol. And one study, only one study, has made on day 2 an embryo transfer instead of day 3. So all these modalities have shown that increased gonadotropin used in IVF adversely influences the clinical pregnancy and live birth rates. In a large retrospective study, around 800, Lubna Pal Infertility Study 2008, she studied that as much as you increase the doses, as much you have a risk of cycle cancellation. And as much as you increase the doses, your chances for success rate also decreased. The IVF drugs given in high doses may harm the eggs. Well, going from that, there is a study by Alan Handyside presented at ESHRE Annual Meeting 2011. The research in UK from 8 European countries also have shown that larger doses of medication, especially in women older than 35, resulted in a higher proportion of chromosomal abnormalities. This research needs to be extended to mild stimulation regimens and natural IVF cycle. So if you look at this slide, by Handyside also, that the maternal age versus the aneuploidy, and you see the analysis of first and second polar body by RA CGH. You see the group of age between 36 to 33 to 36, the aneuploidy rate, or per aneuploid zygote greater than 2, 20%. Between 37 and 39, 33%. 40 to 42 of age, 57. 43 to 45, 87. That makes a total of approximately 58%, which is really high. So if we want to individualize the control ovarian stimulation in vitro fertilization, if you're predicting a higher response, a suggested protocol with the antagonist and 100 plus 150 IUI FSH, with the objective to minimize ovarian hyperstimulation syndrome. If you're predicting a normal response, but you want to maximize your success, you use the agonist and also 200 units of FSH. If you're predicting a lower response, that means you want to minimize the treatment burden on your patient. You can go for the antagonist and include 300 IU in gonadotropin in FSH. Now going for the choice between antagonist and agonist for the poor responders, what the literature is indicating us? There is a systemic review which was done and a meta-analysis. 12 randomized controlled studies, whereby comparing the agonist control and the GnRH antagonist They have found that they are associated decreased oocyte retrieval, decreased level of estradiol, decreased endometrial thickness. But when it comes to the cancellation rate and the clinical pregnancy rate, there are no changes. Now, if we go to another modality with such luteal estradiol priming for poor responders, a meta-analysis of 8 cohort and randomized controlled studies. So we have a 621 with luteal estradiol primed and 468, the number, for non-LE primed. You see the cancellation rate is 0.6. The clinical pregnancy rate is 1.33 with 95% evidence. No significance vis-a-vis the mature oocyte, nor for zygotes. And then you conclude that increased clinical pregnancy rate may be related principally to a decrease in cancellation rate. Now, using androgens or androgen modulating agent for poor responders in IVF. Also another meta-analysis that was found in 2012 in human reproduction. There were 2 studies using transdermal testosterone, 1 study using DHEA, aromatase inhibitors, 2 studies, recombinant LH, 7 studies, recombinant HCG, 1 study. And the effect of live birth, you see on the transdermal testosterone, it's plus 11%. However, for the rest, there are no changes using all these different ages. So the pre-treatment with DHEA for 12 weeks in poor responders. Also, Young published in Fertility Study 2014, a randomized double-blind placebo-controlled trial. And you see the age is similar, AMH also, oocytes. However, the clinical pregnancy rate percentage, 19 for the DHEA, 25 for the placebo. But the live birth is equal, 12.5 to 12.5. Adding growth hormone to the ovarian stimulation, a meta-analysis of 6 RCTs for a number of 169 patients. So for clinical pregnancy rate, we have a plus 16%, live birth rate plus 17%, and patients reaching embryo transfer 22%. The conclusion, the total number of patients for 169 is relatively small. So we need further and larger randomized controlled studies in order to have or to conclude whether the addition of growth hormone is beneficial or not. For the minimal stimulation protocol, using clomiphene and gonadotropin plus the antagonist, you see that the clomiphene citrate 100 milligrams starting day 3 till day 7. On day 8, we start the stimulation with the gonadotropin. On day 11, we add the antagonist, 1 injection, 0.25 milligram, until maturation, whereby we trigger with HCG 10,000. We retrieve on day 15, and we transfer between day 17 or 18. So for the full stimulation protocol, we use 300 units of FSH plus 150 units of HMG. And also we add the antagonist and we trigger with the HCG 10,000. So the minimal stimulation versus the full stimulation in low responders, that was reported between 2008 and 2009. Well, there is no significance between the age, day 3 FSH, and embryo transfers, clinical pregnancy per cycle or per transfer. So what you see here, that the vials of gonadotropins that they were used for the minimal stimulation, it was 9.7 versus 49.8 in the full stimulation protocol. So we are having 4 times the number of vials, and the results for clinical pregnancy per cycle and the clinical pregnancy per transfer is non-significant. Then you have to question why you are overloading and bombarding the ovary of your patients. So the medication cost difference between minimal and full stimulation in IVF for low responders. And here you can see an idea about the minimal stimulation cost and the full stimulation cost. And go back to the total down, minimal between 1,000 to a full stimulation of 8,000. That is a great burden on the patient. So Holifen, the baby chase studies, they also have their examples on the full stimulation IVF protocol, whereby they start giving doxycycline and then continue doxycycline until day 10 for ovulation tests. Then they add estrase, then estrase and cetrotide, and then they do ultrasound and blood work. They continue with menopur, Gonal-F, clomiphene citrate, dexamethasone, and until day 41. Day 42, they make an egg retrieval, and they give Medrol tetracycline. They add aspirin. Day 44, they add endometrin and Lovenox. So until day 54, you see, they continue with these pills until day 54. So Holifen's IVF protocol involves some 30, some more, some 300 shots, 130 pills, 300 hormone patches over 8 weeks. One patient on the year 2010, she spent nearly $70,000 on fertility treatments and the related expenses. Amazingly. You see the chart of stimulation for the patient. So Figueiredo et al. Published in 2013 a study using clomiphene citrate and gonadotropin with agonists versus the conventional control ovarian hyperstimulation. A meta-analysis of 7 randomized control studies. In both groups, the clinical pregnancy rate was 28 in the CC gonadotropin antagonist versus the control ovarian hyperstimulation, which is 24. The live birth, it's 30 versus 26. Miscarriages, 17 to 21. Endometrial thickness, metaphase 2. Oocytes, they were not significant. In this case, why do patients discontinue fertility treatment? So a review of 22 studies from 8 countries. They say that 39% they postpone. 14 because of physical burden. 14 because of psychological burden. 17 because of relational problems. 13 they reject the treatment, and 15, they have really financial concerns. So there are barriers to mild ovarian stimulation for IVF. The barriers are, first, that the physician and the patients are happier having more eggs. Secondly, the physicians are resistant to change their protocol and trend. Thirdly, also the physicians are afraid of reduce the pregnancy rate, so their mind is somewhere else. And fourth, physicians worry about reported outcome in a very competitive field, and that is a major reason for the practice. So the key point, which is a takeaway message, in the absence of a clearly superior protocol for low responders in vitro fertilization, the use of a cost-effective and patient-friendly protocol, one that decreases the physical, emotional, and financial burden to the patient, is highly preferable. And at the end, I would say the less is the better. Thank you very much for your attention.
Thank you, Dr. Michelle Abu Abdallah, for a wonderful, wonderful description, because you have, after all, summarized the less the better. The more we are doing, the more we are tiring of our patients because of physical, mental, and financial constraints. So better to go the lesser way with the minimal stimulation protocols, and the physician should also learn to do the same. I think with time constraints, I'll stop here only and over to the Lakshmi Shirkhande for the next speaker. Lakshmi, you unmute yourself.
Lakshmi ma'am, please unmute.
Good evening, one and all. It's a pleasure to welcome Dr. Botros Rich to India, though virtually. He is president of Middle East Fertility Society. He is also professor and head reproductive endocrinology and infertility in Department of OBGY, University of South Alabama. Dr. Botros will be speaking on ovarian stimulation for PCOS patients who are undergoing ART. Dr. Botros, the stage is all yours.
Good morning. Good morning, ladies and gentlemen. It's a great honor and pleasure for me to be with you today in this fabulous meeting, the Indian Fertility Society.
Sir, do you mind to switch on your video?
Yes, I am sharing. Let me start. Okay, 1 second.
You need to start your video, sir.
Yeah, start my video. Good evening, ladies and gentlemen. It's an honor and pleasure to be part of the Indian Fertility Society. This meeting, we would have loved it to be in person and to be with you and among you in your very outstanding meeting today. However, we all hope that by next year we'll be all together in one room sharing this meeting together. On behalf of the Middle East Fertility Society and as the president for this year, I would like to thank the Indian Fertility Society and wish it every success in the field of patient service. Today our topic is ovarian stimulation for polycystic ovarian syndrome patients undergoing in vitro fertilization. Let me see. So ovarian stimulation is an integral part, as previously discussed today, and in many parts. However, with polycystic ovarian patients, there is a wide variety of patients that we see. There is the typical patient that's in our mind that has the central obesity, that's the insulin resistance. But none of us have missed those patients who actually are slim, thin, and active, have a high LH to FSH, maybe high androgens, but normal insulin and normal body weight. And these are the patients that hyperstimulate and hyperstimulate severely when stimulated in polycystic ovaries. In two words, polycystic ovaries is a combination of two things: excess androgen, hyperandrogenism, and anovulation or irregularity in ovulation. If we look back in 1992, the NIH has defined the polycystic ovary as the combination of two things, as the combination of anovulation and hyperandrogenism. Both of them are clinical features in the absence of any other, any other disease like Cushing syndrome, like pituitary tumor, like ovarian tumor, and so forth. 10 years later from that, in 2003, both the ASRM and the European Society, the ESHRI and ASRM, met in the Netherlands, and they came up that three components are important. So anovulation or resulting in irregular periods is one, hyperandrogenism is two, and polycystic ovaries is three. The presence of any two of those three constitute today what we know as polycystic ovaries as far as definition is concerned. The ovaries on ultrasound has been widely used in Europe. Of course, it's used in daily practice in the US, but has not been used in the US as part of the definition of the polycystic ovaries. Those ovaries have 12 or more follicles that are less than 10 millimeter in diameter, and the ovarian volume is approximately 10 milliliter in volume as well. What about the metabolic effects? All of us today are very aware. It's been 40 years since the first description of insulin resistance in patients with PCOS that linked the two together. Many years ago, in 1935, when Stein and Levenfeld described it, they discussed the obese women, Hirschhut, and so forth. But nobody ever said that the insulin plays a role until the investigations in the late 70s resulted in this publication and others in Boston that suggested that, that there is a correlation between the serum insulin levels and the androgen levels in obese patients with polycystic ovarian syndrome. Markers like acanthosis nigricans in the back of the neck of this patient, other markers like visceral obesity, which results in increased cardiovascular risk factors, are important for those patients from a metabolic point of view. The weight itself is not a prerequisite. However, there is an element of insulin resistance regardless of weight, but when you put the weight on top of it, there is an increase in the magnitude of the problem. Whereas in type 2 diabetes, there is a decrease in the number of receptors, or there is an abnormality in receptors. In polycystic ovarian syndrome, the receptors are neither decreased in number nor abnormal. As a matter of fact, the receptors are normal, but the cascade of events after the attachment of insulin to receptor is abnormal. So if you look at the left side here, there is the insulin in normal women attaching to receptors, and the phosphorylation is a tyrosine phosphorylation resulting in normal metabolism. Whereas in PCOS, the insulin attaches to its receptor here results in a serine phosphorylation in the presence of excess fatty acids that finally results in excess of androgens that we are all very familiar with in polycystic ovarian patients. This particular ultrasound is close to my heart. It's from my sonographer in London in 1986. Was one of the first, was actually in the Lancet publication, was one of the first descriptions under Dr. Howard Jacobs' group that showed an simple abdominal ultrasound that you can see the pearl necklace appears. This was as far back as 35 years ago. Today, of course, all of us use 3D ultrasound, and you can see the multiple follicles, you can see the peripheral distribution, and you can see also the increase of stroma that is seen in those patients. These all result in an abnormality in the lining. So if you look here, the lining is beautiful, trilaminar, white, black, white, black, white, whereas here there is an increase in hyperplasia and results in malorganization of the lining. And then finally, if left untreated, endometrial cancer is the final outcome. Today, with polycystic ovarian, whereas it could present with many things, we are focusing only on the infertility and how do we manage those with particular relevance to polycystic ovarian syndrome. So when the patients come, just in the way of introduction, and my focus will be only on the PCOS, but just in the way of introduction, our first attempt would be to have weight loss. After weight loss, we try to use either letrozole, which is what we use now as first line, or clomiphene citrate. You can add insulin sensitizers for obvious reasons for those patients, as because those patients are actually obese and sometimes resistant to insulin as well. And then finally, the gonadotropins and laparoscopic ovarian drilling is done in those patients. Very, very briefly, lifestyle has a tremendous impact. 1 year of lifestyle based on exercise, nutrition, education results in a significant improvement in menstrual regularity. I always quote one of my own nurses. I did IVF and she was 380 pounds, and the quality of the oocytes was terrible and the quality of the embryos was terrible, and she failed. 2 years later, she did bariatric surgery. She dropped her weight from 380 to 127, got her periods on her own, and got pregnant on her own. So first life therapy should be drop of weight, and a loss of at 5 or 10% of the body weight results in improvements of reproductive function in as much as 50% of those patients in 6 months. What about clomiphene citrate? Very useful for those group of patients. We use letrozole, we use Femara now as the first line. But I want to say that most of the pregnancies happen within the beginning 3 or 4 cycles. So the 3/4 of those pregnancies happen in this time, and pregnancies are rarely achieved after 6 cycles. So there is no point in going for 10, 15, 20 cycles, as sometimes we see in those patients. What is the side effects? Besides some cramping and blurring of vision, OHSS is rare, multiple pregnancy is rare, but disturbance of the endometrium is very well known. Here you see the normal endometrium with trilaminar appearance in the normal ovulatory patients, white, black, white, as you see here. And there you see an endometrium that is thinned out and that is irregular in appearance. This photo is a courtesy of, this photo is taken from my friend Bob Casper. It was Professor Graham Burton gave it to him, showing him the difference in the uterine vessels that is at the junction of the myometrium and the endometrium in the as a result, that affected the endometrial function. And Dr. Casper was one of the first to suggest of endometrial thinness or endometrial irregularity in women with PCOS taking clomiphene. This is a publication from Dr. Gonen, who was his fellow in 1990, suggesting that the thin endometrium is one of the major impacts of clomiphene citrate in PCOS patients that results in a discrepancy between the ovulation rate and the pregnancy rate in those patients. What if you add metformin? 2 of the well-known prospective randomized trials shows no difference if you take metformin in addition to clomiphene versus if you give clomiphene alone, but a significant difference between if you give clomiphene versus if you use metformin in PCOS patients. And this was a US study. Similarly, in another Dutch study here, published in the British Medical Journal, suggesting the same. No major difference between the addition of metformin to clomid versus placebo to clomid. However, more and more recent meta-analysis here suggests that the addition of metformin in obese polycystic ovarian patients results in an increase in the odds of ovulation and pregnancy rate, whether this was clomiphene or whether this is also HMG. What about aromatase inhibitor? We all remember 15 years ago that the first report suggested abnormalities and so on. This has not been confirmed in any long-term studies, and the Canadian multi-center study of all the IVF centers showed the same. And currently we use a 5 milligram dose for 5 days to trigger ovulation in those patients. And several meta-analyses have shown at least similar pregnancy rate, if not improved pregnancy rate, compared to clomiphene citrate in the aromatase inhibitor patients. I want to move from the regular ovulation induction that I focused on in the last 3 minutes to IVF patients. Here I'm showing you a robotic surgery. You certainly do not need to do any robotic surgery, but doing ovarian drilling for some of the women that had severe ovarian hyperstimulation in previous IVF. I mean that you give them 1 or 2 FSH injections, they do not respond, you increase it slightly, and you have excessive response of 50, 60, 80 follicles. So what do? You end up canceling the cycle. By day 5, 6, 7, you have this huge number. You drop the dose to 75, you get no response. So some of those patients would benefit from ovarian drilling to minimize the ovarian hyperstimulation. What about the IVF patients? Let me take you straight to that part, as this is really, again, my emphasis with you today. For the IVF patients, we have seen a major change. And although I personally was one of the biggest proponents for the agonist protocols, as our center was the kind of helped develop it in the late 80s, from 86 to 1980 to 89, we did multiple studies, all prospective randomized, showing that the agonist was better than the protocols available at that time. And that was for obvious reasons. However, we all deal with 3 groups of patients. We deal with the hyper responders, or PCOS, which I'm covering here, the poor responders, which my friend Michelle Abu Abdallah just covered, and then the regular patients. For the hyper responder, for the PCOS and the poor responder, there is no question that the antagonist is preferable to the agonist. And for one reason here and that reason is prevention of ovarian hyperstimulation syndrome. Why is that? Because every meta-analysis that has been done for the last 2 decades, for 20 years, have shown a much lower incidence of OHSS in the antagonist protocols compared to the agonist protocol. In addition, you of course could use a GnRH to trigger ovulation in the antagonist protocols, whereas you cannot use the GnRH to trigger ovulation because there is no already FSH and LH in the pituitary at that time. Little bit zoom or focus on the agonist protocol. Different doses has been used for the agonist protocol. The first, why agonist? Because the HCG is typically the prime stimulator of vascular endothelial growth factors. There is 4 kinds of VEGF, VEGF A, B, C, and D, and then there is 3 types of receptors, R1, R2, R3, and then here I want to say that the presence of VEGF A, and when it works on the receptor 2, it results to excessive hyperstimulation. Whereas the use of the GnRH, which has results in the production of LH, which has a much shorter half-life compared to HCG, and hence the stimulation part is very short-lived and it goes down. Whereas with HCG, all of us have experienced the excessive long hyperstimulation, and all of us also, when if the patients were pregnant, particularly if they were pregnant with 1 or more, then they were hyperstimulated for a long time. Of course, the GnRH could be used only in the antagonist cycles. It has been around since really 1989, 88. I mean, this is not new to use the GnRH for trigger. However, the main thing is that at that time, the antagonist was not used. So those cycles that were used in association with the GnRH trigger were only the HMG cycles. And then in 94, 95, the antagonist started, but really never took off until the early 2000s. For the early 2000s, people were more comfortable with it, and success rate was similar to the agonist. So forget about saying is it better or not better, assuming it's the same. Assuming it's the same pregnancy rate, you avoid the risk of severe hyperstimulation. If you add freezing to that, you would get very rare chance of OHSS in these patients. Bruce Shapiro have done this study in Las Vegas, published in FERT and STIRT, that he used doses basically of trigger between 1 milligram and 4 milligram. So many people, I mean, we have typically used 2 milligram 36 hours and 2 milligrams 24 hours. We currently use 4 milligram 36 hours, and I think both are equal. The reason for using 2 and 2 is that some of the earlier studies suggested that if you give 2 milligram 36 hours and you check the LH and progesterone the next morning, that is the morning before the day of the egg pickup, you find if you find that the LH is low below 10 and that the progesterone is very low below 2 or 3, then those patients do not do well. I'll come back to that, but that was the reason why giving an additional bolus of 2 milligram of GnRH, like 2 milligram of Lupron, for example, at 24 hours after death. Of course, there was a price. What was the price is a very poor luteal phase, a marked suppression of the luteal phase, very low progesterone and estrogen labs. And from as early as the 2003 in JCEM, you see here when HCG is used for the trigger versus GnRH agonist used for the trigger, the level of steroids, level of progesterone is very, very poor. And this is the comparison of agonist trigger and luteal function in stimulated cycles using 150 units and normal responders that are not supplemented, basically externally. One again of the early meta-analysis 10 years ago showed here that 8 randomized trials with fresh embryo transfer, 3 randomized trials using donor. And if you look carefully at the hyperstimulation rate, this is the hyperstimulation rate, 0 out of 266, 0 out of 170 donors, basically over 400 cases with an agonist trigger, no hyperstim. In comparison with HCG trigger, approximately 7% have hyperstimulation. So again, what is the price for that? Here is the price. That when you use the agonist as a trigger, you did not get hyperstimulation. When you use HCG, you got 7% hyperstimulation, but the live birth rate was decreased by as much as half. Bart Fauser in JCEM again did a study showing different agonists as trigger between Lupron, triptorelin, and so forth, as you can see here, and showing you as the steroids, and showing you a significant decrease of steroids unless you supplement with intramuscular from the day of the egg pickup as well. One of the early fertility and sterility papers compared PCOS versus non-PCOS patients, and you can see here similar number of eggs, similar fertilization, similar maturity in those patients. But then one of the scare was that many of those patients, you cannot get any eggs retrieved in them. And again, remember that I told you that the concern was that the LH and progesterone on the morning before the HCG, after the HCG, I'm sorry, and before the egg pickup. So the HCG says given midnight today. If you check the next morning, the LH and progesterone, if you find that the LH is very low and the progesterone is very low, these are the patients at risk for death. For empty follicle syndrome. However, in a large size, this was actually an abstract in Fert and Sturt, and not, and to my knowledge, not in print as a paper, but it was a big number of cycles, 12,000 cycles, of which more than 100 had empty follicle syndrome. One thing they did whenever this happened after collection of one site, they stopped the retrieval and they scheduled it in 6 hours later, and then finally found an average of 6 to 8 eggs in those situations. So again, it did not necessarily correlate with what we thought to be the correlation, which is a low LH and a low progesterone. It could be helped in some cases, but I want to underline in some cases, if you reschedule the retrieval 6 hours later. However, one of the things that is still could not be conquered is a very poor luteal phase. David Meldrum, a few years ago, suggested that if the addition of 1,500 units of HCG at the time of the egg pickup. So the agonist trigger is given 36 hours. And at the time of the egg pickup, 1,500 units of HCG, it preserves the luteal phase. And you get a very low incidence. So it is not the 7% that you got if you use 10,000 units of HCG, but you actually get a low incidence there. The agonist trigger could be, and poor luteal phase could be helped by 2 ways. If you use intensive luteal phase support, intensive being a high dose of estrogen, high dose of progesterone as well, or if you do a freeze-all technique.
So I'm sorry to interrupt, gentle reminder, we are already 10 minutes late now. So if you could wind up.
I'm really sorry to interrupt.
I'll move to my conclusion. So finally, from Peter Homaidan, showing you that the two ideas worked very well together, either that you use the 1500 units on the day of the egg pickup or you use extensive luteal phase support. In my personal experience, we found that the luteal phase is still compromised, and in many of those patients, they do not do well as far as clinical pregnancy rate. So it's been our practice that if the patient is hyper-responder with high estrogens, then an agonist would be used in the antagonist protocol. The agonist would be used to trigger ovulation, and freeze all embryos would be the situation. This is my final paper here, which was again from Las Vegas, Bruce Shapiro, showing you in a controlled trial, 3 groups, the agonist only, the dual trigger, and the intensive luteal support. When you have the agonist only used to trigger ovulation and no intensive luteal phase support, you have the lowest pregnancy rate and you have the highest miscarriage rate. The LH alone did not work. So in conclusion, ladies and gentlemen, I want to summarize that the practice of IVF in PCOS patients has been completely changed in the last 20 years, has been completely changed because of the availability of 2 things, have been the availability of an antagonist as part of the stimulation protocol and the ability of an agonist trigger. In addition to that, successful, very successful embryo vitrification, blastocyst vitrification that allow you to freeze and to thaw. And this would be our recommendation today for those patients who are polycystic ovarian syndrome with a very high response. I want to thank you for giving me the opportunity to be on your prestigious meeting this evening, and I look forward for many years of our collaboration between the Middle East Fertility Society as well as the Indian Fertility Society. Your prestigious society is very well appreciated in our part of the world, and as this year's president of the MEPS, I would like to extend to you every wish for success, support, not just of your meeting, of your year and activity and life. Thank you.
Thank you so much, Dr. Botros, for your lucid and informative talk. And our delegates are really excited to note that you are one of the editors of the Bible of ART, which every doctor has to read before starting his or her IVF center. And I'm really happy to note so much of interest in your talk, that too on Sunday evening, 8 p.m. So there are a couple of questions from the audience for your talk, and it means that they are still alert and attentive. So with the permission of organizers, in continuity, can I continue with the questions to Dr. Botros?
Yes, ma'am.
Dr. Soumya?
Yes, ma'am.
Yeah, thank you. Yeah. Dr. Botros, now in this freeze all policy, you only said that everyone has shifted from agonist to antagonist. But do you still have some indications where you will have the agonist protocol in PCO? Or you will to totally antagonist protocol for all for the PCO patients?
So really, as far as numbers are concerned, we have moved to an antagonist protocol. But you're absolutely right. There are some patients that when you use the antagonist protocol, you get amazed with poorer quality of eggs compared to the same patient when she was using an agonist protocol previously. So a patient does an agonist protocol, does not succeed, then you normally try to use something different. So use an antagonist protocol and you're amazed by the poorer quality of eggs. And in those patients, we go back to the agonist protocol. We're just a bit more careful with them. Again, what we all share among all of us is that these are challenging patients. You give them 75 units, 0 response, no response. You go up a bit. You go 150, still not much response. You go 225, 300, you find tremendous number of follicles even before you reach follicle maturity. So what we've done with this is many things, including alternative days. So for example, we use 1 day of 150. We find that things aren't moving on. So the next day we go to 200 or 225, and then we go back. So we keep using doses between the two. Picking, for example, a medium dose of 187.5, we used that in the past a lot, but it is not, for some reason, it is not the same. They need a little push to go over and then a little pull back to come down. But definitely the agonist in many times has produced beautiful, beautiful eggs in those patients.
Yeah, I know there are some centers which are die-hard fans of the agonist protocol, but you have rightly mentioned that shift to antagonist, but wherever indicated, you can still use agonist protocol.
Of
Similarly,
course.
yes, yes,
Yeah.
sir. One
Yeah.
more question, Dr. Soumya, for him. In this freeze all era, there are some indications where you can do fresh transfers even in PCOS. So can you please elaborate where we can go ahead and do fresh transfers instead of freeze all
Yeah.
policy? Yes.
Of course. So there are many still advantages, like we're not advocate of 100% freeze all for all patients all times, because there are many situations that we all share that those patients would benefit from a fresh protocol. I tell you one thing, that whenever I have older patients and I have 1 or 2 eggs and so forth, in those patients, we are all still very scared that we go to day 5 or 6 and freeze. And many times, we try to tell them, let's hold the stick in the middle and freeze 2 and put 2. And you find that the ones we've frozen did not make it. And this is despite the pride that everyone has in the vitrification and the blastocyst formation and so forth, which we fully advocate. But no, fresh is definitely good, but fresh would be ideal for the less than the excessive responder that is exploded or that has gone slightly out of control. And they go out of control, they went out of control from all of us if we just go above the limit a little bit more. So if we use those patients who have thousands of picograms of ml of estradiol, those would not be the best patients to have a fresh. But if you, for some reason, have a reasonable number in PCOS patients are those that are between 10 and 15, then you can use. Once you exceed that in terms of number of follicles, it is still our safety net to go for a freeze all in those patients. Because again, if they get pregnant and the ovaries are as big as that, there could be a big price to be paid.
Thank you so much, Dr. Botros. There are still a couple of questions for you because audience want to have more time with the master. But I understand because of the time constraint, if there's still time, I will go ahead with those questions. But I hand over the stage to the organizers.
Yeah, Dr. Soumya, can I ask a question?
Yes, ma'am.
Sunita ma'am,
We
please
have
ask,
10 more
ma'am.
minutes.
So, Dr. Johnny,
Ma'am, you are the chairperson for the next session. I'm so sorry. Ma'am, you're the chairperson.
So, Dr. Sunita, you may ask. You may ask.
Dr.
Go ahead.
Dr. Johnny Award, please unmute yourself. Yeah. So my first question to you is your comments on pregnant trial. Use of oral antagonist in pre-IVF in endometriosis for pre-IVF treatment. You have to say something for this trial, which is still going on.
Oh, let me see if
Oral antagonist for pre-IVF treatment in endometriosis patients.
Pre-IVF, you meant?
Yeah.
Pre-IVF. I'm not aware of any study on that. I think these are still phase 3 studies in general.
Yeah, it's still going on. I just wanted to know your comments on this.
Yeah, you know, we're doing now a randomized trial, registered trial, comparing no treatment versus 3 months of GRH agonists versus 3 months of Vizan, right? Pre-IVF to see the outcome. So this is an ongoing study. But then we did it.
Oral antagonist.
Why not antagonist?
Yeah.
To my mind,
not agonist. This is oral antagonist. It is pregnant trial, which is still going on. Oral antagonist. So I just wanted your comments on this trial.
Yeah, I do not expect to find much results. I don't think there's a difference whether we take antagonists or agonists.
So my second question from the audience is a patient of 37 years with AMH of 2.7, having one endometrium of 2.5 centimeter and another is 5 centimeter, and she is having painful cycles. I mean, she is dysmenorrheic. And she wants to go for IVF. Do you want to go for surgery first and then IVF, or straight away for IVF?
Yeah, in this particular case, I would advise her to try some form of medical suppression. If I can control the pain with medical suppression, I would stay away from surgery. I will leave surgery till the very end. But sometimes surgery is required. I mean, sometimes.
Can I ask one more question, or is okay? Ma'am, you can
Mr.
ask.
Maninder,
You may ask.
Dr. Sudha, Dr.
10 more
Mishal
minutes.
has logged in. I see him who is here. He is here. So I think Dr. Michelle has logged in. Maninder can interaction with him.
Dr. Botros, just wanted one question. You had mentioned something, the doses of Lupred according to the weight of the patient. Can you re-elaborate on them? According to the weight of the patient.
Right, right. Well, actually, the part in the study that I showed earlier on the weight was the HCG to the weight of the patients, but it averaged approximately about 1,400 units or 1,500 units. For the Lupron, again, as summarized in the study I showed by David Meldrum, there has been, for the Lupron in particular, has been anywhere from 1 to 4 milligrams that has been used. Again, I favor the 4 milligram. One of the advantages of the antagonist is that it retains the FSH and LH in the pituitary. So when you use an agonist release, you can release that. It is natural to think that the higher the bolus of the agonist, the higher the release of the FSH and the LH in this situation. So I use now 4 milligram period. I mean, I do not use, so again, 1 milligram, 2 and 4 has been used. I use 4. The only sometimes we use, and we in our center, sometimes we use 2 milligram 36 and 2 milligram 24, and sometimes we use 4 milligram at 36. We found no difference in my hands. I found no difference between the either approaches in those.
Dr. Botros, just 2 quick questions to you. What is your cutoff of BMI where you will just not accept that patient for ART? And in which cases you prescribe cabergoline after your pickup in PCO cases?
So what is AMH?
BMI cutoff.
BMI? No.
Where you will just not accept that patient for ART.
I do not turn the patients down. So again, I live in the now in Texas and previously in Alabama. The average BMI in our area is around 34, 35. This is not the shocking patients. So if I am going to turn down patients because their BMI at 35, as they do in the UK, then unfortunately, I'm going to exclude 70% of my patients before they even start. So I do not exclude. And I understand the limitations of the BMI and so forth. And we advise them to lose weight, and we advise them many things. The bariatric surgery helps, but of course it has to be medically indicated. So this is another issue altogether. You know, it's not like exercise and weight loss. But there is no question that I myself had. I mean, I gave one of my own nurses as an example. We had horrible embryos and we failed the IVF. And then 2-3 years later, she does a gastric sleeve. Her weight went from 380 to 127, and she got normal periods and got pregnant on her own. So it shows you that there is. I'm not arguing about the impact. I'm arguing about the practicalities of it in real life.
If you don't refuse, then what is your starting dose? If you don't refuse,
the starting dose we typically use is we add 75 to whatever would be an overweight person. So and as you know, in the US, we use a typically higher dose, for example, compared to Europe and so on, a little bit. I don't use these much higher doses, significantly higher doses in good responders. So you can say, for example, you can, and this is just an approach, that you can categorize your patients into 3 groups: those with AMH less than 1.2, and those with between 1.2 and 3.4, and those above 3.4. So those that are high, you use 150. Those that are in the middle, you use 225, and those who are very below 1, you use 300. And of course, you can add 75 to those below 1, and you will never get a problem with those patients, or you will very rarely get a problem with those patients. It is those patients in between that are not really, that are 3.5, 4, and sometimes you give them 225 and suddenly find that you have 30, 40 follicles by day 5 of stimulation.
Dr. Botros, have you found any untoward effect of using Lupre directly 4 milligram in lean and thin patient? Suppose BMI only 18, 20. So then also you will use 4 milligram.
Yeah. So you can, if somebody is 18, 20, then definitely you would consider 2 milligram. Yeah. I mean, a BMI 18 to 20.
So
And
you are
so on.
giving 4 milligram together or 2 milligram and then 2 milligram after 12 hours?
Right. I mean, for years I did 2 and 2, and then more recently I'm doing 4. But my partner, I mean, like, is still using 2 and 2. So it is very nice for us to compare. And we really could not find a huge difference between 2 and 2, 36 and 24 hours versus a 4 milligram.
Yeah, so you are giving 4 together, so no need to check LH on the next day. So no need, not worried LH is more or high, less than 15 or more than 40, and no
Right.
worry about empty follicle.
Right.
So you are relaxed.
We don't need to, but again, we run 2 centers. In one centers we check everybody. We check them also to for a variety of reasons. We check them even in the HCG to see that they have taken the HCG, so that we don't get a surprise. And so, but it is certainly not a standard practice. I mean, this is if you want to be, and again, depending on how confident you are that the patient follows instruction and she takes the HCG ticket, and similar for the Lupron, that she took the Lupron on time, and you have a good LH and progesterone for those. It's not a requirement, but it would not hurt if available.
I have a question for Dr. Awad. Dr. Awad?
Yes.
I wanted to ask, sir, what is the role of melatonin in endometriosis? How do you find it? Melatonin, pre-treatment.
I wish I have experience with this. I'm not sure I'm the right answer, the person.
Gynecologist, you talked about Bisant, sir. Gynecologist, how do you find it?
We do not have studies to evaluate its impact pre-IVF, right? Because it has been promoted essentially for pain associated with endometriosis, right? But again, I think we're doing one of those few randomized trials, which is ongoing so far, just to see if there's any benefit. But
Only 1 minute left for the oration. I think we should wind up now.
Thank you. Due to time constraint, thank you, Dr. Jawad. Thank you all the international speakers for such a wonderful talk and discussion. So, and I thank all the chairpersons for moderating so beautifully.
Just a minute. Thank you, organizers, Dr. Sudha Prasad. It's a fantastic conference going on, and thank you on behalf of Maninder and Dr. Sunita. Thank you for giving us the opportunity to chair this session.
Thank you, Chair.
Thank you, Dr. Lakshmi. Thank you, Madam.
All of you, Dr. Malik, Dr. Prasad, all
the pre-conference workshops and the conference, the third day has been doing wonderfully well. And we have to thank the hall coordinators also for managing the time, because that is the most difficult part to do. And I think they have done it successfully. So thank you, whole team.
Thanks to the entire team. Then we will wind down the Middle East session, and then I hand over to Dr. Soumya for the next oration.
Dr. Shall also. Wish him best.
Yeah, they've left. They've all left.
Thank you, Dr. Ashwati.
Thank you.
Now we have the last but the most awaited keynote oration of the day before the grand culmination of the first virtual Global Congress of Indian Fertility Society. I would like to invite our respected chairpersons for the same, Dr. M. Gauri Devi, Dr. Nalini Mahajan, and Dr. Rashmi Bagama. Dr. Gauri Devi is immediate past president of Indian Fertility Society and director of Gauri Hospitals and Bridge IVF New Delhi. Dr. Nalini Mahajan is director Mother and Child Hospital Delhi and president Fertility Preservation Society India. And Dr. Rashmi Baga is professor Obs Gynae in PGI Chandigarh. I request Dr. Gauri Devi ma'am to kindly invite Linda C. Giudice. Over to you, ma'am.
Good evening to all of you, and my hi to Dr. Nalini Mahajan and Dr. Rashmi Baga, who are my co-chairs. It's my proud privilege to introduce Dr. Professor Linda Giudice, who is to talk on is climate change affecting reproductive health and fertility. There are interesting papers coming in, and it is one of the findings was that higher altitude countries have low fertility and higher skill accumulation, and the reverse is what is found in the low latitude countries. So it will be interesting to hear Professor Linda Goodis, who will speak on this subject. Now, to introduce Dr. Linda Goodis, she is the president of International Federation of Fertility Societies, that is IFFS, and she is the chair of International Federation of Gynaeops FIGO, Committee on Reproductive and Developmental Environmental Health. And she's the director of the Center for Research on Origins and Biological Consequences of Human Infertility, and she was the past president of ASRM. So the stage is all yours, Dr. Linda.
Thank you so much. Thank you so much for the kind introduction and also for the invitation to present today on climate change and is the climate crisis affecting reproductive health and fertility. And I'm trying to get myself into, there we go. I have no disclosures. Today, I would like to review climate change and associated conditions that affect human health, the impact of climate change and air pollution on reproductive health, fertility, and pregnancy outcomes. And we'll review some animal studies, population studies, and IVF cohorts, and then touch briefly on advocacy efforts to reverse the climate crisis and air pollution, and how do we advise patients about climate and fertility. Well, just a few basics. I think we're all aware that the climate of a region or a city is its typical or average weather. The Earth's climate is the average of all the world's regional climates. And climate change is a change in the typical or average weather of a region or city or the Earth's climate. And climate change has impacts in terms of warming temperatures, changes in precipitation patterns, increases in the frequency or intensity of extreme weather events, and rising sea levels. And these impacts threaten our health by affecting the food we eat, the water we drink, the air we breathe, and the weather we experience. So climate change affects health, and today we are going to focus more on air pollution and a little bit on extreme heat. And climate change can affect numerous systems throughout the body. And today we will be talking about reproductive compromise and effects on gametes, embryos, pregnancy rates, implantation rates, miscarriage, and pregnancy outcomes. And it would be remiss not to also mention that besides the physical consequences of climate change on health, there are also consequences on mental health and well-being. With climate change, there's an increase of individuals staying indoors. Also, there is mental stress, and there can also be community stress. And populations of concern are typically low-income communities, indigenous peoples, pregnant women and children, and one thing that rarely makes the list but is important is preconception health. Also, older adults, vulnerable populations, those with disabilities or pre-existing or chronic medical conditions. Now, when we talk about climate change, we talk about global warming, but global warming and air pollution are intricately linked. And global warming makes air pollution worse by extending the ozone season, resulting in droughts and storms and fires and smoke. And sources of air pollution contribute to global warming. And these include burning fossil fuels such as coal-fired power plants and gasoline-powered cars and diesel trucks, all of which emit particulate matter 2.5, volatile organic carbons, nitric oxides, and carbon dioxide. And reducing CO2 emissions can reduce these air pollutants and health impacts. So the effects, the mechanisms that underlie air pollution and affecting reproductive compromise include endocrine disruption, especially the polyaromatic hydrocarbons, copper, lead, zinc, and particulate matter from diesel exhaust. They also induce reactive oxygen species, formation of DNA adducts, epigenetic modifications, and abnormal DNA repair. And all of these can result in disruption of normal gene and protein expression and cellular and organ function. So what about fertility effects? There was a study several years ago that in Sao Paulo, in which mice were put in a chamber that had a feed of air from the high traffic freeway nearby, and other mice who were put in a clean air container. And then the investigators looked at live-born reabsorption and fetal deaths. And what they found was in the clean chamber, the number of live-borns was significantly higher than in the polluted chamber. The resorptions were lower, and the implantation rates, implantation failures were lower in the clean group. At the population level, a study from China has demonstrated that in areas that are highly polluted with high ambient exposure to fine particulate matter, that the pregnancy rates and fertility rates are markedly decreased compared to the regions that have much better air quality, that have higher fertility rates. Now, what about the effects of air pollution on spontaneous fertility? In addition to the study that you saw in mice, there are also human studies. And I've chosen this one just to highlight from the Nurses' Health Study published in 2016 by Mahalenga, in which 36,293 nurses were studied. And the hazard ratio for infertility was 1.11 for those living less than 200 meters from major roads. In addition, animal studies show, and there are many of them in this nice review by Carré in 2017, that show that pollutants, air pollutants, increase the risk of germline mutations, decreased sperm production, altered seminiferous tubule morphology, decreased motility, decreased numbers of germ cells, and increased FSH. And this was especially in response to exposure to diesel exhaust. Also, in humans, what we find, and again, many studies, most studies agree that adult male exposures to vehicular traffic, polyaromatic hydrocarbons, sulfur dioxide, nitrogen oxides, PM10, and ozone, diesel exhaust versus non-exposed, result in decreased sperm morphology and motility, increased rates of DNA fragmentation, and increased sex chromosome disomy. There are fewer studies in females, both in animal models as well as in women. Some of these agree upon that there's a decreased number of primordial follicles with diesel exhaust exposure. These are studies in animals with long-term exposure. And in women, it has been noted that those who are occupationally exposed to benzene and other organic solvent exposures experience higher rates of oligomenorrhea. Now, recently, IVF and fertility cohorts are giving insights into associations between environmental toxicants and reproductive potential and outcomes. There's the EARTH study at Harvard, the SMART study in Albany, and the NIH LIFE study. This is the study from Hauser and colleagues looking at an IVF cohort, and they found that the closer residential proximity to major roadways significantly is associated with lower implantation rates and live birth rates after IVF. the percentage of IVF cycles resulting in live births for women living less than 50 meters from major roadways was 33%, but those living more than 400 meters from the major roadways was 46%. Now the question arises, does it matter when in the IVF cycle the exposures occur? And there have been several studies addressing exposure to ambient air pollution during cycles, and these suggest that they do affect outcome. Here you see a typical IVF cycle with the gonadotropin stems portion of it, the ovum pickup, the embryo culture time, embryo transfer, implantation, and then pregnancy. And several of these compounds have been measured. And Legros, for instance, found that nitric oxide and at the time of embryo culture was associated with a lower live birth rate. They found ozone was associated with a decreased live birth rate from embryo transfer to delivery. And particulate matter exposure during embryo culture associated with lower pregnancy rate, but not live birth rate. In addition, another group showed association with lower chance of intrauterine pregnancy if the exposure was during gonadotropin stim. And Zhang and colleagues found that these other contaminants were negatively associated with biochemical and clinical pregnancy rate, with the longer exposures having the higher odds. So basically throughout the IVF cycle, so chronic exposure as opposed to particular times in the cycle. And this is still an area of investigation. Now, what about pregnancy outcomes and air pollution? And this is an interesting study from Mongolia that demonstrated that miscarriage rates track seasonal ambient air pollution levels. So here you see with sulfur dioxide, nitrogen dioxide, carbon monoxide, particulate matter 10, particulate matter 2.5. And as the levels of the air pollutant go down, the miscarriage rate goes down, and these are months of the year. And then as the levels go up, the miscarriage rates go up. In addition, in Africa, there was a study that reported an association between pregnancy loss, so miscarriage less than 20 weeks, and stillbirth as well, and its relation to ambient PM 2.5. This was a longitudinal case control study looking at survey data. And the study design was that patients were self-compared case and control live birth. And here you can see that with each increment, so here's the, in the map of Africa on the left, you see the high density populations, and the data demonstrated that for each increase of 10 micrograms per meter cubed of particulate matter 2.5 was associated with an adjusted odds ratio for loss of 1.122 with miscarriage and stillbirth. In the US, recently, there was a publication in JAMA Network in summer of this past year, demonstrating air pollution or looking at air pollution, preterm birth and miscarriage and stillbirth in a systematic review. There were 1,851 articles identified, 68 of which met inclusion criteria. And importantly, they examined data from nearly 33 million births. 57 of these studies focused on air pollutants, as shown here, and 90% on heat. And they found significant associations of air pollutant and heat exposure with birth outcomes. Particulate matter, or ozone, was associated with increased risk of preterm birth in 79% of the studies and low birth weight in 86%. And positive associations were found across all US geographic regions. The subpopulations at higher risk were women with asthma and minority women, and especially Black women. These findings are remarkable because the studies had, of these nearly 33 million births, had varied study designs, different timing and duration of exposures during gestation, different associated comorbidities, heterogeneity of air pollution components, different methodologies to measure exposures, varied definition of heat, and genetic variability among populations. Now, the question arises, does the exposure to air pollution per trimester determine miscarriage risk? This was a prospective study in which the air pollutants were measured 2 weeks before ovulation in the pregnancy cycle and 2 weeks before pregnancy loss, as well as over the whole pregnancy. And the findings were that ozone and particulate matter 2.5, as well as sulfated compounds, were associated with increased risk of pregnancy loss, and when the exposures were over the whole pregnancy, as opposed to a 2-week interval, suggesting chronic exposures are more critical than particular gestational ages. And finally, at the global level, air pollution and preterm birth have been demonstrated. In 2010, and this is a recent article of 2017, summarizing that in 2010, particulate matter 2.5 associated preterm births were responsible for 2.7 million, or 18% of the total preterm births globally. This is a remarkable number and quite high, and these findings demonstrated the highest risk in China and Southeast Asia, as well as parts of Africa. So with regard to preterm birth, and this I think is more applicable really as we consider what we have observed in humans, is largely epidemiologic data. And so the question for preterm birth is it all about associations, or is there a cause and effect? And here in the US, there was a closure. It was basically a natural experiment when 6 oil-fueled electricity generating plants and 2 coal power plants were retired. And what they found was that the preterm birth rate fell from 7% to 5.1% after plant closures. So the question is, can we change course? We can do this with policy changes, education, networking, one by one, and of course, all of us together. What can we do to change the course of climate change and air pollution? Policy changes are absolutely needed. Removing lead from gasoline, for instance, resulted in lowered blood levels at the population level over time. This was a policy change in the US in the 1970s. This is when the law was passed, lead in gasoline was taken out, and the blood levels of the population went down. Similarly, Scotland's ban on public smoking resulted in a decrease in their preterm birth rate. What can we do to reduce air pollution and reverse the climate crisis beyond policy? We can educate and advocate. The Philippine OBGYN Society has a primer on reproductive and developmental environmental health that talks about climate change as well as environmental chemicals and how to advocate with ministers of health and local governments. FIGO has a whole committee, and I'll talk about that in a moment. My institution, the University of California, San Francisco, has a variety of brochures that can be downloaded from the internet free of charge. And we give these to all of our pregnant patients. And these recommendations are also applicable to those contemplating conception. In addition, IFFS and ASRM and the Medical Society Consortium are all promoting educational activities, and the World Health Organization and UNEP has a report periodically on endocrine disruptors, and so does the American Endocrine Society. So what can we all do to reduce pollution and reverse the climate crisis? We can conserve energy. Walking, biking, carpooling, public transportation as we can, using solar and wind energy, energy efficient appliances, turning off lights, using cleaning products and paints that are environmentally safe, no aerosol sprays, and minimizing consumption. And finally, how can we counsel our patients? To counsel patients to mitigate risks of exposure to air pollution and heat on high pollution days, with reports if there are local air quality index monitors. They have certain ranges, and when they are high pollution days, patients should avoid outdoor activities, close windows, and exercise more than 300 meters from high traffic areas. We didn't talk so much about extreme heat today. There are some data, not with regard to fertility, but with regard to preterm birth, that in combination alone, as well as in combination with high particulate matter, can contribute to preterm birth risk. And of course, again, common sense things to limit outdoor activities to morning or evening, increase fluids, avoid being in the sun for long periods, and access to air conditioning if possible. Our committee at FIGO on reproductive and developmental environmental health has recently issued a climate crisis and health statement, and it talks about the climate crisis and women's health. And we have developed a number of infographics that are downloadable from the FIGO website in several different languages about pregnancy and climate change, preterm birth, low birth weight, stillbirth, and effects on brain development. The latter I did not discuss, but clearly is an important issue. And what we can do, as we mentioned earlier, global reduction in air pollution emissions, steady divestment from fossil fuels, and reducing toxic exposures. So I hope that I have convinced you that healthcare professionals and researchers can advocate and to protect the reproductive health for this and future generations, and to reverse the climate crisis that we are currently in, and will still be there after the COVID crisis passes, hopefully soon. So I want to thank you all for your attention. And as president of the IFFS, I welcome you to attend the World Congress of IFFS in Athens in 2022. Thank you so much.
Dr. Linda, I am Rashmi Bagga. I am working in PGI Chandigarh, and that was an excellent presentation. It draws our attention to an area which we do not focus on. As we all know, globally, the preterm birth rate has not changed over the last so many years, despite decades of our efforts, which have been focused on maintaining cervical length, giving progestogens, taking care of infections. But this area is totally new, and we have to work on this, because whatever we may do, until we take care of the environmental pollution, nothing is going to help us to get down the preterm birth rate. So I'm glad that you have touched on this topic, and we need to do some research and focus on that and see how we can reduce the pollutants and maybe help in this aspect. Thank you very much.
Thank
you, Dr. Linda. It was an outstanding keynote oration, and it is a very very, very in thing about the air pollutants and its effect. Not only that, in India also, the phthalates, there's a lot of work going on, phthalates and the different pesticides, plasticides. So you have really brilliantly explained with referrals and proper papers its effect on fertility, on ovulation, abortions, preterm birth. And I'm sure in the time to come, we will also be able to tackle it. In you know, in India, there are some papers which are coming that it is also responsible for PCOD. There are papers coming on it, and male infertility. And our Punjab is a very good example of that. So I'm sure for the time to come, we will be reading and doing more about it, and the solutions you have explained or you have told us to how to overcome this, that's also very good. So I thank the organizers for giving us an opportunity to chair this session from mine and Dr. Nalini Mahajan and Rashmi Bhagat side, and also congratulate the team for such a brilliant conference. Thank you.
Thank you so much.
Thank you, Dr. Linda, for that captivating talk, especially when the AQ levels are rising. And I thank all the chairpersons for moderating the session. So I invite Dr. Rashmi Sharma for conducting the valedictory now. Thank you, everyone.
Thank you.
Thank you. Thank you so much.
Thank you, Dr. Soumya. Respected seniors and dear friends, so now we have come to the conclusion of a very successful 16th annual Congress of IFS and the first ever global virtual Congress. And indeed, it is a historic occasion for us because despite so much of difficult conditions of COVID pandemic and being, going totally virtual, it has been an outstanding conference and unprecedented situation for us. So first of all, I would like to invite Dr. Sudha Prasad, our President IFS, for her address. Over to you, ma'am.
Thank you, Rashmi. My dear friends, colleagues, delegates, my national faculty and international faculty, and exhibitors, I welcome you all in this first virtual global conference and 16th Fertivision, which has happened, and we have reached slowly, gradually. We have reached to the last day of the session. And in this validatory, I am seeing till the last session, the enthusiasm of the organizing team with their time management was so super that still they are thinking it is very, very difficult to conduct the virtual conference. For 8 hours, you are sitting in front of monitor and making everything perfect. It is quite, it really requires the energy. So you people have done so well. I am really amazed, surprised, and so happy. And you have taken the IFS to a very, very big height. Congratulations to all of you for this. And I should appreciate that more than 5,000 login were there for the 3 days, excluding those 10 workshops went so well. So I really thanks to our organizing team, led by Dr. Umesh Jindal, and she has really did the appreciable work. She has done a wonderful job. Initially, when I took over, we were really thinking in this COVID pandemic, how the things will go. Shall we postpone? Shall we we are not going to do this year, or we should extend? But the way the COVID is going on, I don't think the next year probably also we will be on the virtual phase. It's like this, and now we are quite used to, we are quite experienced, and we feel that it should go very well, and we can talk to our international faculty from all the globes. It can be done. So we are very, very comfortable. Thank you so much for giving us a good virtual conference, and it is a big success. Thank you, team. Thank you, organizing team. And I must tell all my senior IFS colleagues, who all have participated and joined hand with each and every moment is fantastic, I must tell you. Thank you so much.
Thank you so much, ma'am. Thank you for your encouraging words. And I would like to invite, in fact, all the dignitaries. See, being virtual, sometimes we forget the formalities. But then I like to welcome all the dignitaries, Dr. President, Dr. Sudha Prasad. We have already heard our Secretary, Dr. Neena Malhotra, Organizing Chairperson, Dr. Umesh Jindal, and the whole organizing team, Dr. Harinder Kaur Oberoi, Dr. Neeru Thakral, Dr. Swati Verma, Dr. Alok Sharma, and Dr. Vanita Suri, along with our Vice Presidents of IFS, Dr. Pankaj Talwar and Dr. Bharti Dhure Patil, and the Joint Secretaries, Dr. Kunju Green and Dr. Leena Vadhva. I welcome all of you and thank you so much for all your presence today. So now I would request the organizing chairperson of this Congress, Dr. Umesh Jindal, who has been a backbone of this conference, for saying few words. Dr. Umesh, ma'am.
Please unmute yourself.
Unmute, please.
Yeah, thank you, Rashmi. I'm trying to write this speech since morning, and I am a very happy and satisfied person to deliver. But I realize that this is the most difficult part because I don't have enough words to convey my feelings for everyone who has unconditionally helped and supporting us in this mission. The 16th Annual Conference on Indian Fertility Society, Fertivision 2020, which was also the first virtual and global conference, has been a grand success. I wish to convey my sincere gratitude to the past and present executives of Indian Fertility Society to give us the opportunity to organize this conference. Hosting a conference jointly and taking along 4 northern chapters of Chandigarh, Punjab, Haryana, and Himachal Pradesh was a great challenge, but this was very easy and enjoyable because of the accommodating, unconditional, and understanding attitude of all partners. Working on a virtual mode was a totally new experience. We were wading through unknown waters. All this could not have happened without the untiring efforts and guidance of the IFS President, Professor Sudha Prasad, the organizing chairperson, General Secretary, Professor Neena Malhotra, organizing secretary, President-elect Dr. K.D. Nair, Chair Scientific Committee, and my co-organizers, Dr. Neeru Thakral, Dr. Harinder Oberoi, Dr. Swati Verma, and Dr. Alok Sharma. The vision of the organizing committee to divide the whole program into workshops to concentrate on specific themes and main conference, which involved mainly the international faculty, provided to satisfy the quest of knowledge for all. We tried to bring an academic opportunity equivalent to ISHRE and ASRM in India. The pandemic and the virtual platform proved to be a boon for us, and we were fortunate to get an overwhelming response from the world leaders. In addition to the efforts of Dr. Neena, Dr. Sudha, Dr. Nair, I would also put on record the efforts of Dr. Sarabpreet Singh to invite and coordinate international faculty from the embryology stream. I must acknowledge the contribution of other senior members of IFS who also poured in their support to guide us at any difficult situation. It was through the joint efforts we now have a galaxy of star speakers participating in this unique global event. I thank all the international faculty who have participated and brought international academics to India. The international recognition by IFFS, BFS, Middle East Fertility Society, and MSRM, and our Indian societies, ISAR, ACE, INSTAR, ISSRF, which were the fruits of hard work of our past and present executives, was a big morale booster. We organized 10 workshops on 29th November. I wish to thank all the conveners and co-conveners for putting up great effort to set up a very interesting scientific program and setting up a stage for the main conference. To be precise, 13 international and 307 national faculties and MOCs participated in 10 workshops. I extend my sincere gratitude to all the faculty members who contributed to the dissemination of scientific knowledge. The mammoth task of managing all activities, the flawless performance, and execution could not have been possible without a very efficient hall management team who worked tirelessly. Here, I would like to acknowledge the contribution of Dr. Niti Tiwari to coordinate the activities of 5 workshops. I have personally learned many things from her. The clarity of messages and direction to workflow. Dr. Priya Varshney also pitched in and managed 5 afternoon workshops. The main conference was organized from 4th to 6th of December. The day started with oral and paper presentations. Total of 45 oral papers and 75 poster presentations were there. I extend my thanks to all the presenters for their hard work. The quality of papers were really appreciated and by most judges, and they had difficult time in giving the results. The team led by Dr. Geeta Radhakrishnan, and I pay my regards and I really appreciate her efforts, and supported by Dr. Gaurav Majumdar, Dr. Loveleen, Dr. Monica, and Shalini Gender. They had to work against the time and lot of pressure from presenters and the organizing committee to organize all the sessions. The team has come out with flying colors with their efficient management. There were 18 total sessions. I extend my thanks to all the judges who gave us their time and helped to conduct the sessions. The great hall management team managed nearly 200 participants of free communications in all. We had almost 1,000 logins even for free communications, and 1,200 to 2,000 per day in the main conference, and in a total of nearly 4,000 to 5,000 logins. The inauguration was organized virtually. There was a great deal of planning. The hybrid mode was conceived and executed efficiently by Dr. Surveen Bhuman under the guidance of our leaders. Nearly 1,500 delegates watched the inauguration ceremony. I again thank our Honorable Health Minister Shri Harshvardhan Professor Hugh Taylor, President ASRM, and Professor Kamal Bakshi for gracing the occasion. Thank you, Surveen, for a great show. A quiz organized on 29th, 4th, and 5th by Dr. Aswath was a special attraction and was enjoyed by more than 100 participants every day. I congratulate the winners. On behalf of the organizing committee, I extend my thanks to Dr. Aswath, who has mastered the art of quizzing. The main challenge for our main conference was the time management. We had international faculty participating from all over the globe. It was a great task to prepare the scientific program to suit the time zones, then practically to translate it efficiently. I must acknowledge the positive impact of pressure exerted by our seniors in the center, Dr. Sudha, Dr. Nair, Dr. Neena, which really alerted the team and put them in do or die mode. We had our rough moments, but the team spirit never got dampened. I thank you for trusting me. I would fail in my duty if I do not acknowledge the hard work of Dr. Niti, Dr. Neeru, Dr. Swati, and their team for conducting the show so efficiently. I thank all pharma companies, Intas, Sun, Cooper Surgical, Intermedics, Alembic, MCure, Bharat Serum, Abbott, GE, Ultrasounds, Merck, Cipla, Cryobiosystems, Zydus, and if I missed anybody, please excuse me, who have supported us despite the financial constraints imposed by the corona pandemic. I must thank the backbone of the whole exercise are the executive staff at IFS office, Ms. Poonam Kotia, Mr. Santosh Kumar, my office secretary, Mrs. Kulvinder, or lovingly called Kelly, for her untiring work and tolerating all types of pressures, numerous phone calls, and doing a variety of jobs, which perhaps are even difficult to enumerate. The other staff of Jindal IVF, Mrs. Sudha Sethia, Mrs. Dr. Suresh, were always there to help me. I will not thank the team of Jindal IVF and my students who unconditionally did what I told them to do. But I just say that I'm very proud of them and we'll feel very fortunate to have such a good family. If I have to name one person who single-handedly managed the show at the back end is Dr. Manisha Jain in my team. I'm really indebted to her for all her contribution. We have tried to create a real-time conference experience on a digital platform. Nearly 1,000 delegates participated in 10 workshops organized on 29th November and had more than 3,000 logins on all days of main conference. Finally, the beautiful e-platform and flawless technical support by the Conferences International, headed by Mr. Sumit Ghai, has made this virtual conference a pleasure and enjoyable experience for all. The platform was even appreciated by international experts who joined us for the conference. To mention a few members of his team, Ms. Tanvi Sani, who was very efficiently managed all international faculty, some 500 Indian faculty and organizing committee members, her patience and efficiency is evident. Vikas, Shivam, and Atul, who worked at the back end and answered every query and satisfied every problem in login or the smooth flow of the scientific program in all the halls. I may have missed Sumit because I have come in contact with these people, so I know their names, but I congratulate your whole team for taking this conference very efficiently. I applaud Sumit with such a splendid team who worked 24/7 and made this conference happen. I can't thank enough the support by Dr. Sudha, Dr. Nair, and Dr. Neena. I will miss the regular weekly Sunday evenings, which we have been spending together on Zoom for the last so many months. The patience and clear decision making of Dr. Nair and efficiency of Dr. Neena is something to be envious of. Corona had its toll on the organizing committee also, and many other team members and faculty who braved the pandemic and personally defeating it. I also thank my family, my husband, Dr. S.K. Jindal, son Aditya, daughter-in-law Sheetal, daughter Manishi and Rajneesh for supporting, and also my beautiful grandchildren who have tolerated my absence from home and my mood swings. Once again, I thank IFS for giving me and my team the opportunity to organize the Fertivision 2020. I hope everybody this conference proves a landmark and paves the way for many more such conferences. Thank you, everyone.
Thank you so much, ma'am. Thank you so much. Now I humbly invite our dynamic secretary, Dr. Neena Malhotra, for saying a few words.
Yeah, thank you, Rashmi. I'm honest, I'm going to say a few words because it's the fag end of the conference. I just address, I can see Dr. Linda Good is here, President of the IFS, who's logged in till date, Dr. Sudha Prasad, Dr. Umesh Jindal, the Chairman of the Local Organizing Committee, Dr. Kuldeep Jain. I can see Dr. Nair, Dr. Sonia Malik, and Bharti and many seniors who are missed. I think as it said that all good things come to an end, so does this conference. I know it's good to have an end to the journey, but I think it is the journey that matters the most. And I think the journey which began in the first week of August has taken us and has made us wiser, humble. I think as a team, how we work, how we learn is what I have learned. I can't forget the first mail that I shot on the 4th of August to foreign faculty. And I realized it was truly a litmus test to realize where we stand. In the next couple of weeks that I sent my mails to my friends and then networked, I think I realized that there was not a single refusal to say how popular we are as a society and also how well we network. In fact, there was a time when we had to say no because some mails came later and were missed in the pandemic. So truly long live IFS. This is the way I would say. I think Dr. Jindal has already covered everybody. I think there'll be a vote of thanks, but I have no words to thank the leadership in Dr. Sudha, who had so much of trust and faith in all of us. Dr. Nair, truly, I think I have learned so much in this journey from you, how to take quick decisions and the wit and the grit to go forward. That's truly, and I think I don't see it, this is the end. I think it is the new beginning. I think a new beginning for all of us as we go and move in the pandemic. And for me, a new beginning. I think I've begun to work how we can work in a humble way with humble resources, with humble funding, and of course, limited spending. I think that's the way I think, and has given me more humility to work as a team. Thank you so much for giving me this opportunity. Thank you all.
Thank you so much, ma'am. Thank you so much. Now I would like to invite Dr. Sudha Prasad for announcing special appreciation awards for, for greatly contributing in the growth of IFS and in the conference. Ma'am, and I would share my screen alongside.
This is the great opportunity to...
Is my screen shared?
Yeah, please. This is a great opportunity to give the appreciation award. First to Dr. Kuldeep Jain, who has made the flag of IFS very, very high. And he started the first preparatory embryology course, and this was the 8th year. And 104 participants were there. Dr. Kuldeep, we really, as a IFS team, we really appreciate your effort. Please accept this award from us.
Thank you, Dr. Sudha. As a core worker, I don't think I need this appreciation, but thank you very much for your kind words. I will continue to work for IFS, and you people have really put up a great show. So congratulations, Umesh, you have done it. And I think now you are satisfied that, because you said that it is your last opportunity when we were discussing about the about this conference in our meetings. So really wonderful, and thanks Dr. Sudha, Dr. Nina. I think people who have worked tirelessly, they deserve the awards. But thank you very much for your thoughts. So thank you.
Thank you, Dr. Kuldeep. The next award goes to, the appreciation award goes to the person who has really worked tirelessly and making this conference very, very success, is Dr. K.D. Nair, the President-elect of Indian Fertility Society. I remember I had the corona, I was out of the team, and Dr. K.D. Nair, Dr. Neena Malhotra, and Dr. Umesh Jindal and her team used to sit every Sunday from 7 o'clock to 11 o'clock. I really appreciate all your effort has really made the great, great success. We didn't had any experience of doing this virtual conference with the time management with so many foreign faculty, but Nina said rightly, to whom she wrote, everybody replied and accepted the invitation. And I'm grateful Dr. Linda Gullis is here to give the confirmation that we have really worked hard to make this conference a success. Dr. K.D., please accept this award. And
thank you, ma'am. Actually, it has been a landmark conference for IFS. I remember in 2017, I organized a physical conference in Delhi. Now, this time it was a virtual conference. It was a new thing for all of us. And I must congratulate you, Dr. Neena, Dr. Umesh, the way we worked in spite of the pressure, in spite of the differences, we have been able to carry it in a very excellent way. And that is going to reflect on the USP of our society outside. Not a single session lasted beyond time. You see, we were all very worried about it. We had a lot of heated discussion with Dr. Umesh, but in the end, we have been able to manage it. And we could gather the most precise scientific speakers from all over the world. You see, 57 speakers in our conference. Generally, we used to have 20, 25 speakers, international speakers. We have this time 57 speakers, and to manage them, this is just shows our organizing capacity of the society. I am very sure next year onwards, it is going to be a step ahead of this. It will be physical, it may be hybrid, it might be virtual, but we have the basic learning and we'll carry it further. Thank you, ma'am.
Thank you. Thank you so much. So next appreciation I want to give from my core of the heart to my Secretary General, Dr. Neena Malhotra. Initially, she was very harsh about it, that how we will do. But finally, when we sat together and we discussed, and for this first virtual conference, there were so many problems while arranging everything, but yet we have done it. We have done it, a grand success. And really, Neena, you have made the effort 24/7. And finally, we have reached to today's last day of the conference. Thank you so much. Please accept this award.
Thank you much. Thank you, ma'am. I just would want to bring here, ma'am, I forgot to, acknowledge Sarpreet, who was with me at all the Sundays. He was with us. I think he's the one who really helped us with all the brainstorming in faculty. Thank you so much, everybody. Thank you.
Thank you, ma'am.
Thank you so much. So the organizing team, initially, you remember when the midterm meeting was there, that there will be 4 societies will come together, who will be the leader, how it will be going. So it was so much of confusion. But Dr. Umesh Jindal, you have really made it, and you have taken, I may be harsh or little upset how the thing will go, because I was seeing from far off, of course, from the Delhi, that people are little relaxed and things are not coming up. But for the time management, you have really shown that your team is the excellent team to keep the time. And I'm so happy that everybody at the end, including our national faculty and the international faculty, are so happy with the time management, because I remember when I got the message that Indian conferences, yeah, it is always delayed. So it will be too difficult to reach to Indian conferences. And some comment came something like this. It was very, very upsetting. This was the reason I thought I should speak to Umesh. And finally, Dr. Umesh, you have shown that you are the leader and you can do the very good conference. It may be last, but why it is last, I cannot understand. You can do more and more conferences like this. Please accept this appreciation award, please.
I thank from the core of heart the kind words you have said. And at this juncture, I must thank my great grand institution of PGI Chandigarh, who has imbibed this punctuality in us. So I think this is how you grow up with an institute and how you do it all your life. Thank you, PGI, for this day, which I'm there.
Thank you so much. I was also your colleague in PGI for some time only. I remember. Thank you. So the appreciation award goes to this certificate to all your colleagues who all have joined hands for conducting this conference. Dr. Neeru Thukral, Dr. Harinder Kaur Oberoi, Dr. Swati Verma, and Dr. Alok Sharma. Please accept this certificate of appreciation. You have made the great effort to make this conference successful.
Thank you very much, ma'am. Thanks a lot.
Thank you so much.
Also, a special appreciation from the side of the organizing committee to Dr. Geeta Radhakrishnan for her tireless efforts, and special applause for Dr. Manisha Jain, as Dr. Umesh Jindal had already told that she has worked so tirelessly during the conference preparations. So now coming to the prize distribution for best paper and poster and quiz competitions. As IFS, in the IFS, we are always about, promoting research, and IFS as a society is always focused on how to improve research quality in our country. So before announcing these prizes, I would fail if we do not thank the Free Communications Committee, especially under the guidance of Dr. Geeta Radhakrishnan, Dr. Lavleen Sodhi, Dr. Gaurav Majumdar, Dr. Monica Verma, and Dr. Shalini Gendar, who have done a fantastic job in analyzing all the abstracts and, seamlessly doing the free communication sense. Thank you so much, ma'am. Thank you, everyone, from the core of our heart. So now, announcing the prizes. So this is the prize for Dr. Kuldeep Jain Best Clinical Paper Award under less than 40 years category, which goes to Dr. Janani S. And on her work on best, better, or equal, comparing the production of oocyte yield by AMH and AFC in women with discordant ovarian reserve tests. Congratulations, Dr. Janani. The next award, Dr. Kuldeep Jain Best Embryology Paper under less than 40 category, goes to Dr. Apeksha Shahu on her work on calcium ionophore for artificial oocyte activation in surgically retrieved sperm sample in a case of male factor infertility. Congratulations, Dr. Apeksha.
Are they here?
The next award, Best Clinical Paper.
Rashmi, are they here?
We sent them a link, ma'am. They must be here. Apeksha is here. Apeksha, I can see if you can unmute yourself.
Yeah. Good evening, everyone. Good evening, ma'am. Good evening, sir. That was a wonderful conference, and thank you. I will thank you, thank everyone, thank my team.
Congratulations. Yeah.
Dr. Janani is also here. Dr. Janani, congratulations, congrats.
Yeah, thank you, ma'am. Thank you so much.
The paper was really good. I had also heard that paper. It was really good, nice research work.
Yes, thank you, ma'am. Thank you so much.
Congratulations. Yes.
So, so the next award for best clinical paper in more than 40 category goes to Dr. Anita R for her work on the role of intrauterine ABCD-TM on clinical pregnancy rate in patients with recurrent implantation failure. Congratulations, yes. Dr. Anita. Congratulations.
Congratulations.
Yeah, I am Vasanti Parnivel. I am the author and Dr. Anita is my co-author.
Oh, okay.
That's fine.
Yes, some confusion in the name. I had been informing them, the team. That's fine. I'm co-author.
Okay. We will change this.
Correct that. Dr. Vasanti, we will definitely correct that.
Yes, sure. Thank you so much. Thank you.
Next award for best embryology paper under more than 40 years category is presented to Dr. Sandhya Kumari MV on her work on modified pentoxifylline is superior to pentoxifylline in enhancing sperm motility and fertilizing ability. Congratulations, Dr. Sandhya.
Thank you, ma'am. Thank you to everyone. Especially thanks to organizer for giving me an opportunity to present this. And I thank my guide, Dr. Guru Prasad Kaltur, who has given me an guidance. And because of him, I am able to achieve this. And once again, thank you to the organizer. Thank you, ma'am.
Congratulations.
Okay, congratulations. So the next award for the best poster under less than 40 years category, Dr. Brigadier R.K. Sharma Award, is presented to Dr. Sindhuri T.R. on her work on comparison of fertilization rate and embryo quality between microfluidic sperm sorter and density gradient centrifugation semen preparations in patients with DFI of more than 25%. Congratulations, Dr. Sindhuri. Congrats from. So the next award, Brigade 40 years, is presented to Dr. Sunita on a work for infertile women for thin endometrium. Congratulations, Dr. Sunita.
Thank you so much. Thank you, Indian Fertility Society. Thank you so much. Thank you.
Congratulations. Congratulations. Dr. Mangala Telang Best Original Research Paper is presented to Dr. Ratna Boli Bhattacharya for her work on transdermal testosterone versus oral dehydroepistrone pre-treatment in improving IVF outcomes in diminished ovarian reserve patients, Poseidon Group 3 and Group 4, a randomized controlled trial. Congratulations, Dr. Ratna Boli.
Thank you so much, ma'am. Thank you. It feels really great to receive this award on this podium. And a special thanks to my mentor, Dr. K.D. Nair, sir, for inspiring me, for making me believe that I could do this. Thank you so much, sir, and to Dr. B.N. Chakravarti, sir, for inculcating this knack for research and academics. Thank you so much. Thank you, everyone.
It was a brilliant paper. It was brilliant.
Thank you, ma'am. Thank you once again.
Congratulations, Dr. Ratna Boli. The next prize, Dr. Sonia Malik, Best Clinical Fellow. First in the exit exam goes to Dr. Vasudha Gupta. Dr. Vasudha Gupta, Fellow from Sir Gangaram Hospital. Congratulations, Dr. Vasudha.
She around?
Thank you, ma'am.
Oh, congratulations.
Thank you, ma'am. Thank you so much, ma'am.
Congrats. So Dr. Sonia Malik's second Best Clinical IFS Fellow is actually a tie. So it is presented to two fellows this year, Dr. Pooja Unial and Dr. Ritika Gupta. Congrats, Dr. Pooja and Dr. Ritika. Congratulations.
Thank you, ma'am. Thank you so much, ma'am.
Ritika.
Congratulations from all of us at IFS.
I would really like to thank the IFS Society, the organizer of Fertivision, and my mentor, Dr. Abha Majumdar, and a special thank to Dr. Shweta Mittal for being always there for me. And I'm really, really, very thankful to all of them. Thank you, ma'am.
Congratulations, dear.
Congratulations.
And from me also, I'm here.
Yes. Yes.
Yes, ma'am. Yes, it's Dr. Sonia Malik Prize, ma'am. Actually, you should have announced, but
No.
the paucity of time, we are going ahead like this, ma'am. So this year, Dr. Abha Majumdar's best published original research paper would be presented most probably in the midterm meeting because of some problems with the website of the journal. We could not analyze the best research paper this year, so that would be presented within few months. So now coming to the debate prizes, the first prize in the debate goes to Dr. Soumya Prasad. These are special prizes being given by INTAS this year, and they would be getting a Kindle.
Wow.
So Dr. Soumya Prasad is awarded first prize in early versus late fetal reduction. Congratulations, Dr. Soumya.
Thank you
and
so
the
much.
second prize is awarded.
Thank you, Dr. Surveen, ma'am, for giving me this opportunity. Thank you so much.
Congratulations.
So the second prize.
It's all your hard work, both of you.
Thank you, ma'am.
Shweta Gupta.
Shweta Gupta from Dr. K.D. Nair's unit, awarded second prize in the debate, and she will also be awarded a Kindle from the INTAS company. So these are special awards this year.
Thank you. I would like to thank Dr. K.D. sir, Dr. Sudha ma'am, and Dr. Surveen ma'am for giving this opportunity to me. And I think this will encourage us to grow academically more stronger. Thank you, everyone. Thank you.
Don't keep on reading Kindle. Okay?
Yes, thank you.
Both of you were very good. It was difficult to decide.
Thank you, ma'am.
So now coming to the prizes for the quiz. So we had 5 prizes every day for 3 days. But before that, we have to thank Dr. Ashwath and Dr. Bharti Joshi for such Dr. Bharti Joshi for conducting it so well. So on 29th November, the first prize in the quiz goes to Dr. Deepa Taleta. Congratulations, Dr. Deepa. And the second prize on 29th November goes to Dr. Charu. Congratulations, Dr. Charu. These certificates would be couriered to you very soon. The third prize on 29th November in the quiz goes to Dr. Bhavani Shekhar. Congratulations, Dr. Bhavani. The fourth prize, that is the consolation prize on 29th November, goes to Dr. Kubera. Congratulations, Dr. Kubera. The fifth prize goes to Dr. Neela Mali on 29th November. Congratulations, Dr. Neela Mali. On 4th of December, the first The third prize goes to Dr. Vani on 4th of December for quiz competitions. Many congratulations, Dr. Vani. The consolation prizes goes to Dr. Charulata Chatterjee and Dr. Y. Annapurna Bhavya on 4th of December. Congratulations. Then for 5th of December, the first prize goes to Dr. Divya Lakshmi in quiz competition. Congratulations, Dr. Divya. The second prize goes to Dr. Chandana Bhatt. Many congratulations, Dr. Bhatt. The third prize, again, on 5th of December goes to Dr. Y. Annapurna Bhavya.
Wow.
Many congratulations, Dr. Bhavya. The fourth and the fifth prize goes to Dr. Parul and Dr. Astha. So these quiz competition prizes, they have got cash prizes. The first prize is 10,000. The second prize is 5,000. The third prize is 3,000, and the consolation prizes is 1,000 rupees each. So congratulations to all the winners of the quiz competition.
Just a correction, Rashmi. First prize is 10,000, second 7,000, and third 5,000.
Okay, okay, that's great, ma'am. So Dr. Bhavya now is double rich.
Thank you so much, ma'am. It was a well-organized quiz and we had a lot of fun.
Great, great. Thank you. So now some appreciation prizes from the side of the whole organizing team and the central committee. It is for their tireless work during the conduction of this workshop. So we would like to appreciate Dr. Aswati Kumaran, Dr. Anupam Gupta, thank you. Dr. Gaurav Kant, thank you so much, Dr. Gaurav. Dr. Harmeet Grover, Dr. Jasneet Kaur. All these appreciation is from everybody at the IFS for your work and contribution. Dr. Manisha Jain, a special thanks from the whole organizing team. Dr. Nidhi Sharma, Dr. Neeti Tiwari, Dr. Panchampreet Kaur, Dr. Reema Goyal, Dr. Ridham Ahuja, Dr. Sarabjit Singh, Dr. Soumya Prasad, Dr. Sheetal Jindal, Dr. Venu Kadian, Dr. Bharti Sharma, Dr. Manishi Mittal, Dr. Monica Verma, Dr. Ritika Bajaj, Dr. Shalini Gendar, Dr. Shanujit Sodhi, Dr. Shikha Sardana, Dr. Sukriti Bansal, special thank yous, Dr. Bharti Joshi, Dr. Bhavna Puri, Dr. Mohita Gupta, Dr. Astha Chakravarti, Dr. Deepika Gupta, Dr. Geetika Sharma, Dr. Priya Vashne, Dr. Sangeeta Khattar, Dr. Tanya Chawla, Dr. Jyotsna, Dr. Shifali Agnihotri, Dr. Shifali Vadwani, Dr. Yogita Dogra. Thank you so much. So it involves efforts of so many people for conducting the halls, for quiz, for free communication. Thank you so much for everyone at the IFS. And a very special thanks goes to Mr. Sumit Ghai and his whole team of Conferences International for so flawlessly conducting the virtual conference. Mr. Sumit, your team has been fantastic.
Rashmi, there is also an appreciation for Dr. Sarpreet Singh. There is a certificate which I think we have not missed in the list, which had to come before. So Dr. Umesh can announce this right away, madam.
Yeah.
No, it is. So I don't think we have it here, yes, but there is a certificate for Dr. Sarpreet Singh which has been missed. So we would just acknowledge Dr. Sarpreet Singh also here for his.
It was there.
No, it's Sarabjit Singh.
Sarabjit, not Sarpreet.
Everybody confuses, so it's Sarabpreet Singh.
Sarabpreet, there is.
Congratulations, Sarabpreet. He was the.
He was really
all
the
the
backbone
Sundays.
of the entire team. And I think he deserves a big round of applause and an appreciation certificate.
Yes, yes.
Thank you, ma'am. Thank you. I'm grateful.
And yes, we will fail if we don't appreciate Mr. Santosh Kumar, the secretary in IFS office, Ms. Puram Kotia in the IFS office for their tireless work, and Ms. Kulvinda Kaur. Thank you so much. Thank you so much. And of course, we cannot, we cannot appreciate enough all the pharma sponsors who have so much, helped us in conduction of the conference. Thank you so much, Cryobiosystem, Abbott, GE, Jackson-Pal, Sun Pharma, Bharat Serum, Zydus, Cipla, FEG, Emcure, Intas, Ferring, Merck, Intermedics, Mankind, and Cooper Surgical. Thank you so much. Thanks from the bottom of our hearts. And now I would like to invite Dr. Neeru Thakral for vote of thanks.
Thank you, Dr. Rashmi. Good evening, everyone, respected dignitary and all dear friends. It's my honor to thank everyone being a local organizing secretary of this conference. First of all, I'm thankful to the past and present IFS executive for keeping faith in us and giving us this opportunity to organize this Fertivision 2020. My sincere gratitude to our President, Professor Dr. Sudha Prasad ma'am, Dr. K.D. Nair sir, Dr. Neena Malhotra for their excellent guidance and inspiration to organize this mega event. My heartiest congratulations and best wishes to all award recipient and quiz winner. My special thanks to Dr. Umesh Jindal ma'am for her excellent leadership quality, affectionate attitude and dedication to make this conference a grand success. I shall like to express my sincere thanks to all esteemed national as well as international faculty, president and chairs of various society for disseminating their knowledge and experience to all of us. I express my special thanks to all the mentor, convener and co-convener of all the super hit workshops with appreciable scientific program. I thank from bottom of my heart to all the delegates for participating in large number and making it a rich environment for all of us. I must thank hall management team, coordinator of all the hall, Rhythm, Rima, Nidhi, Neeti, Ashwati, Astha, Swati, everyone. My heartiest thanks to all pharma company, Abbott, Intas, Ferring, Sun, Cipla, MCure, everyone Dr. Rashmi has mentioned, even though they come forward in this pandemic with this financial constraint also. I express my gratitude to the conference international team, Sumit, Tanvi, Atul, all, and our head office staff, Poonam and Satish, for working day and night, for picking all the call. If somebody is not logging, we just message them and just immediately they log in the everyone. Now I thanks a lot from my Haryana team member, Dr. Sarvjit, Shalu, Dr. Ritu, Rima, Priya, Dr. Renu, and whole the team of executive of my Haryana. And on behalf of Dr. Harinder, I thank Dr. Sarvjit, Sukriti, Dr. Monica, Jasmine, and everyone. Thank you and thank you very much. And I must thank Dr. Sonia Malik ma'am also, to wonderful mentor for organizing our workshops.
There were so many workshops. I'm not the only one.
All the mentor, all the convener, all co-convener, everyone for organizing. Thank you very much.
Thank you so much for making the conference. This was the first experience, but we did it finally. There was lots of confusion how to do, but we did it. And thanks to all pharma companies and our event manager. He has got lots of banging. Finally, at the last moment, he was running that I have to do right now, and you did the best, Sumit. Thank you so much.
Sumit, show your face, please, and
please
participate. Let's take a picture.
Sumit, can you show your face at least to everyone?
Aaj to dikha do.
Videos on.
And your team also.
And your team also.
Tanvi. Acha, hello. Anisha and Tanvi.
Where is Tanvi?
Oh, thank you so much.
Thank you very much.
I think let's ask everybody to open their videos and we can have a last pick of all together. Shweta, Soumya, Apeksha, Vasudha. I can see some more names.
Seeing you after
Ritika Gupta.
We can have a group photograph, everyone video on for the valedictory.
Why is light?
From the audience.
Chaplin, please switch on. Chaplin is there.
Let me know.
Soumya.
I'm there, ma'am. I'm there.
Soumya, on kar.
On है मैम मेरा.
Soumya is the only one who's got the background. Fertivision background.
Hello, Dr. Jayant. Oh, good, nice to
Hi,
join.
Dr.
Thank you
Jayant.
so much for joining.
Thank you, ma'am. Thank you.
Oh, he's such a great person.
He's such an inspiration.
Really. Always.
Ready?
So kind.
Yes.
Have a thumbs up like this.
Cheese.
We have a thumbs up from
Yes.
Oh, Harinder has come. One more with Harinder. One more with Harinder.
I see some Vasudha who is not switched on. Ask her also to.
Vasudha, Apeksha.
Vasudha. There are two missing.
There's another screen also, na? There's one more screen.
Yeah. We'll do both the screens.
You're doing the thumbs up.
Yeah.
Okay.
Taken, thank you. Taken.
Thank you.
Thank you.
Second page. Second page.
See?
Okay, done.
Done?
Yeah, I would request everyone to stand for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you.
Thank you, everyone.
Thank you so much. Thank you so much for
Hello. Thank
joining
you.
us in validity.
Thank you.
Thank you.
IFS, thank you. Thank you very much.
Thank you.
अब जो फर्स्ट लीव करेगा उसको प्राइज कौन लीव कर रहा है?
Three cheers to IFS. Dr. Sudha ji, three cheers to IFS.
Yes, we all did it. We all
Three
did
cheers
it.
to IFS. Hip hip.
Hip hip hooray!
Great.
Good one.
Same
Very
time
good
of
one.
our executive 9 started 9 to 10 from last 3 months.
चलो.
So relax today, Dr. Umesh.
Dr. Umesh, अभी नींद अभी सो जाओ. बैठे बैठे 10 घंटा पहली 9 महीने के बाद I think after an year's time we sat like a conference sitting at one place.
One place. I know. It's a...
We actually attended all the sessions.
All the sessions.
Attended all the sessions.
And what a big basic difference because Dr. Sudha, Dr. Umesh, Dr. Neeru and Dr. Neena and Dr. KD were there at that time. All the time.
Thank you.
Sorry, we're not serving you dinner, so it's a little unusual. We've done everything unusual. But sorry, I think we should have a dinner sometime together to celebrate.
Yes.
Pray that we all can get together. Because I think without a black label, we'll just say cheers.
सुमित ने अरेंज नहीं किया. सुमित ने
नीना ने अरेंज ही नहीं करा.
क्या मैम? सॉरी इसलिए sorry.
नहीं,
no drinks and no food.
नीना ने habitat book किया हुआ है.
मैंने book किया हुआ है मैम. I've already paid the advance. So you decide the day. The advance is already there. The habitat booking is already there.
It's in the accounts.
We've got a credit note from them. So whichever days.
Nina, this calls for Moria, not Habitat. Come on.
Oh, fine. Then
good. Yes, we can.
Well, for that we have to take permission from the treasurer. Serene has to give us the permission. She's the treasurer.
We need sponsors.
No, Serene is going to sponsor. Let's give us the heads up for that.
Treasurer, we have to catch treasurer now.
Treasurer's there. She's going to give us permission and we'll go.
Yeah, definitely. Let's go.
Yeah.
Post-COVID, but.
Yes,
yeah, post-COVID, but yes. Not now.
Yes.
Thank you so much.
Thank you so much.